Well, good rainy morning, everyone. On behalf of the Canadian Pressure Injury Advisory Panel, we would like to welcome you to our second Pressure Injury Summit, hosted here live in the beautiful city of Ottawa. We would like to thank you for sharing your time with us, both in person and, of course, online, as we explore insightful topics throughout the day. My name is Joshua Morleo, and as what Troy has mentioned, I'm the president of the Canadian Pressure Injury Advisory Panel and also currently practices as advanced practice nurse for wound endostomy care at the Salvation Army Toronto Grace Health Center, a complex continuing care and rehab facility in the heart of downtown Toronto. Recently, I had the privilege of working with an interprofessional team to look and to conduct a point prevalence study, which enabled the organization to understand the extensive needs of pressure injuries across our organization. And it also enabled us to focus on key strategies that will allow us to enhance the quality of our care. I think a lot of our clinicians and healthcare providers that can resonate and share the same sentiment with me when I say that regardless of where you are practicing at in the healthcare sector, the need for pressure injury care is on the rise. Therefore, there is at this time that pressure injury prevention is of utmost importance. So last year's summit was monumental, as it provided us an opportunity for the panel to identify and also validate the gaps in pressure injury prevention and management across our Canadian nation. Now, CPIAP was grateful to partner with both the University Health Network as well as Nurses Specialized in Wound Ostomy Continence Canada for this pilot event. We had about 300 attendees at this time, and we were so delighted with that, online and also in person. And we were fortunate to have about 9 industry partners to carry out this event. Now, I just want to highlight some of the key learnings from our esteemed speakers on that previous summit. So first up, we have Pam Hubley. She set the stage by reinforcing the importance of prevention and how this can address the burden of care. She also highlighted the value of an interprofessional approach in ensuring that holistic care needs is provided to all our Canadian patients. Dr. Lee Chapman, our Federal Chief Nursing Officer of Canada, reminded us of the current global crisis of nursing retention and shared the nursing retention toolkit as a national strategy for organizations to adopt and to help our nursing teams. I mean, it is really important for us to acknowledge that the frontline nurses are there at the point of care 24/7. And I'm not just saying this because I am a nurse myself, but nurses play a crucial role in the adoption as well as the sustainability of practices related to pressure injury prevention. Dr. Chester Ho, our great colleague, labeled pressure injuries a silent pandemic. And I love when he advocated the need for systemic change that looks into a carrot stick approaches, which I personally love the stick approach, to foster a culture of accountability. I think a little bit of a larger stick to start making things serious is what we really need across the nation to address pressure injuries. Now, Dr. Sharon Gavison, who I'm fortunate to share this stage with today, and our president-elect, inspired us to reflect on the purpose of this summit and also why CPIP was established in the first place, highlighting the lived experience of persons with pressure injuries. Dr. Gabison informed us and reinforced how vital it is to listen and partner with persons with lived experience as we influence the healthcare system in generating tangible solutions. Dr. Kevin Wu, who I'm always honored to continue to work alongside with, has shed the spotlight on complex continuing care settings as a sector and environment where pressure injuries are highly prevalent. And this is because of the multiple comorbidities and high frailty of patients on this area, and where nursing care demand is on the rise. James Hanradi also echoed that Dr. Wu's perspective and reinforced that nursing workload is an important aspect that needs attention, and this can influence the quality of care by patients that can impact pressure injury development, while on the other end of the spectrum also affect the nurse's well-being. Now, one of the most powerful moments of last year's summit was having Luz Adriel, who we are honored to have today, this morning, because she has shared her experience of pressure injury firsthand, who shared her inspiring story of resilience. She also educated each and every attendee of the impact of pressure injuries to the person's quality of life. And lastly, we had Dr. Craven, Dr. Craven shared an ideal care pathway for patients with pressure injuries receiving surgical intervention, but she reinforced a simple yet crucial aspect of daily skin checks as a means to reduce incidence and severity of pressure injuries among the spinal cord injury population. Now, the key learnings from our presenters and the interactive discussions with the summit attendees highlighted important calls to action which affects sectors of government, healthcare organizations, and other stakeholders. This also provided CPIAP a roadmap to work on over the next term. Now, CPIAP would like to thank Mr. John of Open City for here. Thank you, sir. And as you can see, you can also scan the QR code in the screen here to download the summit proceedings. He was the one that's instrumental to providing us the summit proceedings, and also with today's summit, he will also capture some of the essence of what we are going to be learning about. Now, we have listened and we have learned from our first summit, and we have worked more things to take it to the next level in the second CPIP summit. So our hope is that today's summit will shift mindsets, transform our culture to ensure that we support practice excellence in pressure injury prevention and management. And at this time, I would like to pass it over to my colleague, Dr. Sharon Gabison.
So good morning, everyone. My name is Sharon Gabison, and I'm the president-elect of the Canadian Pressure Injury Advisory Panel. I'm a physical therapist by training. I'm also an assistant professor in the Department of Physical Therapy at the University of Toronto and an affiliate scientist in pressure injury and home care research at the Kite Research Institute at the University Health Network. I'm very pleased to be here today in the beautiful city of Ottawa on the heels of Stop Pressure Injury Day, also known as Worldwide Pressure Injury Prevention Day. And I believe our collective attendance, both in person and online, speak to the commitment that we all have to shifting our mindset and transforming culture to support practice excellence and stop pressure injuries. And I'd like to open our session today with a territorial land acknowledgement. So we wish to acknowledge that the land on which we gather is a traditional unceded territory of the Anishinaabe people. CPIAP and NSWAC work and operate on the traditional homeland of the many diverse First Nations, Métis, and Inuit people whose ancestors walked this land before us, and those persons who we share this great land with today. What I'd like to do now is just review how our day is going to unfold. So you'll soon be hearing welcoming remarks from the Honorable Natalia Kusendova-Bashta, the Ontario Minister of Long-Term Care. We're then going to hear from Dr. Sandra Young, the Executive Director, Standards and Education Health Standards Organization. Dr. Joyce Black will be providing our keynote presentation from the National Pressure Injury Advisory Panel. Joshua Moralejo will then guide us on CPIAP's journey from the past to the present and the future. And at 10:30, we will have a networking break with our industry exhibitors, and posters are on display just outside of this room. And just for your information, washrooms are located outside of this room, I think to the back, kind of at the perimeter. So you just kind of need to go back there. And there's wheelchair accessible washrooms as well. We'll then hear from Mr. Bob Brown, who will share his story with us, and we'll hear from Unity Health, who will speak about evidence to action, a journey in pressure injury prevention. You will then hear from myself and Dr. Chester Ho on the National Pressure Injury Recommendations to support policy change. We'll break for lunch at about 12:50, where you will have an opportunity to network, visit our industry exhibitors and posters while enjoying lunch. When we return from lunch, you'll hear from Christine Hagner, clinical nurse specialist in wound ostomy continence from Vancouver Coastal Health, who will speak to a blueprint for pressure injury data collection to action. We'll then have an interactive session on the use of technology in pressure injury prevention and assessment with myself and Joshua. And we'll hear from Dr. Kimberly LeBlanc, president of the Canadian Nurses Association, who will speak to the shifting the culture around pressure injury prevention and management and long-term care. And have another networking break with industry exhibitors, followed by a panel debate, Are Pressure Injuries Avoidable? And we'll conclude the day with reflections and next steps. So we'd like to also take the opportunity to highlight the e-posters that are out in front of our room, in this room. And I'd also like to take this opportunity. So these are our e-posters. They're just right outside the room. And I'd also like to take this opportunity to thank our industry partners who are identified here, and also Woundpedia and NSWAC. Okay, so at this time, what I'd like to do is open the session with opening remarks from the Honorable Natalia Kusendova Bashta, the Ontario Minister of Long-Term Care.
Hello, everyone. Today, we bring awareness to the importance of prevention and treatment of pressure injuries, also known as ulcers or bed sores. On any given day, 1 in 4 Canadians are affected by these injuries, which can greatly impact a person's quality of life. These injuries are different as they are typically on a bony area where the wound causes a reduction or lack of blood flow, causing tissue and skin to break down, making the healing process very slow, painful, and often difficult to manage. While these injuries do affect ordinary Ontarians, long-term care residents are especially susceptible. Which is why earlier this week I announced our government is investing $3.74 million to expand the delivery of skin and wound care training programs for up to 1,100 long-term care staff. Having more RNs, more RPNs, and more PSWs trained in skin and wound care will help bring more world-class care to our residents. And I am so grateful to our partners like NSWAC and Wounds Canada for delivering these vital programs. On Pressure Injury Prevention Day, I want to thank all healthcare workers trained in the specialty for the vital care and education you provide. Your work helps patients and residents lead fulfilling lives, and for that, we are very grateful. Thank you.
Okay, at this time, I would like to introduce Dr. Sandra Young, the Executive Director, Standards and Education from Health Standards Organization, who will give us opening remarks. Sandra Young is an innovative healthcare leader with 35 years of experience in advanced practice nursing, senior leadership, patient safety, quality improvement, and project management, research, education, policy, and regulation. As Executive Director, Standards and Education at Health Standards Organization, she drives evidence-informed strategies for standards development, integration, education, and the Q-Mentum program with a focus on reliable safety practices and integrated people-centered care. With a proven track record in strategic leadership, quality improvement, and policy development, she has held senior roles across multiple sectors, elevating healthcare excellence. Sandra was a first graduate of a nurse practitioner program in Western Canada and has practiced in advanced practice nursing in both Canada and the United States in fetal, neonatal, and pediatric intensive care and community-based follow-up care for mothers and babies for the first 23 years of her career. Sandra has served as the Chief Professional Practice Officer for the College of Registered Nurses of Alberta and the Standards and Practice Director for Respite, Supportive Long-Term Care, Mental Health, Palliative, and Hospice Care across 2 provinces with aged care. She holds extensive experience in improving patient flow and patient experience across sites and sectors, especially during the pandemic focused on emergency care. Sandra also led the clinical project management of a 189-bed pandemic response unit constructed and commissioned within 16 weeks.
Good morning. Whenever I hear that introduction, I just feel very old. It's really a pleasure to be here this morning, and thank you so much for the invitation. Thank you, Kathy, for inviting HSO and Accreditation Canada. And I'm really pleased to have the opportunity to open your day. I'm wishing you the best and most productive day. But I'd like to talk to you about how committed HSO and Accreditation Canada is to optimizing skin integrity and our real focus on putting patient safety first. As our CEO, Leslie Thompson, speaks to, if you have the opportunity to read her recent paper, Quality 5.0, it really speaks to putting patient safety back on the front burner, especially when we're all recovering and progressing after the pandemic. Okay, so we'll talk a little bit about pressure injury by the numbers, but really I'm going to focus this morning on required safety practices. And for those of you who are familiar with accreditation, you probably know about required organizational practices or ROPs. And if you're anything like me, when you've led accreditation in an organization, that was printed off and had coffee stains on it, and it was crumpled and dog-eared because that was the highest priority that you were focusing on. And so we've changed as of April of this year to required safety practices. And I'll speak more to that this morning. Really wanted to emphasize that when we're looking at putting patient safety on the front burner, that optimizing skin integrity is right up there on the list. I'm going to trust this is moving. Is it moving? Okay. HSO is the Health Standards Organization, and many people know about Accreditation Canada, but they don't know about HSO, and they're confused by how do these two relate together. So I thought I would start off by explaining who our teams are and what we do. So Accreditation Canada is in every hospital in Canada, 1,017 hospitals, and in 70% of long-term care, primary care, and community care. And also in 45 countries around the world with global Momentum as well. So you can understand that when we implement a standard, we really try and ensure that it's been evidence informed, obviously, but that we have people with lived experience, policymakers, researchers, and frontline providers around the table helping us to bring all of those voices into developing the standards and the RSPs, but also to send those out through a public review process where we hear from Canadians on how to continuously improve and advance those standards. So when I think about the long-term care standard that was released, over 18,000 Canadians contributed, and we have the pleasure of dispositioning every single one of those comments and integrating those into the standard before we put them forward. So there's quite a rigorous process that goes into this. We also have advisory councils. And so one of the advisory councils that informed the new RSPs is a patient safety advisory council co-led by Ross Baker with us. And we have experts in the field of every single one of those required safety practices around the table, supporting the development and the ongoing updates to the required safety practices. So behind the scenes is my team developing the content with many, many experts from across Canada and the world. And then they get delivered into the accreditation program for organizations to self-assess against, continuously improve, and then ultimately have surveyors come out and assess their practice against policies and procedures. So when we think about the standards, we really focus on being people-powered, so that people-centered care. So you notice that we've shifted the language from patient-centered or person-centered to people-centered because that relationship between the healthcare team and patients is inextricably bound. And we really try and move forward with shared decision-making with clients, their caregivers, their care partners, central to that process. And certainly the prevention and the goal that we all have to eliminate pressure injury is a team game. It definitely takes a team. I've listed some there, but really wanted to emphasize that throughout all the standards and the RSPs, you'll see that integrated people-centered care approach. So there's a reason why I put a baby on this screen, because you heard that I used to be a neonatal and pediatric nurse practitioner. And the reason I did that, I don't need to tell everybody in this room what a pressure injury is. But the reason I put a baby on the screen is that my publications in skin integrity are in the neonatal population. And remembering that pressure injury can happen across all ages and all sectors, and really exposing people to that greater understanding of the large-scale systemic impact of pressure injury. When we talk about pressure injury, I think all of you know all of these, but it's really important to speak to what Joshua was saying was around systems impact and the impact of pressure injury. Sorry, the Zoom is blocking out the screen. Physical and mental well-being is impacted. Obviously, quality of life, relationships, and one of the biggest impacts is productivity, to feel like you can contribute in the ways that you want to contribute when you're managing chronic pain is really, really difficult. Increasing the risk of infection, increasing the risk of having ongoing injuries and complications that can lead to necrosis, even amputation, impacts on mobilization, resulting in hospitalization and morbidity and mortality. All of you know the impacts on hospital cost. Some of this data, this data is getting to be a little bit dated, but the idea of how much of an impact this has for all of us and how focusing on reducing and eliminating pressure injuries could really support all of us relative to the cost that it incurs and the workforce demand that it incurs when we already have a workforce crisis. We've taken this focus to structure, process, and outcomes. So when you think about accreditation, many organizations are faced with, I need to develop a quality management framework. Well, if you adopt accreditation, that is your quality management framework. You don't have to create another framework. And so that structure really does address governance, leadership, care practices, workforce safety, as well as client safety and outcomes. Throughout all the standards and the RSPs are the processes to drive those outputs and outcomes. And what you'll notice is a change in the development of the required safety practices and the standards that we're starting to put out. And I'll make note of the fact that we have this ambitious plan that between 2025, the beginning of 2025 and the end of 2027, all of the standards will be updated and evidence informed. So you'll have current content to reference. And what's being incorporated is quality indicators. So it's that shift from checking a box on the day that the surveyors come and everybody runs around to get everything ready to continuous quality improvement all the time and asking organizations to demonstrate how have you been driving continuous quality improvement? What have been the measures that you've been using for baseline? What are you comparing to? What does good look like? And how are you changing outputs and outcomes? So here's the new required safety practices. I won't list them all, but I'll talk to you a little bit about how things have shifted. There's no magic as to why this is number 16. We could have put them in any order relative to skin optimization. So how did we get here? The first thing that we wanted to do was ensure that they were updated, that they were evidence informed. And we really have got this focus on don't put it down on the page and don't ask people to do it unless we know that there is quality and safety evidence to say this will make a difference. When we talk about Vincent, and I'll reference his paper and his work, there's a lot of discussion about stopping the work of safety. So all the busy work, all the administrative work, there's certainly validity in reporting, analyzing, improving and learning. We don't want to throw the baby out with the bathwater, but we want to move away from the work of safety to having more proactive approaches to safety. So we've really tried to synthesize down and demonstrate through evidence what are the most important safety interventions that we should be focusing on. So that's how we got from that list from 38 down to 24. And we're actually continuing to synthesize that list down. We're following reports that come out of ECRI, the Emergency Care Research Institute, WHO, and other sources, AHRQ, although that's changed a bit with American administration. We're watching for any of the evidence that's coming out around emerging safety practices, one of which is really coming to the forefront is diagnostic errors. We've also changed the title from required organizational practices to required safety practices with purpose, because safety is everyone's business and everyone has a role at all levels of the organization. And most importantly, patients are decision makers at all levels of the organization as well. So you'll notice change in the accountability where everyone has a role in the required safety practices. And the biggest difference, which I'll talk about today, and really the conversation that Kathy and I have had around continuous improvement, measuring and monitoring, and innovation. So moving away from QA to QI. And so actually requiring organizations in the required safety practices to be demonstrating what is your baseline, what are you comparing it to internally and externally, and how are you improving over time? So most of you know that pressure injury and wounds were rolled up into optimizing skin integrity in 2020. And then in 2025, we've increased or introduced the measuring and monitoring components. This is the RSP for optimizing skincare, and I'm going to break this down a little bit later, but you can see that my point in showing you this is not to go through it in detail, but to demonstrate that the accountabilities are at all levels of the organization. So patient safety 1 and patient safety 2 has really been an emphasis for us. So if you're anything like me, you learned about safety reporting, immediate management, the disclosure process over time, analyzing using a systems approach about what happened, not who did it, learning from what you want to improve, and how do you share that across an organization. So that's really patient safety 1, that retrospective view. And again, continue to hold that in high regard, but also trying to introduce patient safety 2. So patient safety 2 focuses on that proactive approach, understanding who's at risk and how can we be proactive in advance before something happens, through safety huddles, through skin care rounds, through leadership rounds, through pre and post brief debriefs. What can we do actively, and what can the team debrief around who was at risk yesterday, what happened yesterday, and how does that proactively inform what we're doing in the here and now? So asking organizations to demonstrate how they're including that in their practices. So this is the RSP, or required safety practice process, and none of this will be surprising to you, to have a standardized approach, whether that's a clinical practice tool, whether that's a policy, whether that's a standardized decision tree, a standardized evidence-informed approach that the whole team is working from. Ensuring that everyone's oriented and has continuous learning around that approach. The evidence shows that there's a lot of controversy around, well, should we do this or should we do that? Should we use this dressing? Should we use this product? And really what the evidence shows is if you all do the same thing, that's when outcomes start to change. And then what do we need to do, and how do we measure and monitor our practice? So understanding, what are you measuring? Why are you measuring it? And to what end? And then we introduce benchmarking, and our intent isn't to make this complicated. Internal benchmarking is great. A whiteboard having a run chart is benchmarking. So your internal quarter over quarter data is as important as looking at external benchmarking as well, to understand what is good, what do we look like relative to another unit, to another site, to another organization, to a similar population. And how will we identify opportunities for improvement? And how will we transparently share those with the team? And then the cycle is iterative, in that then we have that shared learning and we continuously improve. So I mentioned Vincent, and certainly the London group is coming out with more and more frameworks around patient safety. And we work very closely with Health Excellence Canada and follow the national approach to incident management and patient safety. So encourage you to refer to Vincent and the model. And what we've reflected in the RSPs and are reflecting in the standards reflects this model, in the sense of we still are looking at past harm and learning from it. If you look at Ross Baker's pivotal paper from 20 years ago, unfortunately, the incidence of patient safety harm has not improved in some areas, and in other areas since the pandemic, it has even gotten worse. So we need to do something different, which is why we're also speaking to patient safety too, and being proactive. Creating that reliability and standardized approach so everyone on the team has the same shared mental model of what we're trying to achieve and how we're going to achieve it. And then having a sensitivity to operations, really recognizing the workforce crisis, really recognizing and focusing the teams on what will make a difference and how can we remove administrative burden and have them focused on working side by side with clients, patients, residents, caregivers, and their care partners. So just emphasizing the data, took some time to look at the CPIAP data, and I recognize this is limited by how well things are reported, and so that could account for the increase in numbers. The increase in numbers could also be accounted for the increased complexity of patients that are being introduced, remembering that CPIAP data is focused on hospitalized patients, as well as the increased screening and prevention. But suffice it to say, it's more than doubled in the last 10 years. When we talk about harnessing data, many people ask us, well, what should we be looking at? What should we be measuring? And thanks to many of you in the room, there's an incredible body of literature around what does make a difference and what should we be measuring and how can we be monitoring this to inform our improvement endeavors. So I've listed some here. Not going to read them out, but this is some of the guidelines that are in the required safety practice to help organizations. We're not going to prescribe what they're doing. They know their work best. They know their populations best. But to be thinking about what are the measures that you are monitoring and how are you going to identify opportunities for improvement? What's going to make a difference in your population? And when you're coming up with those indicators and measures, it's important to be working with the frontline teams, to be working with caregivers, care partners, and clients. They know the data probably best. That's their lived experience every day. And where can you focus? So really, when you're using measuring and monitoring, that helps you to identify what to prioritize. And many times, as many of you know with quality improvement, is if you move a big boulder, many pebbles follow afterwards. So if you prioritize what you're working on, you can make a big difference, especially when a whole site or a whole organization is focused on one or two big projects at a time, rather than many, many dispersed projects. And then benchmarking. Again, I'm not going to read all of these out, but thanks to so many organizations across Canada, there is data to look at, to compare to understand what does good look like, what could better look like, and who can we partner with. I saw a bunch of cameras come up, so I'll wait a second. And I'm sure these slides are going to be shared. Are they going to be shared? Please, yep. Then that spares people. So really encouraging people to be harnessing the data. So understanding not only how we can prevent injury, but more importantly, promote skin integrity and really be addressing new injuries as soon as we possibly can. And maybe moving away from quantifying what's happened in the past. Rates and understanding rates, and especially if rates are changing, are important. But what can we be doing further up the line for promotion, prevention, and addressing new injuries as soon as we identify them? Can't say enough about documentation and information transfer and the importance of interoperability. It's really difficult to feel like a team when you're pulling on people from many different sites, many different organizations, and you're trying to coordinate care, and you're not all on the same system. So where you can be driving interoperability, it really helps for that shared decision-making. And setting clinical outcomes, setting those clinical indicators and doing it in partnership with the entire team, inclusive of the clients and families, and measuring and monitoring. So we hope that the RSPs provide a bit of a guidepost to making a difference. So just in summary, really looking for active and visible leadership, prioritizing the reduction of pressure injuries and the elimination of pressure injuries, and prioritizing that as part of a safety plan in organizations where patients are at risk. That interprofessional collaborative team with the client central to that team, and really looking at that collaborative approach. And it's really difficult to be collaborative if you're not all singing from the same songbook. So having those standardized protocols in place that everyone has agreed to and has reviewed and are evidence informed. Then pulling on our champions, which you've already heard from, but really pulling in our specialists, not when things are really difficult, but earlier on to help us to prevent further injury. And then looking at new innovations in technology, and we all have to evaluate that using an ethical framework as to when it applies and why it applies and when we're incorporating technology and innovation, and of course, artificial intelligence. I find it a little bit odd when people talk about a criteria about artificial intelligence when artificial intelligence is part of what we're doing every day. It's part of what we're doing right now. So we have to be cognizant and aware of what's impacting our decision-making around enabling technology. But there is more and more technology, and you're going to hear more about it today, that can really start to influence a proactive approach to reducing injury. And then can't say enough about a systems analysis and learning what's going on and identifying early what you may be able to prevent, and then shared learning. Communicate, communicate, communicate. We talk a lot about really the message doesn't get transpired until you say it 7 to 13 times. So one email and one policy distribution is not enough. It's going to the front line, it's having conversations, it's doing leadership rounding, it's having skincare rounds. It's that layered messaging that starts to create change and starts to create momentum across a unit, then a site, then an organization. So with that, I thank you. I hope you have the best day. I hope it's really productive. I hope you take it back and share the learning. And it's just been a privilege to share the required safety practices with you this morning. Thank you.
Dr. Sandra, before you go, do we have time for questions? Are there any questions from our team or group here in person? Anybody would like to ask a question for Dr. Young? Dr. Young, I do have a question because I have to always ask a question. So we like the fact that there's all of these data avenues to really collect pressure injury information, and there's quite a number of them. And sometimes for us as clinicians and healthcare organizations, we often don't know where to go and how we can compare best. I think it's also common to the essence that they're great data to have, but how can we ensure that they're speaking amongst each other that allows clinicians to really understand how data is deposited, synthesized, and applied?
Well, that's a big question. There's about 4 concepts in there. I think that just going back to one of my slides, I'm not going to be able to go there maybe. I think you make a really good point about how are these sources talking to each other. And one of the things that we've been trying to do at HSO is partner with different pan-Canadian organizations to do that sense making. That if we're developing a standard, then how do we partner and connect with CIHI about what are the indicators? And then how do we connect with Health Excellence Canada around, well, what would an improvement pathway look like? So that that momentum is starting and trying to do a little bit more sense making like you're talking about. Certainly looking at primary healthcare right now, many of those organizations are coming together around performance metrics. I think the most important thing that I'll leave with is there's lots of sources of data and it can be overwhelming, like you said, but just focus on one thing at a time, something small cycles of change, and have everyone rally around it. And most importantly, listen to the frontline providers and the clients and the families. They know where to start first. And it's great when you start to see that momentum because, as I said, you make one change and many other outcomes result. So start small. Don't be overwhelmed with big.
I like that. Bite size is better.
Always.
Thank you. Thank you so much, Dr. Sandra Young.
There's one question online.
Oh, there's one question online.
Yes. How does the change in ROP from pressure injury to optimizing skin integrity impact on the success of accreditation?
Success of accreditation of the organization, I hope, not our success. I think the most important difference is, well, 2 differences that I'll make. One is moving away from, it's not at the organizational leader level. It's at every level of the organization where the required safety practices are asking people to focus. So that active and visible leadership and commitment but really looking at how does everyone contribute, including clients and families, to ongoing improvement. And then the second one is measuring and monitoring. So moving away from checking boxes and really understanding what difference are we making. It's not enough to report this is our pressure injury rate and check a box. Well, why? Why do you have a rate? What can we do differently? What do you compare to? And how are you showing a difference in not only quality outcomes, but safety and experience as well?
Great. Do we have time for one more question online?
Sure, one time.
Okay, so, oops, sorry, yeah, there's multiple questions now. I'd like to know if in your experience with neonates, you've seen in medical device-related pressure injuries and how you work with the multi-professional team to build approach that could improve skin integrity.
Well, yes. There's so many examples. When you think about a neonate who doesn't have the connective tissue, doesn't have the same layers of skin yet developed, and how fragile they are for insensible water loss and the shearing damage that occurs. So, not only how we're handling neonates just in and of itself, clearly, if you've met any neonatal nurse practitioner or any neonatal nurse, their bed is their pride. It is how you set that bed up and how you reduce skin injury is really where the focus is. And obviously, there's many opportunities for lines, shunts, any of the medical devices. And there's great technology coming out as to how we can support that and how we can work with parents to support that over time. So there's incredible amount of literature coming out in that area.
Thank you.
One last
Okay,
question.
this is the last question. So what are your thoughts on having zero harm, 0% of facility-acquired pressure injuries as an organizational goal?
Oh, who comes up with these tough questions?
Welcome to CPIAP, by the way.
Yeah. I struggle with zero anything. And there's so many factors that contribute. With our best intentions, we work with many different clients, many different families, many different professionals. Many people transition from one care delivery site to another, all in one day. They could be talking to home care, virtual care, palliative care. So I struggle with zero, and I'm sure that's probably not the answer you were looking for. I think we struggle with promoting first and preventing second. And once we're talking about rates, then I think we've missed 2 steps before that.
Thank you.
Okay, so
Yeah.
I'll let you, you're off the hook. I'm gonna let you breathe. And on behalf of CPIP, Dr. Sandra, thank you so much for your time. I know that you're very busy, but you came out all the way here to Ottawa to join us for this cause, and looking forward to collaborate with you in the future. Thank you so much. Thank you. Dr. Sandra. Okay, so by the way, when I asked the question as to who do we have here in the room and who has traveled the furthest, possibly our next keynote speaker might be that person. And I am actually very privileged to introduce to you Dr. Joyce Black. So Dr. Joyce Black is a professor in the College of Nursing at the University of Nebraska Medical Center in Omaha, Nebraska. She teaches senior level nursing students in intensive care nursing, teaches advanced pathophysiology to nurse practitioners, pharmacy, and physical therapy students. Dr. Black also supervises research activities of graduate students. She is an internationally recognized expert in pressure injury prevention and treatment. Dr. Black is the immediate past president of the NPIAP and has been active in developing many position papers related to the COVID-19 crisis and detecting pressure injury in persons with very dark skin tone. She is often credited with the rediscovery of deep tissue pressure injury and was inducted into the Academy of Nursing for this work. Dr. Black has received many awards for her work in pressure injury, most recently the Joyce Black Excellence in Teaching Award, created for her accomplishments with NPIAP and given to her as the first ever recipient. A prior award was the Koziak Award from NPIAP for her work to rediscover deep tissue pressure injury. Dr. Black's current work with NPIAP is co-chairing a task force to examine stage 2 pressure injury. There's more, the second page here. Without further ado, I'm honored to welcome Dr. Joyce Black.
Well, there we go. Thank you very much. Well, I did travel a bit Omaha, Nebraska is in the middle of the United States, but actually a pretty straight shot to here. Everything goes through O'Hare, so that's where I spent a little bit of time. Thank you for asking me to come today. I'm going to turn the discussion 90 degrees and talk about clinical care rather than policy. I don't set policy here in Canada. I don't even set policy in the United States. So I'm going to turn us a little bit. These are some disclosures. I do serve as a consultant and a lecturer for many companies. I'm also an expert witness in medical malpractice claims in the US. I actually had a call to do a case in Canada a few years ago, and I said, I can't. I was born in Minnesota, which is right next to Canada, but I'm still not a Canadian citizen. And they said, no, we can still use you. And I was like, no, you can't. Stop it. So here's my objectives. I want to drill down with you on how to assess darkly pigmented skin. That's becoming an increasing issue in the US. You guys are actually more diverse in your population here in Canada than we have ever been in the US. So I'm going to set the stage for where the issues are, and I think it might be something that we could work together to improve. I do want to look at prevention in a couple high-risk groups, that being the critically ill and the person in the operating room, and then very briefly talk about improvements or how we could improve treatment of pressure injuries. So let's start with darkly pigmented skin. This is a patient obviously with very advanced deep tissue injury of the buttocks. And the question is, did we miss it in the beginning? How did we get to this stage? One of the most critical pieces of data that I look at is not only the rate of pressure injuries in darkly pigmented patients, but the mortality. So if you go to the very bottom of the slide, you can see the mortality is almost 4 times higher in people with darkly pigmented skin, odds ratio of 5. That's significant to me, and that tells me that, at least in the study, it implied very strongly, we're missing the pressure injuries in their stage 1 and deep tissue injury phase. And because we're missing them, they're becoming more advanced. And then the question is, are we caring for them properly, which we'll get to at the end of today's talk. So here's the challenge in assessment. If I didn't have that red ring around this patient's butt, would you see it? Would you see it? You think you might see it, but that's because I have the red ring around it. Now, once it ulcerates, pretty easy, right? Because the contrast is pretty sharp. In contrast to people, if you're familiar with the scoring system for skin color, well, let me make it easy. In contrast to a Swede who has absolutely white skin, you can see the stage 1 deep tissue injury very easily. It's the stage 2 you miss. So that's absolutely the opposite. And sometimes it's skincare that picks up the stage 2. So there we go. How can we change our practice in assessment of these patients? I'm going to advise you to start looking at a consistent use of a skin tone assessment, either Fitzpatrick or Monk. I would encourage you to do that on admission. It doesn't need to be done with each assessment. I'm going to ask you to use natural light to assess the skin, and I'm going to show you a slide in just a second how important that is. So that means the night nurse can't do that assessment of the skin, the initial skin color, because fluorescent light changes the color of the skin. I'm going to show you a slide about how valuable it is to moisturize the skin. Not only moisturize with skin products, but wet the skin before you do the exam. In many patients, pressure injuries result in pain. And so you need to ask about that pain. I have a story from when I was working with second-year nursing students. We had a patient who'd had a total knee done. And the student came to me and said, the patient's complaining of pain. And I said, all right, let's get to the list of what the possible drugs are. What's the pain score? And I think she said something about 4 or 5, somewhere in there. So we picked an oral narcotic because he was going to PT in a little bit. And I go into the bedside with her to give the drug. And I said to the patient, where's your pain? Oh, right here, kind of. I must have hurt my shoulder because it's going down into my left arm. Oh, hold on here. We're not giving you Percocet. Hang on. We've got a problem. We've got a person with a possible MI. So the pain story is important because pressure injuries hurt. And even though the patient may be telling you that they need something for pain, it may be pain in the pressure injury. So it's important to ask what the source is. We're going to compare the skin color to surrounding skin and then avoid calling people Hispanic, or you'd call me German. I don't know if that helps at all. The term Hispanic doesn't tell you anything. The term Black doesn't tell you anything. So we're going to avoid using that. I want to share with you this slide in which the wound nurse was asked to see the patient. So start on the left and move to the right. The nurse was asked to see the patient about skin problems, and the nurse said, I think there's something on the ankle, but I'm not positive. And the staff nurse said, no, it's fine. So he added light to the story. So that's the middle picture. And you can see something is there. But look at the difference when he moisturized the skin. And so I said, what'd you use? Saline. Just took a syringe of saline and squirted it on it. You don't have to have a sophisticated moisturizing system. But if you're doing moisturizing, it's important. Yeah. Say it again. Oh. Is it advancing now? I can't see what you're seeing. Now you're seeing the moisturized skin. Oh, I can see by your faces you're seeing something different. I'm seeing the complete slide, and I apologize for that. So now compare across the slide and you'll see, oh, one more. Perfect, thank you. Now you're seeing, correct, am I right? Now you're seeing all the way from unmoisturized skin in just standard lighting to moisturized lighting. Look at the difference in how easy it is to identify that deep tissue injury. So it really makes the point that you do need to moisturize, you do need to have adequate light, big part of the story. So there's a couple of skin tone charts around. The ones that I think are the easiest for people to use are either the Fitzpatrick, which is 1 through 6, or the Monk, which is 1 through 10. I don't really think it matters. I think, though, for your system to look at how many people are getting pressure injuries based on their skin tone will be very helpful for you because it will help you decide what education is needed. So we use the inner arm to determine skin color. My suggestion is you measure it at the time of admission. It's not going to change. You don't have to measure it every time you see the patient. Now, the Fitzpatrick scale was designed by a Boston dermatologist a number of years ago when he was trying to figure out the risk profile for melanoma. And he saw more melanomas in lightly pigmented skin. So the Fitzpatrick scale tends to lay more heavily on the lightly pigmented. You can see there's only a couple of options for darkly pigmented in Fitzpatrick. Monk is a more diversified, even distribution of skin tone. So there's probably a benefit to Monk. I'm old, I use Fitzpatrick, but it works either way. The idea is to get an accurate, objective assessment of skin tone. So some of you are saying to yourself, where did this come from? How come I never heard a word about skin tone in my entire education? Well, you probably didn't. I mean, I didn't educate you, but I can tell you at the University of Nebraska, well, I'll tell you in a minute about the University of Nebraska. The question was, how well are we teaching student nurses about skin tone? So Joy Pittman and I put together this little study. Here's the document. I don't expect you to read it. It's just my transition slide. Asking the question of maybe that's the problem. Going back to that original slide of 5 times the mortality rate, maybe the problem is we never taught them well to start with. So let's figure it out. So here's what Joy and I looked at. we looked at physical exam books, and we found that some of the books had photographs of patients with dermatologic disease in darkly pigmented patients, but there was actually no objectives on skin tone diversity. And what we were looking for was what are the photographs? Do we have photographs of the stages of pressure injuries? Some did, none had pressure injury stages by skin tone. So our students, the book isn't helping them. So when we did this study, I went to our physical assessment instructors and said, are you guys teaching skin tone? Oh yeah, oh yeah. I'm thinking, well, the students clinically haven't got a freaking clue. So I'm going to call you on that. I don't think you are. So step 2 of the process for me and Joy was to look at the mannequins that we were using, because today a lot of students get a lot of training in non-patient related situations, the labs and the sim labs with mannequins. So how many mannequins have we got with darkly pigmented skin? Joy's at the University of South Alabama. 50% of her mannequins were dark skin versus light skin. I'm at the University of Nebraska. 20%. Do I think we should have more? Yeah, I do. So there's the situation. So we aren't training people properly to catch this. And yet we know that pressure injuries are higher rates and more fatal in people with darkly pigmented skin. To me, a big gap, kind of an easy gap to fill, if you think so. So what does the guideline say about pressure injury detection in darkly pigmented skin? So it says to use something called subepidermal moisture assessment. And there have been studies done on using subepidermal moisture assessment to have early detection of pressure injuries in darkly pigmented skin. So it works fairly well. Here's what it looks like. There's the actual device, and it's been approved by the FDA for the heel and the sacrum. So you put that device on the heel, and it gives you a number of the transepidermal water, or pardon me, the subepidermal moisture. And using the premise of inflammation, subepidermal moisture would accumulate with inflammation, and inflammation is the part of healing of early pressure injuries. So there's the physiologic connection. What the company says is when there is a change of 0.6 from baseline to today, there's elevated risk in that patient. This is a study done, a second study done, where they made a little map of what the wound looked like in the areas of subepidermal moisture change. So the other thing the guideline recommends is to look at skin temperature. So yeah, my mom used to assess my body temperature like this. Yeah, you feel hot, take your clothes off. I don't have anything to treat your fever. Out on the farm, we'll just fan you down. So today, since everybody wears gloves, it's pretty hard to just measure somebody's forehead temperature. So we're gonna uptick this a little bit with some thermographic measurements. Thermography is a measurement of blood flow into the skin, and the scientific basis is blood that cannot enter ischemic tissue will render it cold. And when patients have inflamed tissue, the tissue will be hot. So it's my mom, but just made into a little device. So here's an example. If you're not familiar with thermography, I'm going to have you go way over to the right side, and you'll see a rainbow of colors. So if the skin is hot and inflamed, the image will be red or orange. If the skin is ischemic, the color will be purple or blue. So here's the story on and the way the camera works is you get a photograph alongside the thermographic measures. So what you're seeing was taken in one image. The little red dots on the guy's heel are just the camera finding a center. So this is a guy who was found down on the street. Nobody knew how long he was down, but on admission to the ER, his heel looks fine. His heel looks great. And have you jump over to the thermographic image now. You can see his heel is purple. Now, normal skin is yellow to light green. So the guy holding his hand up is alive because his hand is yellow and green, but the patient's heel is purple. So we have early identification on admission of lack of blood flow to the heel, and therefore floating the heel would be a perfect solution. And that's actually what it did not go on to ulcerate. The inflamed case, here's a patient with sacral pressure injury developing some undermining up on the upper rim, and the thermographic camera gives you that inflammatory response, the yellowish change to the tissue. So it's a good device. SEM is a good device. They both work. It's just your choice of how you're going to do that. So I want to move into prevention in high-risk patients. I'm going to talk about critical care and the operating room. Those are the two, at least in our hospital, that's where the risk really starts. So it's absolutely crucial, and you heard a little bit about this a few minutes ago, to have a skin assessment done on admission of all of the skin. And boy, do we struggle with that. We struggle with that, particularly in the ICU, because we hear things like, well, the patient cannot be moved right now. Okay, can you get the patient moved at some point because he's still laying on the linen from surgery? So I think you're going to move him eventually. Do you think you could look at the skin at that point? The other thing we ask is that 2 nurses examine the skin. That's been a fairly common thing. And somebody said to me, so a nurse with glasses would be 4 eyes. I said, no, I'm not talking about that. I'm talking about 2 people with 2 functional eyes. So I guess if everybody's blind in one eye, you'd need 4 people. I want people, honestly, you can drive this into oblivion, right? So the second person is there in part to help the decision of what we're seeing, and in part to do what you see in the picture. Because people that are morbidly obese, it is impossible to move some of the skin folds with one hand to look with the other hand or treat with the other hand. So that second person is also there just to mechanically get the skin assessed. And then one of the problems, and Joshua's been on the team with us on this stage 2 thing, is don't guess what the problem is. Identify the problem correctly. So we have a huge tendency to stage every open wound of every etiology as stage 2. It doesn't matter what its cause was. I had a nurse tell me one time a patient had a stage 6 on the sternum. And so I thought, wow, I got to see this, a stage 6 on the sternum. Well, the sternum was missing. So she was actually looking at the pericardium. And I thought, oh, okay, you're just anatomically going down. We don't call sternal dehiscence by staging. So people stage everything, and it's important to get the stage right. So we use Braden in Omaha. We don't have any choice. Barbara Braden was from Omaha, so we're never gonna lose the Braden scale. But the problem is, the perception is that this thing is not accurate, and therefore it's of no value, and therefore it's parked in the medical record just to be there. I actually asked some nurses one time, what do you do with the Braden scale? Put it in the chart. Yeah, I know, but what do you do with, no, nothing. We just fill out the numbers and put it in the chart. Well, it was meant to help you with pressure injury prevention. Okay, all right, I'll believe you, so if that's the mindset, then how do you change practice? And in critical care, one of the big complaints is that it doesn't deal with perfusion and oxygenation. So how valuable is it? But it's the critical care patient who's also laying in bed almost continuously. So I think it still works. It just probably isn't as good as it could be. So as I was saying, what happens to the Braden scale? I don't know. Does it direct care? I don't know. Sometimes not. We have staff nurses who want the Braden scale to be 17 or higher, because if it's below 17, the wound nurses come and start ordering a bunch of stuff. So they intentionally scale it down to 17. I think what we need to look at, though, with the Braden is immobility is the cause of pressure injuries. I told some people last night I do legal work, and I get asked by attorneys, what's the cause of a pressure injury? And I charge them a fortune. And I sit there, gosh, what is the cause of a pressure? Hang on, let me think about this for a minute. Just a minute. I'm coming, it's coming, pressure. And they look at me like, you got to be kidding. And I go, no, truly, it's pressure. So the cause of pressure injuries is immobility, aggravated by shear. And in the sedated ICU patient, you've got that whole combination of problems. So numbers are high. Incidence is high in critical care, probably higher than any other unit in the hospital, except perhaps surgery, and we'll look at that in a minute. So in this study, 59% of the hospital-acquired pressure injuries were coming out of critical care. And the sacrum and heels are the most common. You can see the whole list of risk factors, and that's what I hear from the critical care nurses is these patients are really sick. We're saving their lives. They should be pleased to be alive with a pressure injury. I said, well, they don't see it that way. They don't have any idea that you manipulated the vasopressors or you adjusted the ventilator. They have no idea about that. What they do know is they spent a year of their life going to an outpatient wound center to be healed. That's what they do know. But that attitude is hard. It's hard to break. There's the risk factors that correlate, and of course it makes sense. So how do we prevent pressure injuries in the ICU patient? We need to have the right bed to begin with because you're not going to be able to move them once they land in bed. If the patient's obese, get the bariatric bed in before the patient arrives. Put the foam dressings on the sacrum. We have plenty of evidence that they work. Get the patient moving. This is tough because I hear the patient's hemodynamically unstable. All right, well, let's try moving them a little bit. Just don't turn them to the left side. You turn them to the right side because if they dump the wet lung on the heart, it's going to be a problem. So start on the right side and don't stand and stare at the monitors. Give them a chance to recover because if their pressures are going to fall when you move them, just like yours do when you stand up, give them a chance to recover. Turn teams are very helpful with ICU. We need to use wedges to keep the patient at 30 degrees, but the wedge needs to be under the patient, not hanging out on the bed. And then the chair is a huge issue. I'm working with a hospital right now where the cardiac surgeons have ordered that the patient be up 12 hours a day in a chair. And so they interpreted that to mean they get them up at 5 and put them back to bed at 5. And I said, but what do you do in that 12 hours? Nothing. They just sit there. No, they can't just sit there. I didn't fly here. It didn't take me 12 hours to fly here. I couldn't sit for 12 hours in the terrible bedside chairs. So you can't do that. The document you're looking at is a document that we prepared a while ago, Joy Pittman and I, and it's a shortcut to the guidelines. It's available at NPIAP. So it can help you. It's a checklist of what to do with the critically ill. One thing you'll see is you can turn patients every 2 to 3 hours. So that's an asset. A question I commonly get is this deep tissue injury that started in the ICU, is it deep tissue injury or is it skin failure? Whatever that is, we don't currently know what skin failure is. We know that deep tissue injury is common in the ICU and it's not skin failure. We're struggling. A lot of people want to intentionally rename deep tissue injury as skin failure. I don't know what skin failure is. There's no biopsy, there's no photographs, there's no nothing of skin failure. Jump into the OR. The operating room nurses say that a pressure injury coming out of the operating room is one that appears within 72 hours of the time in surgery. So that's actually a long period of time on that body part. So what they're saying is if you're in surgery and you're supine, we have 72 hours of time in which we would call that an operating required ulcer. Incidence runs all over the place. The highest risk groups are the prone cases, the open heart cases, and any case over 3 hours. Most OR acquired pressure injuries are deep tissue injuries because the patient is completely immobile and anesthetized. I understand that I would not lay down for surgery if I wasn't fully anesthetized. I'd get up and run away. So these are very classic cases of surgical acquired pressure injury. So how do you prevent pressure injuries in the operating room? You change the mattress. These patients can't move and can't be moved. In fact, a few years ago, the AORN had a statement in their standards that after 2 hours in surgery, the patient needed to be moved. So my husband's a surgeon, and I came home and said, guess what? You're going to start hearing from the OR nurses that after 2 hours, you need to move the patient. And he said, no, ain't going to happen. You mean you'd have to back up, take the drapes off, change the patient, re-prep, no, we're not going to do that. So look at the risk prior to surgery, particularly padding prone to pressure injury areas. That's what the dressings are great for. Photograph any open areas to start and make sure that the table has adequate padding on it. Get the heels off the table and then position the patient as best you can on the table to both allow for the operation to go on, right? That's the big thing, and protecting the skin. When you do a root cause analysis of operating a required injury, you need to find out from the OR what position the table was in, because they don't always say. They don't always tell you. They do tip this patient to allow surgical access, and that alters where the pressure injury may come. They examine the unique positioner. Sometimes they're still using egg crate foam. And if that's the case, that needs to go in the trash, or you can take it camping with you or whatever you want to do. There's no value to that. And these are not coming from cautery pads, so you can leave that out of your discussion. The patient on the upper left is one I think you'll find interesting. He's a guy who came into our hospital for elective lumbar fusion, which was done prone, except the face holder on the operating room table wasn't padded. Nobody saw that. So after surgery, he has these wounds. My daughter, who's a lawyer for the hospital, said, Mom, what are you doing? I said, stop it. I wasn't there. Mom, come on. He came in for elective surgery and leaves with these. I'm just going to have to pay the case. I can't, there's no way I'm taking this case to court and saying, look at how fabulous we provide care. We can't keep your face intact during lumbar surgery. So that didn't happen. Deep tissue injury does have a number of unique appearances. So I would encourage you, if you're struggling, this is a document on the NPIAP site where it'll help you figure out what is and what is not deep tissue injury. So very quickly on the treatment of wounds, I like to use the analogy of the three-legged stool. And just like the three-legged stool, if one of these legs is missing, the wound's not going to heal. The first one is getting rid of the cause of the wound. The second one is adequately nourishing the patient. And the third one is treating the wound. I was really pleased to look at your exhibits today. You have all of them. You have all of these in your exhibit hall. That's not common. Most of the time, the exhibit hall is filled with things to do to the wound. But in reality, the body heals the patient, not what you put on the wound. So you got to take care of the body. So how do we do with repositioning patients? In 1994, the original Purple book said, do not position the patient on the wound. How many times have you made rounds on patients with sacral pressure injuries like this guy, and they're laying on it? And you say to them, sir, you can't keep laying in the position you're in because that's how you got the wound. You need to get off of your back. Well, I can't. The Price is Right is the TV show that drives me nuts because nobody will turn on their side when their favorite TV show is on. It's like, stop it. Stop it. Move the TV. Well, we can't. The TV is bolted to the wall. So when you see a patient with sacral ulcers, please start writing turn side to side only to get the pressure off. You've got to get them off of that. Obviously, they need to be on their back sometime during the day. So 3 hours a day, that's it. And then if a patient's tube fed, how do we deal with the head of bed elevation problem? Can we turn a patient with head of bed elevation? I think we can. Now, nutrition. Okay, slap yourself in the face about nutrition because this is absolutely awful. In our hospital, I can't speak for yours, in our hospital, patients don't get fed in critical care until their NPO for between 5 and 7 days. I'm that case. I was septic 2 years ago. I was hospitalized for 3 weeks, lost 30 pounds, including skeletal muscle, because I didn't get fed, or I couldn't eat it, or I was in ileus, or I was ventilated. The nutritionist never saw me. I lost 30 pounds of weight. Now I put it all back on, fortunately, right? Fortunately. So this is an old chart of how high metabolic rate becomes with some of these. So look at the top two, major burns and major trauma. Major burns, I think we got figured out. We dealt with nutrition a long time ago with that. But if you're a trauma center, you need to be thinking about how high their metabolic rate is. It's absolutely high. And we need to improve nutrition. So we need to add oral supplements to the diet. We need to stop restricting the diet in older people with pressure injuries. Those recommendations about low cholesterol, low fat, low this, low that, were generally for cardiac disease management. That day is gone. Let's get the pressure injury healed. If the guy wants to eat ice cream 3 times a day, let him eat ice cream 3 times a day. For those of you in acute care, and I guess in long-term care, do you know how much of the tube feeding's actually being given? Or are you holding it multiple times a day for meds or going to PT? And so if that's the case, you need to alter the structure of feeding and feeding at night to start people's feeding. We do not do well at nutrition. Moving to topical wound care, here's the most common mistakes I see. Hydrocolloid dressings are used on necrotic wounds when it's difficult to get any other dressing to stay. And if you put a lid on a trash can, it's simply going to get worse. So it looks good. You don't see the wound anymore, but the organisms are percolating. Adhesive film on any wound. Adhesive film was never meant to be a wound dressing. Wet to dry dressings on granulating wounds. Do you guys ever see the order that says wet to dry until healed? Have you seen that order? That's job security. You will never get a wound to heal doing debridement with every dressing. That's stupid. They can't do wet to dry dressings to heal because you're pulling off the tissue. When you use negative pressure devices, be certain that you identify how many foam dressings you stuck in the body, because you might do the first dressing and I'm doing the second one and I have no idea how many I'm looking for. And they get stuck back in the depths of the wound, only to lead to abscess. We still soak wounds. We still treat them with hydrogen peroxide and Epsom salts and all sorts of stuff. So lots of errors. So how many of you are irrigating or cleansing wounds with normal saline? Don't raise your hand. You're going to embarrass yourself. Normal saline has no benefit to killing bacteria. Normal saline is normal saline. So if you're still using normal saline to irrigate a wound, like this respiratory bullet thing, if you're using that thing, you're actually baptizing the wound. So you're not doing any good whatsoever. If you're using Dakins to cleanse the wound, you're killing everything under the earth, including the cells you need to stay around. The fibroblasts, the good cells are being killed by Dakins. Hypochlorous acid is an irrigant that can be used to kill the bacteria and not destroy the normal tissue. Then how much force are you using? It's supposed to be between 4 and 15 pounds per square inch. That little respiratory bullet's got nothing, just drips of fluid, so you can knock that one off. Here's a little data on hypochlorous acid in case it's new to you. Hypochlorous acid is the first box here, the HOCl here, if you can see my mouse. The next one is Dakins, and the next one is hydrogen peroxide. The kill rate is not the same. Hydrogen peroxide doesn't kill much at all. So no value to those other solutions. Debridement is a technique of choice for many people. There's lots of methods to debridement. Please do not debride stable eschar. Please stop doing that. If the patient has no blood flow to their limb, you open up the wound and it becomes osteomyelitic. So you're looking at that kind of heal. This is one of my favorite series of photographs. This is a blood blister that was debrided. I'm not sure what you gained. You can see the necrotic tissue, and a few days later, you're back to necrotic tissue. So there's the reason to not debride. Joshua, I'm looking at time. We have a problem, or at least I hear we have a problem with compliance. Nobody does what we tell them to do. That is a Rojo cushion. The arrow didn't come through right here. That's a Rojo cushion sitting on the Rojo cushion box underneath a bunch of dressings. Didn't ever get behind the butt of the patient, but is there sitting dutifully on the windowsill. People have a problem with compliance, and what we're asking for sometimes is out of reach for patients. So when you want them to do a particular plan of care, ask them if it's reasonable. Or what, am I asking you to do something you can do, or is it something you can't do? I'm sure the patient we're going to hear from later on is going to tell us about that. There are a number of groups of patients in whom compliance is a known problem. The paraplegic, particularly the young paraplegic, who was very recklessly driving their car and hit a bridge abutment. They don't see that what has happened to them, and they don't realize it. Obese patients are not comfortable in many hospital beds and just pop into the bedside chair. And then patients with dementia who do not understand the need to be repositioned. So this paraplegic was a patient of ours and wanted nothing more than to go to the casino. And he sat in the casino all day long in his wheelchair and gambled and came in when he was septic. I think one of the challenges ahead of us, though, is recognizing that there are a number of patients who have wounds that will not ever heal. And we can do any number of things to them, but they will not heal. And we need to really figure out what palliative care should be, because we're going to change the goal from healing to palliation. And that's an important change because it allows the patient not to go through weekly debridement, not to go through daily dressing changes, measuring the wound when we can, not because we have to. Our biggest goal is probably to manage the odor in the wound with metronidazole. So I think the best part of our relationship is yet to come. We've had some fabulous discussions on stage 2s. Joshua's been part of that. What's the pathophysiology? What's the differential diagnosis? And we're getting ready to push that. And I think here's where we should be looking. Can we get more diagnostic devices like SEM and the thermography into more facilities to detect wounds early? Can we predict failure to heal so that we, like the oncology patient, can say, with your stage of wounds and your disease, it's going to take 2 years to heal this, and I'm not sure you're going to be around for 2 years. You don't say it like that, as crudely as that. But what else can we do? And then can we manage full thickness pressure injuries without without urinary catheters, because we're getting urinary tract infection left and right in those cases. So let me stop. I know I ran over. I apologize. I tell stories and I can't stop. So, but do you want me to answer questions or should we go straight to break? You tell me.
Are there any questions? There's lots of questions online.
Oh, is there? Okay.
Yeah, I'll pass.
Oh, I see hearts flying up. That must be a
That's
good thing.
good. Do we? Oh, we don't see them on the screen.
Flying hearts is always good.
And we did start a little late, so we are good with time. And don't worry about my part. It's important, but I'll keep it short and sweet.
All right, so we have several different questions here. I'm just going to kind of keep it more to the clinical ones for now. So one, can a deep tissue injury occur within 12 to 24 hours of immobility? I'm thinking of ER wait times.
Yeah, what we've classically understood is that the time from pressure to purple is 48 hours. However, I can tell you in people who are paralyzed, it will go much faster in 12 to 24. In very thin skin, there was a picture in my set of a patient with a big deep tissue injury across the forehead. That came up very quickly. There's no fat there. I mean, even though you tell people they're fat-headed, there's really no fat there, so there's nothing to keep it from delay. So the answer is yes.
Thank you. Another one online. How can we encourage bedside staff to prioritize pressure injury prevention? It seems the common theme is often that pressure injuries are not prioritized until they occur or until they progress significantly.
How about beats me? I don't know, particularly the ICU. I had an argument with the ICU one day. I was fed up with their practices. And so I said, okay, I get it. ABC, airway, breathing, circulation. I get that. I teach it. Can I have D for dermis? No. D is drugs and drips, Joyce. We got to stabilize. When they come down from surgery, we got to get all this organized. All right. Can I have E for epidermis? No. E is emboli protection. We need to get them in their sequentials. Okay. Going down the other letters of the alphabet, can I have S for skin? No. We're the ICU. We're saving lives. We don't care about skin. I don't know how to answer that. I do think posting numbers, we did a competition one time between nursing units. That helped because we had prizes. Yeah. Question in the back.
So this may be a follow-up to that because when you're saying that the nurses with their brain, they just put it in the chart. We experienced that too in Vancouver.
You shook your head a lot, so
Yeah,
I could tell you followed.
It's so frustrating, especially because on our brain, we have on the back the actual pressure injury prevention care plan
By
based on the
subscale?
subscales. Yeah.
Oh, fabulous.
Yeah.
That's
But
the way it's
again,
best used.
that just goes in the chart. And so how do we get that brain scale risk score to translate into the pressure injury prevention?
Do you chart on an electronic record?
Well, some of us do and some of us don't. I work in long-term care and it's mostly paper.
Oh, okay. I was going to tell you, if it's electronic, you just program whatever the subscale comes in, the interventions pop into the task list. In paper records, it's going to be harder because you're going to have to transfer that to a formal plan of care or a daily plan of care. Yeah. The way it's best is the subscales. And we used to use for all the 4s and the 1-3, continue to monitor activity, continue to monitor mobility. So we had a care plan for each one of them. And it went into our EHR until we got a new EHR, and then we fell to the back of the line. So we're struggling with the same thing. Yeah.
Okay.
You must have the answer, not the question, Kim, right?
Well, like you, I do a lot of legal work. And one of the things that I think is going to change things is I'm sure it'll be out in the paper soon, but there was a big lawsuit of which a major hospital in Canada lost because they were being sued because they did not prevent a massive pressure injury in someone who was then discharged to long-term care and it resulted in death. So they lost the lawsuit because, and what hinged on it was when I went through all the documentation, they filled out those Bradens like no tomorrow. They never acted on it. Not one piece of documentation showing they acted on it. So that's why, and they said, oh, I'm sure we put in preventative strategies.
Show
Show me.
Yeah.
So they ended up losing the lawsuit because the nurses documented, they acknowledged there was a risk, and they did nothing about it. So I think that those kind of things is what's going to change practice. It's not you and I and everybody in this room who's drank the Kool-Aid going in and saying, we need to do this, and this is why. It's going to be when they're forced to.
So what you guys that don't, some of you do expert witness work, so you know this. The way the law sees that is you knew the risk and intentionally failed to act. And it's that intentionality that drives the verdicts up, because you should have known better. You did know better. It's not an accident. That's how the law sees it. And it sounds like here in Canada, it's the same in the States. Whoever started it pays the whole bill. It's not, you don't get away with saying, well, it wasn't that bad when he left our place. It was this place that did him in. You can't do that. I see Joshua coming with the purple bag. So I'm around if I'm here for the day. So I'd be happy to talk to any of you. Thank you so much.
On behalf of CPIAP, thank you for raising. So we're gonna skip the introductions for myself. All you gotta need to know is I'm JPIP, Josh for Pressure Injury Prevention. Good. So my portion here is to provide just some transparency of what is CPIAP doing this far and where we're headed to in the future. And as you can see, I'm going to just fly through my slides here, just in the interest of time. Those people that are new to the summit and new to the CPIAP who may not know and be aware of us, we are actually a pan-Canadian panel comprised of different interprofessional clinicians and researchers. And we just have one specific goal, and that is to represent Canada and address national issues related to pressure injuries. And I really want to appreciate and acknowledge each and every one of you today, because by being here, you're taking this commitment to be part of our team. And I'll keep everybody's tags in here. Okay, so we want to really owe it to Dr. Kevin Wu's vision of having this national panel available to really be a voice for the Canadians, to really showcase and be the leader in representing these issues to stakeholders. So it's really up to his vision to have this panel available. And with this, he brought this up to the NSWAC board as an idea, which was tremendously accepted. Now, about 5 years ago, I know we are young, but I know we are mighty. And now that you guys are here, we're going to be even stronger. I just want to acknowledge our inaugural members. And even Dr. Kim LeBlanc was part of the initial phase of CPIAP. Kathy Harley was very, very instrumental in trying to lead and also guide the panels in developing a strategic plan. And as what you can see on this particular side, they developed a 3-year plan which focuses on raising awareness on pressure injuries to make sure that this becomes a national health priority, first promoting standardization, and of course, transforming the culture, which is one of our themes today, and our perspectives on pressure injury management. Now, our organizational structure didn't look like this before, but it's now growing. It's ever growing as we continue to build more partnerships and take on initiatives. So we have voting members that are the executive officers and directors, alongside our NSWAC Canada advisors, our past presidents, and also our task forces that's working alongside us. I just want to highlight our executive officers who are actually guiding us and leading us to strategic planning. And we are very fortunate to have Dr. Chester Ho, who is also going to be instrumental in leading us to quality initiatives. And as what Dr. Sandra Young has mentioned before, we want to have that kind of culture of continuous quality improvement. And how do we make sure that we can compare and contrast our baseline data with our ongoing transformational data moving forward, and how we can benchmark across. So these are one of the things that we do as part of the executive team. Now, being pan-Canadian doesn't mean that we're only going to have a few people. We have to have great representation from different provinces and territories in Canada. Hence, we are very fortunate to have 12 board directors from different provinces and territories. Now, I just want to highlight as well that I'm so grateful to have such a wonderful set of talented and very knowledgeable individuals, because it's with this, our CPIAP is actually a working board. We don't just provide oversight, we actually work and co-lead some of the initiatives that we provide. And this is also part of their volunteer time. So it's really such a great commitment to be part of this panel that we have today. Now, again, one of CPIAP's initiatives this term is to ensure that we have a voice of a person with lived experience at the table to guide and influence the board in the decision-making process. So I really would like to commend the CPIAP board for their unanimous decision to appoint Luz Adriel, which we have here today, and who expressed her incredible passion and commitment towards making a difference in the care and management of patients with pressure injuries. And we really are truly excited to collaborate with Luz over the next couple of years and shape things up to ensure that we are implementing initiatives that is basically for the people that deserves that change, and that is Canadians that actually have pressure injuries and preventing Canadians from having more pressure injuries to come. I also want to acknowledge our current CPIAP advisors, and as what you can see on this slide, we have expanded over the years to include our past presidents, interprofessional and patient Indigenous representatives, including Dr. Gary Sivold, who's been with us since the beginning of time. Now, though our advisors are not really voting members, they render their expertise and insights to assist the board in making meaningful decisions. I'm not Speedy Gonzalez, but I'm just going through the slides here. Again, part of our strategic plan, we are focused on 4 key priorities as what is outlined here. I'm not going to read it out for you, but any of our initiatives revolve around these 4 key strategic priorities. Now, I just want to highlight some of the things that we have worked thus far to be as transparent to everybody as what we are doing as a panel. I did highlight already before that, one of the first things that we have, try to plan for and ensure that we implement is having a summit, and that was since last year. And it was really a success because it brought clinicians and stakeholders together. The collective perspectives and responses from the crucial conversations that occurred at that time enabled us to really establish a roadmap that CPIAP can work on for the years ahead. Now, today's summit is really a crucial second part, and because it is really aimed at providing insights or strategies and even solutions for all our attendees to consider. Therefore, each of the topics, if you look at the outline, were carefully selected to complement and address some of last year's gaps and issues that we have identified. Now, if you happen to come across a CPIAP website, you might have come across this pressure point, and it's due to the leadership of Nancy Schottenbeld, our New Brunswick director, and Shannon Hadfield, our former British Columbia director. They have a working group that developed and scanned the entire country for any pressure injury prevention and management resources, policies, and procedures. Now, their hard work led to the development of this pressure point, which is the CPIAP's provincial and territorial Pressure Injury Prevention and Management Center. We really encourage each and every attendee here today and the public to kindly visit our website to see how these resources are available so that you can compare and contrast some of the similarities and potential differences and how we can align those practices together. Now, this initiative became a springboard for CPIAP to really understand how Canada's pressure injuries and practices are, and our resources became instrumental in the development of the white paper. Now, who is familiar with this best practice guideline here? I don't think anybody is. Is anybody familiar with this? Okay. So interestingly, about 4 CPIAP panel members and advisors were part of the development of this guideline. They're part of the expert panel. If I'm to include our CPIAP president-elect at that time, that will be 5. But this shows our panel members' commitment to taking part in such important initiative, since this particular BPG guideline is actually adopted not only widely here nationally in Canada, but internationally in different organizations because of the BPSO strategy. Now, currently, there are 1,500 BPSOs both in Canada and globally that are part of that initiative. And for them to see this guideline can also result into ensuring that it is adopted for us. Now, one of the initiatives that we also had done is, of course, focus on patient and family resources. And what we've done is we scoured the country for resources that are available in different regions of Canada. We have received about 40 of those resources, and then we actually reviewed them. Now, we want to highlight that we have used a content analysis framework by our folks in Australia, by Bukatea and the team, and see that looks into different components and how the resource were formatted, what type of pressure injury prevention strategies were highlighted, and even how they were endorsed by the regional health authorities. So it gave us a perspective of how sophisticated the resources are and how helpful they are for their audiences who will be utilizing them. And the second part of that initiative enabled us to reach out to our regional health authorities across the nation to see if we can house their resources directly at the CPIAP website. And if you're asking why, and that is because we want to make sure that we can make it easier for persons with lived experience to know what resources are available for them that they can utilize as part of their own toolkit. Now, on to some of the ongoing CPIP initiatives. We try to continue to engage the public in terms of our social media strategy, and we are going to be forming a new working group co-led by our past president, Kailan Bolo, who will collectively continue this important work. And our plan for the next year is start establishing some newsletters for our members to really have and also utilize as part of their ongoing learning, and also as part of our prioritization when it comes to pressure injury practices. I'm not going to talk much about the Canadian White Paper because Dr. Chester Ho and Dr. Sharon Gabison are going to be touching base as to what is the progress thus far. But as what you can see here, there is a lot of work that has been done in the past couple of years. We had recently done a modified e-Delphi process with several important stakeholders to really look into several recommendations that we have. And the publication of this paper is coming to fruition about the end or early next year. And hopefully that you guys can really understand the importance of having this to know what Canada's pressure injury landscape is all about. Now, who knows about the international guidelines? A few people. So actually, the international guidelines has come up with a set of pressure injury preventative strategies and recommendations. And this is what's developed by the joint collaboration of NPIAP, EPUAP, and PPIA. Now, the fourth edition of this guideline, interestingly, CPIAP is one of the associate organizations who collaborate in its development. And a couple of CPIAP panel members are actually part of the expert panel groups who reviewed some of the recommendations. Now, it's important for us, as what Joyce has mentioned before, it's good to really complete some of the risk assessments, but what do we do and what do we do with those type of information? And same thing, it's good to have all of these guidelines that are evidence-based available, but what are we going to do from then on? So we are creating a set of task force teams in CPIAP to really look into all of these resources of these guidelines and how we can apply it into the Canadian context. And not just that, in the Canadian context, but in different sectors of care. So whether you are working, let's say, in a long-term care environment, in a CCC environment, we'll see how we can kind of mold that guidelines to reflect your current practices in order for you to support and see that they're actually meaningful for you and your teams. Now, we strive with CPIAP to continue to strengthen our partnerships with international pressure injury organizations. So we did that with NPIAP. And now we're actually venturing out to our colleagues across the Atlantic. And we were so fortunate to actually have met the EPUAP President Tom O'Connor and had insightful discussions on how EPUAP and CPIAP can foster a joint partnership. So definitely a lot of exciting endeavors there, and we're waiting for it to come into full fruition. Now, as what Joyce has mentioned before, CPIAP also is a partner with NPIAP, and a lot of our members are part of different councils and committees that they have. And one of the exciting ones is actually the Stage 2 Task Force, where myself, Caleb, as well as Dr. Kevin Wu are a part of. So that task force is actually a masterclass for Stage 2s. What you know right now at Stage 2, probably you have to forget about it, or probably build on it, because it will provoke you and challenge you, and you'll probably be shocked and be traumatized for the rest of your lives. But it's something that's really valuable, and for me, I'm very excited, but I'm not privy to sharing anything, but looking forward how this can shake things up and be better in terms of how we can identify those types of partial thickness pressure injuries. Now, some of the newer initiatives, this is the last part of my presentation, is that we really want to strive and recognize organizations for the great work that they've done. Again, going back to the topics that Dr. Sandra Hyung has mentioned, we want to establish a criteria and process to really recognize healthcare organizations who exhibited exemplary commitment in pressure injury prevention and management, whether that's adoption of the standards, education, research, and engaging their members in a team to really have a culture of pressure injury prevention. And part of our invitation for some e-posters today is the first step of laying down this groundwork for us. So we really want to make sure that we push and really award people for the great job that they do. This is the carrot and stick portion, not the stick. The other thing that we are trying to work on, and I think this is again in response to an NSWAC who reached out to me not too long ago and asked me is, Josh, what is CPIAP doing in terms of advocating for people who develop pressure injuries but experience challenges with social determinants of health? So in response to this query, as a panel, what we want to embark on is to really acknowledge this and launch Pressure Map. And Pressure Map is an initiative to determine the gravity of this issue in Canada. We want to conduct an environmental scan and establish baseline data to help CPIAP best position ourselves in terms of advocacy. Now, our CPIAP treasurer, Jeremy Call, will be leading and spearheading this along with another subject matter expert and to render his experience and expertise in this particular matter. Now, I'm not going to go into further detail, but Dr. Joyce Black actually highlighted the importance of really doing a comprehensive multimodal approach in assessing people with darker skin tones. And I just love how sometimes the talks blend in. And I said, I don't have to talk much about this because Dr. Joyce Black already preached about it. But I think it's important for us to really advocate for having a health policy or even a strong standard that mandates the importance of not just inspecting skin, but allocating the need for other comprehensive assessment from palpation and utilizing and leveraging even technology. Because if we just say and recommend people to do certain things, at the end of the day, they may not even enact them in their healthcare setting. But having a stronger, much more teeth in terms of our mandate for health policy and also standards will push this initiative forward. Now, CPIAP will also want to embark on more of an educative approach. So next year, we're aiming to launch a couple of webinars in partnership with industry, with subject matter experts and other clinicians. In the next year, we're looking at about 3 to 4 pressure injury related talks. So stay put as we send some invites out, and hopefully that you can also partner with us. That can also highlight some of the incredible work that you are doing in your areas of practice. Now, going back to diverse skin tones, one of the grandiose idea that we have is to, again, as what you can see, Canada is highly diverse, right? We have several ethnic cultural groups and even our Indigenous peoples. And I think really it's time for us to really step up and also support our clinicians in identifying pressure injuries properly. So one of the things that we really want to set up a foundation is create some sort of database of pressure injury related photos representing different diverse skin tones of different stages that will enable the nurses or the healthcare providers at the point of care to appropriately identify and stage those pressure injuries. So this is going to be part of a much bigger initiative, but we would like to really set up some of the groundwork done. So we're going to do a feasibility review at the moment and set up some foundation and see how we can spring this initiative forward. Skip that one. Now, other initiatives that we have, of course, as what was discussed with Dr. Joyce Black's presentation, there was limited representation of education related to skin and even wounds, and even with pressure injuries. And I really want to acknowledge Dr. Sharon Gabison for spearheading this. She has developed, alongside some of the interprofessional teams, a curriculum that can be incorporated with post-secondary institutions. And CPIAP will be partnering with this incredible work to see how we can evaluate and adopt it in other institutions to ensure that there is representation in teaching and preparing healthcare students before they get out of the school to know what pressure injuries are. And as a matter of fact, like part of this initiative in action, we have sent invites to Carleton University, University of Ottawa, and Algonquin University to really invite their students and nursing students to attend. And I think it's important for us to immerse nursing students and even healthcare students to know the gravity of pressure injuries are before they even get shocked and have a heart attack at the bedside, and to know how important it is that every member of the team is crucial in the process. If we are going to mitigate and prevent this issue, everybody's hands will have to be on deck. I'm almost there, by the way. Last two of our initiatives revolves around ensuring that we have literature and publication available for our members to ensure that we can support their ongoing learning. And we will actually going to rely and to the expertise of Dr. Sharon Gabison, Dr. Kevin Wu, and Dr. Chester Ho in finding opportunities for us to partner in terms of research and utilize that as an approach to also guide and advocate and advise our members and also our clinicians and healthcare leaders across Canada. Now, as you can see, we have a lot of things at work here. Overwhelming slide. But CPIAP is really, really invested in the things that we do. And we are really on this thing for the duration of time to make sure that we press all these initiatives forward. Some of these initiatives are already been accomplished, but we're going to be working hard to make sure that we do this not for ourselves, but for the best interest of people that are suffering for pressure injuries. Now, if you would like to be a part of some of the working groups that we have established across here, please notify us and let us know. You can contact us at admin@cpiap.com. And again, we really want you to be involved. Your perspectives, your insights are very valuable, and it can influence the flow of our initiatives and even push things even further for us. Now, for my last slide here, I would like to ask a question to you. For anybody in the audience or anybody that's online, a raise of hand or even a thumbs up for those that are online, anybody who has not seen or even cared for a pressure injury. And I just want to confirm, because I'm not seeing anybody raising their hands on the audience. And that just tells me that you have seen, no matter what stage that is, how crucial it is to really understand the complexity of pressure injuries in terms of their healing, and not only that, the quality of life that it actually impacts because of having a pressure injury. So this is my call to you, to the people that are here today and the people that are online. Coming in here is great because you're showing commitment and you understand the cause and you really want to be a part of it. But it's one thing to actually have that proactiveness, but I want to take that step further by actually being involved. Does everybody have a phone here? Do we have cell phones? Anyone? So if you have a cell phone, if you are not yet a member, I encourage you to scan this QR code right now and be a member of CPIAP. Because again, every hand that we have on deck, every member of the team that we can bring in is another voice that will be a stronger voice that can push an initiative forward. It's good to have one person, but if we have an entire family that's devoted to one cause of making sure that we address the issues of pressure injury prevention and management across Canada, then I think we can make strides. We can ensure that this vision becomes a reality. And with that, I leave you be, and I do hope that this transparency in what we do give you more encouragement to be part of CPIAP. Thank you.
Also Dr. Ho and all the advisors for including the patient voice in everything that you do. And not only do we have Luz on the board of directors now, but we also have a very special guest speaker here this morning. I would like to introduce to you Mr. Bob Brown, who was born and raised and has always lived in Ottawa and area. He is educated. He lives a very full life, which you're going to see in his story. He has to incorporate pressure injury prevention and management in his everyday life. And he is someone who really applauds all of you for what you do on a day-to-day basis so that he can live his life. And so now I would like to turn things over to Bob so that you can see who is Bob Brown and what is this life that he's living. And it's really interesting.
I'm just gonna, it's just a bit of a talk how I, as a kid grew up, and a little quick bio, just it's, you guys know how to treat wounds and stuff, so I don't have to go into that, I don't think. But anyway, it just tell a little bit about my life and stuff, activities and where we are. As Kathy said, I was born in Ottawa. I'm 71 years of age. I've been in a wheelchair for 53 years. My mother's side of the family had deep roots in Ottawa from the old, if people from the Ottawa area at all, they know the old log farm, which was a heritage site, from the ways of the past, still used, and used these days. It operated the same way. I grew up in the west end of Ottawa, so this is a long time ago, so Ottawa's quite different now. The only exposure I ever had to French was the kid behind me in West End, Ottawa. His name was Beauregard, and that's about as close as he ever got to French. So that gives you an idea of my French. Anyway, being in Ottawa, um, as a kid, we had a family cottage, so I developed a love for water. I've always had a love for water. Anyway, everything from boating, water skiing, what else? You know, different kinds of sport, downhill skiing. Um, yeah, just what else was I going to say about that? uh, Wrestling team, track and field, just working out at the gym, just active, and was that kind of person. Um, I had when I was a teenager, I had a paper route on a a lake kind of thing. So that was always good. People wanted with a cottage. There was rural, so they didn't they'd get a paper. The tips were good, so I saved up my money and bought a snow machine. Like it was well, I raced just the local local little community things on a snowmobile, but I bought a year old last year's um, uh, it was a motor ski top fuel snow machine. Like I don't know how many people are involved or even know, but it was high performance. You couldn't buy it, at a store. It was a factory team. In fact, I actually raced 3 classes above Gilles Villeneuve back, you know, well, this is a long time before he passed away, of course. But he was three classes down from me. So I was the youngest person racing E-modified in Canada and the United States. So I probably, if I hadn't got hurt, I probably wouldn't end up Formula One at some time as well. Just the adrenaline junkie in me is still alive and well. Anyway, I'll skip that. Just hang on. Sorry. Yep, that's good. So I did that for about a year and a half, and of course, as a 15-year-old, 16-year-old, you run out of money, especially racing up the big boys then. Um, I was injured in a car accident when I was 18 years old, just driving home, going to the cottage, after work. Nothing glamorous, it wasn't coming out of a ball of fire out of a plane or a snowmobile, which, anyway. But it was a C4-5 quadriplegic. Um, I did my rehab here in Ottawa. I was the second person to go through uh, the it was the just been renovated. It used to be the old Royal Ottawa Hospital. They converted it to the fifth floor to rehab. So I was the second quadriplegic to go through rehab in Ottawa. My alternatives would have been to Lyndhurst or to Montreal, back in, this is a long time ago. So, it was just starting. Um, of course, it's now, was moved from there to the just right behind the Ottawa General Hospital, and it's going to be included when the new hospital is finished, at Woody's Bay. I was always, became, was an advocate, an advocate or became an advocate in disability rights and issues. In fact, the reason I stayed in the hospital so long was about 11 months. Sorry. And just because there was no housing in those days, you go through rehab and then what? There's nothing to go to. So I mean, it's down less than 3 months now, usually for most people. So anyway, the chair of the hospital at the time got three of us to work together to come up with a kind of a housing symposium. And we had kind of like this, I think we had a few more people though, maybe not online, but in those days, so we came up with three or four different models, and they're still used to this day, like sharing an attendant, amongst about 13 people. It's now direct funding, which I'm still on. I've been on it for 28 years, I think. And so you hire and fire your own, well, hopefully not, but yeah, but you get, you take care instead of, hiring agencies, and you tend to hopefully get the person you want and compatible and things like that, it works out for you. And then also it gives you your independence as well too. And so that's kind of where that started. We worked with three students at I forget the program. It was so long ago, but they facilitated conferences like this, and did up reports, and so that's how that kind of got started. The housing model, and it's still in place today. Uh, um, um, sorry. I after I finished rehab, I went back to school and business admin and arts and science. Um, it also began my advocacy in the community. So I've uh, just grab my advocacy in transportation, human rights, and systemic disability issues. Um, Facilitated. Well, I was on different consumer organizations from the municipal. This is around the International Year of the Disabled. I think it was 1980. And uh, just where did I was going with this? Okay. So I served at the local area, then we organized provincially and then federally. Joined the National Organization for Cross Disability Organizations. Um, from there, we kind of worked on everything. The charter was involved with the Section 50 of the charter to include persons with disabilities as a a group, a recognized group under the charter, and that was the only other group that was uh, what you would call it, but the only other group that was recognized under the charter at that time when it came into play. Did lots of lobbying and all the fun stuff. Um, I've pursued a number of you know compl complaints, for example, like transportation and housing, and transportation is a big issue for people. If you don't have transportation and housing for a person with disabilities trying to be independent in the community, it's tough. So when I was first hurt, there was no such thing as paratranspo or paratransit and the housing. So that's worked on getting the housing or the transportation as well going. So we actually got the paratransit going in Ottawa. Um, then you kind of have to be a resident of Ottawa, know about the transit ways, and we have the light rail transit, but for example, they didn't allow vehicles to use the transitway, but there was City of Ottawa bus. So it took some legal work, and we got it. We got the buses onto the transitway, which is kind of stupid in my opinion. But anyway, but real life problems. Um, I've gone to court with the National Capital Commission, with the federal government, right to the Supreme Court. Um, it actually changed the law to the way it is now. They're teaching it in disability studies. The case, I argued my own case. My own lawyers, they were bringing people down to see how it's done. But I did have a bit of a background in not so much courtroom, but because I did work for I did work for National Transportation Agency, which is a tribunal, and so a little bit of legal background, I guess, that way. But one of I think my best cases, or got the best number of people benefit for, was an out of court settlement with the city of Gatineau. They were buying, they were using, this is when low floor buses were just kind of starting coming out. Now every bus is low floor, but they were having troubles with the ramps so they just locked it down. So I took them to file a human rights complaint, and it went on and on and on, back and forth. But finally, it was just ready to come to court. And so they got, I guess they found religion or whatever and decided to, now the court settlement was probably the better way to go. But not just because Gatineau, they bought buses from all, with Montreal, all Quebec City, all the different places. So I basically got a lot of the buses at the time, with low floors. They had to use them. I mean, now everybody, they don't even make the other kind. But at the time, that was a real problem. You couldn't travel in Quebec, if you used a wheelchair. Sorry, one sec. Began professional, yeah. I started my career at a couple of different departments, foreign affairs in Canada, so I had a bit of exposure there. I did mention, then I went to Transport Canada because my love for transport. That was not quite true, but anyway, I picked up on it, and then from there, I started in a couple of different capacities, moved around, got some skills. Then went to research and development, and that's the kind of work I just love. I do it for free. Anyway, then I went to the National Transportation Agency, which was the tribunal I spoke about. It's now called the Canadian Transportation Agency, and I even had a couple of complaints and things like that there, like ground transportation from the airports to get into the city. Most people just jumped in a cab. Well, that didn't exist then. Or, you can do that now. One sec. Yeah, I get rid of that. I'm trying to speed it up a little bit because I know we were a little behind. I mentioned about housing, so I did switch to direct funding, hiring my own staff. This is kind of like what my typical kind of day would look like. I'd get up like 5:30 or 6, get someone to come in, get dressed, shower, get out and get a low floor bus or a paratransport at the time, depending where I was going, back in the early days. Not that many years after I mentioned I was in sports, so I used to play murder ball. I know some of you may know it or not, but they've since changed the name to wheelchair rugby. But before that, I was playing, with the paras and amputees, basketball. So they had to go over you, around you, or through you. So I was the block, basically. So anyway, but we got a sport that was a demonstration sport for wheelchair rugby, or it was called murder ball again, time, and but one of the guys I flew down. That was this just stuff back. Doesn't. But anyway, I had just quit smoking, so I was putting $1 a day. If you could afford $1 a day to put in. So I funded myself to go down and to Toronto to see the sport. So anyway, one of the guys that volunteered to pick me up was a guy, a quadriplegic, driving his own van. And being, mechanically minded and mechanical aptitude, well, this is easy. I mean, I looked around. So I built the first wheelchair accessible van that you could drive, in Ottawa. There was no fabricators around at that time. And so it took a few months. I had a couple of contractors that were do this part, and suspension. Like I love that stuff. Anyway, the idea. Where are we here? Yeah. See, the guy told me, I forgot his name, but it's too bad. But he did tell me, don't be afraid to bend metal. Make in fabricating, put heat to something. In fact, my brake pedal, and because it was all hand controls, built them. It was a tire iron, and I just welded it on, bent it into shape. In other words, make it fit you. Don't worry about you got to find the right one or adapt yourself to it. Adapt it to you, and that was kind of a bit of advice that kind of stayed with me for a long time. Well, I still use it. Yeah. The skin management for quadriplegics. In the recent, I didn't have too many when I was younger. Again, I was 18. Didn't have too many skin management. It's only the last 15 years of getting a little older. I've been finding more things. I was really impressed with this, the previous, presentation about pressure sores, like the heels. It makes perfect sense. I just was saying I got to get one of those lights. And I'll talk probably later. I guess we have it in the presentation this afternoon, but gave me a few ideas as well too. Um, pressure sores. I've had pressure sores on heels, the back of the calves, the butt. The expression "protect your butt" has a big meaning for me. And most other quads. I think, as I'm sure most people in the room, probably have, dealt with people who've, had, well, we saw that before, pressure sores on the rear end. No, skip that. Yeah. Um, every small position or a new equipment adjustment, because you don't feel it, so you don't know if it's gonna, making pressure or it's going to cause, because it happens fast. One day, and it's I've had the tendon in the back of the leg. I'd put a strap on. The next day, it was right down to the tendon. Just instant. So it's I heard, like, what was it, 24 or 72 hours surgery? Nah. The if you have to go in an ambulance or something like that, get me off this gurney kind of thing onto a real bed, and I would go as far as to say to this group, advocate for having air mattresses, when wherever you are, at least to get off. Even just a bed is not good. I switched from, well, actually, even right now, this summer was a hot and humid summer, and it wasn't so much pressure, but the humidity and the heat that I had a skin breakdown, and actually I'm still dealing with it, but get the pressure off of it, but it's closing up fine, but so heat and humidity is one of the things. It's not just, pressure, but it basically worked out that way. I switched from a couple of years ago. I switched from because a Rojo cushion. I mean, here's where you get the innovation. Like a Rojo, I just learned to collapse cells where there was this pressure spot, things like that. Elastics go a long way. Yeah. So anyway, but now I've been using a memory foam cushion with the kind of the center. I just sit around the edges, and but I was talking to one of your colleagues here, and but one of my ideas, it needs to be vented, like some kind of a fan, which would not be hard to build. So I may go and talk about that or something in future. Uh, I mean, it's real life, problems. Necessity is the mother of invention. So watch for this new product. I've always, for example, for wound care, used a water bed ever since I graduated or got out of rehab. Um, and like I could stay three days, flat on my back, and without being turned and things like that. So I stayed with it. If it's not broken, don't fix it. You know. Um, Pressure sores, can come along at any time, and disrupt your whole life. Um, um, Here's another part I want to go into. If it's on your if you're down, well, you're probably going to be home, but like a lot of times it's not always on your butt. It could be on legs or heels. So I was active and working and things like that, or I'd have to go home, get a wound care nurse to come in to dress them and things like that, especially the heels. Um, or but it was easier to do it in the bed. And one of the kind of where I'm going to be going is now and this afternoon is time management. Like you need to living independently in the community. I have to manage not just the wound care nurse coming in at a certain time because I live at home and independently, and but also because the wound care nurse doesn't transfer you into bed and stuff, then I have to coordinate at a certain time, for an attendant to come in to get me in at the same time and put me back in. So, one of the things that I'm going to be leaving you with is, thoughts for, in the community at least, is that, like the time management, like be on time. If give me an idea so I can get the other person, because if they miss, there goes my wound care, and I guess that's pretty much about it. I can leave. I got a few more things here, just real quick. Oh yeah, of course, yeah. Pressure sores. Obviously, I can't go scuba diving, which I am an avid. Been doing scuba diving since 2007 now. Um, um,
Oh, let's
oh,
show them,
what?
Bob. Let's show them.
Oh, okay. Yeah, here. We got a video. It's just down in Bon Air. It's actually Kathy's brother.
Right. Yep.
Yeah, heads over heels. Right. I was down there this year and 28 dives then.
Avec qui? Avec Bob.
Oh, it's just blah, blah, blah. But anyway, like you literally go head first off the dog, you know, and well, it's the easiest way. I mean, you may have to clear your mask a little bit, but you know, and see just another diver with the. I thought we had some of the deeper dives there. Yeah, here we go. This is you know, it's just beautiful down there. You know. I think we've got another one. Yeah, this is just on the St. Lawrence here. We dive have a club that we dive with, and that's on the dive boat. Yeah. Okay. Anyway, but again, just a little more background on just on myself. I use a BiPAP. I broke my leg a couple of years ago, and so I'm not able to lie on my left side because I've still got hardware on the inside, and it would start breaking down from the inside. So I can't lie on that unless I want to go get hardware out. So I usually sleep on my back or my right side because of that. Um, I'm su I'm sure most people here have ever, know somebody with a pressure sore at some point in time. Um, I find the main cause for pressure, the cushions will go flat. Rojos are famous for that. That's why I finally went to a memory foam cushion, and I love it. It's working fine for me. Again, the key message is not everybody is laying in bed. They may have a life or doing other things, so they're not just waiting for the wound care to come in there. There's other things that to do. So the time management is the most critical and important. If attendants and medical staff don't arrive together, it cannot occur. And I'm just about done. Many wheelchair users live independent lives independently in the community, not just institutions and stuff. And I was listening this morning, it sounded more like institutional, but there's tons of people living in the community, living independent lives alone. And we see that especially now. And I think this is the message that we'd want to bring to you, and especially governments. They're trying to get people out in the community, whether it's bed block or just for whatever reason, into the community. And it's the community based. I think, in my mind, is where how does this fit in to this group, as opposed to just the institutional, you know. So there's probably just an idea, suggestion to work on it, think along those lines, the people living in the community. Hospitals, well, that's another thing. But well, I think any questions or yeah. Oh, sorry. It could be on that or anything else.
Well, it'll be on this. So did you get any pressure injury prevention education along the way, or was it when you had a pressure injury that then you started? Then people told you how to prevent pressure injuries.
Yeah. Well,
that's sad.
Once you start getting them, you start to, what should I be doing? What am I doing wrong? Yeah. I never really had much problems early before. I'm not sure just skin maybe getting a little thinner. I don't know. Yeah. So, but I think it would have helped. Well, I mean, I did know it. I've had, like as I did say, collapse, row cushion stuff, and some people say do it, and other people did. It worked for me, so I did it. There was another question.
Hi, thank you very much for your presentation.
Ah.
My name is Gigi Vandenhoeven. I am a nurse in independent practice. I'm also the executive director of the Canadian Association of Self-Employed Regulated Nurses, and we're part of the Canadian Nurses Association. One of the things is that I do work, and there are other nurses that work in independent practice in the community. My question to you is with regards to your benefits as a federal retiree. Has anybody explained that you have up to $20,000 of private nursing insurance?
No, but in an answer, no, but I don't. I do have. There's still with the SLUs and with the LINs. I do have a nurse come in once, at least still, not necessarily for pressure sores, but with catheter chains and things like that. So, but that's under the SLU. So,
Yeah, so there are these benefits as well, and some of the things of the advocacy work of nurses in independent practice is to explain that there is this insurance that people do have. And one of the gaps is the knowledge, that knowledge translation. Often we talk about hospitalization, and a lot of the care is about in the hospital or in the retirement home or long-term care homes. But there are many people that are working out in independent practice, and some of the people have insurance for private nursing care. And so on Monday or Tuesday, along Canadian Association of Self-Employed Regulated Nurses, myself and the Canadian Nurses Association will be talking with the federal government MPs to do advocacy work. And this will be one of the things that we will push that along. So nurses will be able to talk about the nursing questionnaire so the people don't have to go through hoops to get it signed off by physicians. So one thing to put in your toolbox is that you have that available.
but one thing I was really impressed with this morning was that light for the imaging. I think that could be too bad they're a little expensive. I wouldn't mind having one at home, but there's got to be a way or reducing, re-engineering it. I don't know the technology behind it or anything, but I'm going to try and find out and have a look at it because that could save me a lot of grief over the years.
Joshua, I think Lee had a question.
Thank you. So my question is, what kind of advice would you give to maybe a younger version of yourself that still wants to maintain that active lifestyle, but also has a serious wound injury in his buttocks? Now, often as clinicians, that's where we have difficulties in the community to kind of sort of not only gather information, but to just kind of comply to the plan of care. Thank you.
You say, I'm thinking you're referring to some specific, I don't know any, I just guess, it's a wild guess here, but some people they just don't want to listen to it's tough, I mean, you have a life, and we saw that this morning a little bit, like on one of the slides. I mean, I could have gone down, but the other trade-off to that is, being down is, you want your lungs to start filling up, and it's kind of that kind of thing. So a long time in flat in bed, it's which is the worst of the two evils, um, you may save the wound, but you get the patient doesn't live, from pneumonia or something, and which is and I when I first went through rehab, in traction and with the broken neck, the last place I ever want to spend a lot of time again is in bed. I know it's a tough thing, but I mean but innovate though too. Like if it's just one spot or a couple of spots, I would if it's just a new or it hasn't progressed too badly, like on a rojo cushion, fold the cells in half and do them all up and it takes the pressure off at least that point. and it did work for me. This cushion I have, I'm over to one side because there's no pressure. The only pressure on it is the little tensile strength of just the cover of the cushion. I heard 10 or 15 pounds this morning. I don't think there's not even that much, pressure on it.
Thank you so much, Bob. I just want to highlight there's been a lot of love online
Oh.
and a lot of thanks and clinicians saying how inspiring your messages are. So thank you so much for that.
My pleasure.
And we do have one last question in the back.
Yeah, and after Dr. Sibbald also has a.
Yeah, last two questions then.
It's more of a comment. I first want to say I'm in perfect awe of you. I applaud you for being out there and for sharing your story, but equally to being the strong advocate you have for a patient population that is often not in the good position where you're at. You've created change, and I applaud you. Lastly, I would say I echo what you say. The thermography is, if we can get that to a place where technology is more readily available from a price point and accessibility, it's a game changer. So I'm looking to you, Bob, to create something innovative so that technology can be available to everybody just like a cup of tea.
I'm retired. I mean, I'm not, but I agree. Like that to me just sounded like, holy geez, I wish I had that, or at least get access to it fairly readily.
We have one last question, Dr.
Yeah,
Sibbald.
Bob, we had a long discussion last night, and thermometry and the type of thermometry that Joyce was talking about is very sophisticated, and it's around $2,000, and it's not so easy to use. There are infrared thermometers that we've been using for infection that you can get on sale at Canadian Tire for $30. And combined with two other signs of infection, really are 8 times more likely to identify a deep and surrounding infection, unequal vascular supply, or repetitive trauma in an area. And, patients with neuropathy have used this in 3 random controlled trials. And if it was 4 degrees warmer in one spot and they decreased activities, they prevented ulcers. So, and I think I've got some of those thermometers here. I could probably give you one.
Well, let's talk.
Okay.
And other people, there are toolkits. Anybody in Ontario or anybody in Indigenous ECHO, if you do the skills, and we'll be going around the province and doing skills, the toolkits contain an 8 megahertz Doppler infrared thermometers and a simpler way to do screening. And we do have a booth here, but it is something that really could improve practice.
I think that's a game changer for me, but
I'll talk to you.
Okay. So anyway, on behalf of CPIAP, we'd like to thank you, Bob, for sharing your story and telling us about your life. And now we know who Bob Brown is.
I don't know where to go.
And, here's a little something for you to cozy up in.
Thanks, Bob. Thank you, everyone.
So at this time, I'm going to introduce Dr. Kimberly LeBlanc, who's just going to say a few words on behalf of the Canadian Nurses Association.
Going up the shortcut. So just want to bring welcomes from the Canadian Nurses Association. It's been an honor and a privilege the last couple of years to be your president. And, one of the great things that I have the opportunity to do in my role, not only am I getting the opportunity to represent 500,000 nurses across this country, but it's also to remind all of the nurses in the room that we are 500,000 strong. We have a voice. We can use that voice to bring influence, to work with our patient, partners, to work with other partners, to raise our voice. And, I have the privilege as well, whenever I get to speak to politicians or on the national stage, they say what I do for a living, and I get to talk about wound ostomy incontinence issues and pressure injuries. And just quickly, finally, the last big privilege is I get to sit on a task force for disability without poverty. And the work that's being done by these advocates in the community is phenomenal. So as nurses and physicians, OTs, PTs, dietitians, all the different people we have in this room, get out, get involved, support our advocates to do their work, because they do need our voices to help them but keep them at the forefront. So on behalf of the CNA, congratulations on such a great event, Josh. It's great, and looking for the rest of the sessions.
Thank you. So at this time, I'd like to introduce Janet Villandia, Caitlin Vingo, Khalil Mitchell, and Lisa Fan, who will be speaking about From Evidence to Action, Unity Health Toronto's journey in pressure injury prevention.
Hi, everyone. Everyone can hear me okay?
Can hear you loud and clear, Caitlin.
Fantastic. And just a housekeeping item. You'll see us as we're going through the slides. We're going to be changing over presenters. So there'll be a slight delay as we go between people, but you won't hear us say next, next, next. So hopefully that's preferable. So hello, bonjour. First off, I want to say thank you to Mr. Bob Brown for that impactful presentation. And on behalf of myself and my colleagues, it's a pleasure to be joining you all today virtually from Toronto, Ontario. We are honored to be here sharing Unity Health Toronto's journey in pressure injury prevention from evidence to action. Okay, here's our first test if the slides are going to work the way that I want them to. Oh, not quite. There we go. Okay, so I'm Caitlin Bingo. I'm the Senior Director of Practice Informatics and Chief Practice Informatics Officer here at Unity Health Toronto. And I'm joined by my colleagues, Janet Valendia, Nurse Practitioner with Unity Health Toronto's Wound Care Team, Lisa Fan, Manager of Nursing Practice, and Khalil Mitchell, Project Manager. So today you'll hear from all of us on our journey from evidence into action for pressure injury prevention. And in hearing from our different perspectives from clinical, leadership, strategy, data, you'll gain some ideas and hopefully pearls of wisdom that you can leverage in your own journeys to shift mindsets and transform culture. So let's get into what we're going to talk about. There we go. So for today, in our presentation, we're going to cover our governance structure. This is the foundation we have in place to advance changes and best practice in a large multi-site organization that is geographically spread out across the Greater Toronto Area. And we're also going to get into different examples on how we translated best practice guidelines into measurable practice change, and how we took a guideline hundreds of pages long and made parts of that actionable for us. We're going to talk about how we sustain that change, and finally, in how applying a project management approach to our pressure injury strategy has been part of our secret sauce or key to success. Typically, projects have a clear start and end, and pressure injury prevention is not that. Pressure injury prevention is a perennial focus in healthcare. We can't ever kind of take our foot off the gas here. But in applying project management techniques on a clinical strategic priority, we've been able to sustain measurable change. So we're going to get into some details about that as well. So first, let me tell you a little bit about Unity Health Toronto. Unity Health Toronto is Canada's largest Catholic healthcare network. We are located across the Greater Toronto Area with St. Joseph's Health Centre, a community teaching hospital in Toronto's West End. We have St. Michael's Hospital, an academic and research hospital in the downtown core, and Providence Healthcare, a rehabilitative and long-term care centre in Toronto's East End. So in short, we provide care across the city and across the care continuum. An important thing about Unity Health is our amalgamation is actually rather new, particularly on the clinical side of the house. And this factors into our pressure injury prevention journey, as when we started this work, we were really bringing together 3 different sites, 3 different legacies of pressure injury prevention, and different areas of opportunity, resourcing, staffing, all sorts of things. And so this is really a story about coming together towards one goal, and hopefully something that resonates, as I'm sure many of you work across large geographies or with different sites or different areas. So I'm going to get into our governance structure as a starting point. So as I mentioned, this is really our foundation. Ultimately, it's a committee. But what makes it different from the many hours that I spend in meetings is that we've really enabled this group as a foundation for strategic decision-making. And this has been key to ensuring that voices throughout our healthcare network, from direct care clinicians and technicians to patients and patient and family partners, managers, senior leaders, executives, have a shared and equivalent voice and represent and appreciate that they also need to be the voice of their peers. And so this is really not just let's get together and have a meeting, but it's really about empowered decision making. And so you see our principles here on the screen, which is that we're evidence-based, we're focused on first and foremost patient safety data and safe patient care. We leverage data to make informed decisions, and we are aligned with Accreditation Canada. Oh, I went too far. Back up one. And I wanted to show you here how we really anchored this within our clinical governance model. So you see in the red there, Pressure Injury Prevention Steering Committee. And ultimately, that Pressure Injury Steering Committee and those folks I just talked about, they are accountable up to our executive and our board of directors. And we report regularly and have kind of bidirectional communication. And it's been really important to anchor our approach in a structure that supports decision-making and prioritization. This has been really important given the number of priorities that clinicians, physicians, leaders, patient family partners, managers have on their to-do list every day. So to have success, you need to be able to obtain the resources, whether that be human resources, financial resources, time, equipment, surfaces, to do that work. And anchoring this group within a strong governance structure that allows us to pull and push for the resources we need has been critical. It's not enough to be committed or interested, although that is certainly important. You need to have that teeth. You need to be able to push for change. And this structure has allowed us to do that. So I think my point here is really setting up for success is critical. Multiple voices at the table, also critical. Okay, so what you see here is what we're going to get into the details next. This is our multi-year timeline, and it's breaking down the steps we took to take guidelines and move them into action. And so we'll be walking through these different buckets of work over the next 30 minutes or so. Up next, you'll hear about our needs assessment tool. This was our systematic approach on identifying which evidence-based practices to address first, which gaps to address first. We'll get into the recommendations we put in place, how we've implemented them, and really how we're sustaining and growing. And lastly, as a nurse informatician myself, I would be remiss not to talk about how we use data to create actionable insights. So what you see on the screen here is just some of our internal data sources that we use to keep us on track. So we leverage patient safety data through incident reporting, and we report that transparently through our quality improvement plan. We have our needs assessment tool, which has really just been a treasure trove of qualitative insights on the experience and needs of our clinical teams. And finally, we use our electronic patient care record to monitor real-time data from clinical documentation and how we're doing and have a kind of continuous pulse on what's happening. So now I will hand it over to my colleague, Janet. And you're going to see that switch over in action. So hopefully it's smooth.
Finally. I wasn't able to unmute the system. I was just moving buttons. Okay, perfect. Thank you, Kaylin. And hi, everyone. With the committee structure and partnership in place, our next step was to move from theory to practice, translating the best practice guidelines into a framework. Okay, let's try again. So next, there you go. Okay, 3 hospitals, 1 network, and 1 pressure injury committee, all working together with a single goal to prevent hospital-acquired pressure injuries. As Kaylin mentioned, at Unity Health Toronto, we are fortunate to have the support of a committee that represents interdisciplinary collaboration. Our committee includes leaders and clinicians from across multiple disciplines, managers, the clinical equipment department, safety first, physicians, occupational therapists, physiotherapists, dietitians, nurses, the wound care team, and patient and family representatives. To build a strong foundation for our program, we begin by reviewing the evidence and most current best practice guidelines. After a careful review, we selected the 2019 International Guideline for the Prevention and Treatment of Pressure Injuries. This guideline provided the structure we needed to ensure consistency, standardization, and alignment in pressure injury prevention across the 3 hospitals. The 2019 guidelines highlight that quality indicators are essential for evaluating and improving the care that we provide. These indicators help determine whether our practice reflects best practice, and meet the needs of patients and families. The committee adopted these indicators to anchor our cross-site pressure injury prevention framework. These indicators provided a common evidence-based structure to assess our progress across all 3 hospitals. So using the Donavadian's model for quality evaluation, which is a simple but powerful way to look at quality through 3 key components. So the first one, so it is a structure. What do we have in place? Our tools, equipment, and systems that support care. Then processes. How do we do things every day? How do we assess patient risk? How do we document? And how do we implement and deliver prevention and treatment plans? And finally, outcomes. Whether our work is making a difference. Are we reducing pressure injuries? Are we improving patient outcomes? So to bring this model to life, we created the needs assessment tool. So, or we called NAD for short. Specifically, the needs assessment tool help us to collect information in consistent and systematic way. So understand as well the current state of practice across the network, identify gaps and opportunities, and also, and most importantly, prioritize areas of action. So we organized the 2019 best practice guidelines quality indicators into 12 areas of focus, including organizational factors, risk assessment, education, health human resources and wound care teams, support services, nutrition, repositioning and early mobilization, heel pressure injury, moisture, medical device related pressure injuries, patient and family engagement, and measurements. Each area of focus included 2 key questions. So the first one, is this practice or process in place? And the second, is this being applied consistently in daily care? So we also developed the NAT instruction manual just to clarify the intent and the application of each indicator. So for data collection, we use a SurveyMonkey questionnaire based on the 12 areas of focus and their corresponding quality indicators from the needs assessment tool. Committee members from each hospital completed the survey and they gathered feedback from their interdisciplinary team. Once all responses were collected, we analyzed the data to identify similarities and gaps across the 3 hospitals. So from this analysis, 3 key priorities emerge. So assessment and communication, support surfaces, and measurements, which became the foundation for our next step towards standardization. To move from finding to implementation, 3 working groups were organized to address these critical areas of pressure injury prevention. The main purpose of the working groups was to review the full data that was provided in the needs assessment tool, as well to compare findings to best practice guidelines and to validate gaps with key stakeholders, and also to provide recommendations to the steering committee. So the assessment and communication working group focused on improving skin and risk assessment, enhancing documentation, and strengthening interdisciplinary communication. So this team worked in collaboration with the committee, frontline clinicians, and the EPR team, the EPIC team. The support services working group focused on standardizing access, use, and education related to therapeutic services to ensure appropriate offloading and pressure redistribution for high-risk patients. So clinicians such as OTs, PTs, and wound care team worked in collaboration with the clinical equipment department team. And the measurement working group review quality indicators, reporting system, and also how to track outcomes to evaluate the impact of interventions across the 3 sites. This team works in collaboration with the Safety First Department and the data analytic team. So using the working group's finding, our next step was to gather current state data to guide priorities and sustainability. To walk us through this next phase, like data collection, action plan, and sustainability, I will pass it over to Lisa.
Okay, so as we review the current state for the 3 areas of focus Janet had discussed earlier, our goal was to establish a clear understanding of where we're at in each of those 3 focuses to help us set priorities using data that is both strategic and achievable. And so sustaining this work also depended on us continuously monitoring progress in each area. So assessment and communication. So during the time period of 3 sites coming together, local units across the sites had existing visual identifiers. However, they were either in various visual methods such as magnet stickers or even none to identify patients at risk. And identifiers were inconsistently applied and also had different meanings across the units. And so this created variability in assessment and communication. And so to address these gaps, as part of the future planning with EPR, there was a development of a harmonized visual identifier, as you can see here, enabling a clear, consistent, reliable identification for those with a brain score of 18 or less. In our second area of focus, this was definitely a partnership between clinical and operations. There was a variation in risk assessment and surface selection. And so a unified decision tree for risk assessment was created to support standardization with a visual guide to support local units to identify correct surfaces. And in terms of operations, as a result from our support surfaces working group, there were certainly gaps identified in several key areas, including human resources, process for maintenance, replacement, procurement, and inventory tracking. And this led to a creation of a clinical equipment department across UHT. In our third area of focus measurement, across the 3 sites, again, there were very much variation in reporting practices for pressure injuries, including what is reported, who reported it, how and whether reports are being validated, differences in staging criteria, and the degree of the wound care team involvement in the data entry and validation. And so to promote consistency and accuracy, standardization was implemented across the following areas. Definition. So it was defining what is a hospital-acquired pressure injury, reporting timelines, so when to report, clearly identifying roles and responsibilities for those involved in PIP management, and anchoring to our safety incident reporting as a source of truth for HAPI data, and data verification, so who and how the data of HAPI was being reported and verified. And so what is next for us at Unity? So one, we're in the process of actually developing a network-wide pressure injury prevention education for 12 plus clinical roles anchoring to the guidelines. Second, it's bringing the voice of patients to the forefront and further enhancing our patient-facing materials to reflect the voices of our clinicians and those of our patients and family partners. And so as we continue to focus one area at a time in our journey, beyond this includes future focus of nutrition, mobilization, heel pressure injury, further examining our organizational factors, moisture, medical device pressure injuries, and our wound care team health human resources. So here are some practical ways in our day-to-day work with our steering pressure injury committee to build momentum. So one, we begin meetings by sharing our committee's overarching purpose, really highlighting recent achievements and milestones to reinforce the impact that it happens, be able to share patient, staff, or system positive outcomes from the committee's work to make our contributions feel very tangible. Second is to continue the momentum through our working groups between our steering committees, and to assign and tackle very specific issues and be able to report back to our pressure injury committee. Third, it's regularly revisiting our strategic priorities to make sure that those are aligned organizationally, and often reviewing data to review, measure, and drive progress. And four, really show visible progress, support ownership in the issues, and demonstrate real impact. Thank you, as I'll hand this over to Khalil to discuss project management.
Thank you, Lisa. Hi, everyone. I'm going to walk through the importance of project management in the evidence to action journey of the Unity Health Toronto Pressure Injury Prevention Steering Committee. So when the Pressure Injury Prevention Steering Committee was launched, they requested a project planning approach, which is broken into 6 domains to guide the development of their work. The work scope and deliverables were identified to get a clear picture of what they wanted to achieve. We then started our planning in collaboration with the steering committee leads and members. We started to execute the work, which included the needs assessment, development, and launch of working groups. The next was monitoring the work that was executed, and that was done through the steering committee and the working groups. We then, in terms of closure, once deliverables were achieved, they were then presented to the steering committee and the impacted stakeholders. So things were achieved. Once things were achieved, we put them into the sustainability phase that required ongoing reporting and tracking and monitoring. So we didn't lose track of those achieved items. So Caitlin had previously reviewed this multi-year timeline, but I wanted to talk about it again because it's important to highlight the fact that a multi-year approach was needed to make this work achievable. So the steering committee was launched in May 2022, and their focus at that time was to review the evidence. The next phase was the needs assessment development, interdisciplinary stakeholder engagement, refining results, reviewing, and analysis, and that took place between June 2022 to January 2023. Recommendations was the next phase. And so the working groups that were chosen and established based on prioritized areas of focus. And these working groups were the assessment and communication, measurement, and support services working groups. The focus at that time was on stakeholder engagement and making the recommendations, developing recommendations to address the identified gaps. And that occurred between May to December 2023. In terms of implementation, that took place between January and November 2024. And so the committee worked to implement the working group recommendations while also ensuring the recommendations were included in the new EPR, which was launched in November 2024. The new EPR was launched to align clinical documentation across all 3 sites at Unity Health. Our sustainability phase is underway. So from December 2024 to present, we are establishing new working groups. Our current working group is education, and we're also looking at our data governance, continuous improvement, quality improvement plan, and ongoing reporting from our previous working group stakeholders to the steering committee. So in terms of the project strategy, we really needed to focus on a lot of communication. And that was the biggest driver to make the work, to make things happen. And it was really important throughout the project. So we had a clear project scope and goals, and that became clearer with the needs assessment. And then also focused on 3 out of the 12 areas of focus just to make things manageable. We also focused on stakeholder engagement and management through identifying the right interdisciplinary stakeholders, engaging them and maintaining those relationships. This was very important because these stakeholders are subject matter experts and they play a very important role in operationalizing change. To track the volume of work underway, a work plan with clear timelines help to guide and keep us on track. The work plan aligns with our organizational goals, our fiscal year, large corporate rollouts, example, the new EPR, which I previously mentioned, as well as our quality improvement plan timelines. We utilized an iterative approach for our task completion using a create, test, and refine approach. For work plan tracking, we really wanted to identify clearly where is the work coming from. And so we identified 4 areas for work plan sources of work. So we have our corporate drivers, including our quality improvement plan, as well as accreditation standards. Clinical drivers, our steering committee, working groups, incident reports. Our operational drivers, our clinical equipment department, as well as our clinical programs. And technology and innovation includes our EPR documentation, EPR data, as well as projects from different stakeholders in the organization. Example, clinical units leading quality improvement projects focused on pressure injury prevention. At the beginning of the project phase, the steering committee identified goals that they wanted to achieve. And it's very important to highlight the achievements of the working group to ensure that it aligns with the overall strategy and plans. So I'd like to highlight 3 goals achieved by the working groups. So for assessment and communication, they achieved a standardized risk and skin assessment process, now available in the EPR with automated prompts and care plan triggers, interprofessional communication of risks through standardized handover and visual identifiers, development of a harmonized Unity Health pressure injury prevention policy. For support services, the group developed a unified decision tree for therapeutic surface selection, created a process or processes for maintenance replacement and equipment availability across the sites. A new role for clinical equipment coordination is now in place at our rehab site, which aligns with the other sites. So in terms of measurement, we standardize our hospital-acquired pressure injury definitions. So we're anchoring to one definition. And then in terms of the incident reporting, we optimize an incident reporting tool as a required reporting and measurements system across the network. We also launch our EPR dashboard, which is now set up to track pressure injury prevention data trends, and that is now in place. So I'll now hand it over to Caitlin, who will talk about tracking progress and closing out the presentation.
Well, how about you keep control of the slides just for ease?
Yeah.
Okay, so I guess at the end of all that and the work, has it made a difference? I'm happy to share the following results that you'll see on the screen. Recall our areas of focus have been on assessment, therapeutic surface use, and measurement. So you can see our rates of improvement in those areas of focus, and it's been critical that we've maintained or improved our rates of screening and assessment and therapeutic surface usage, month over month as we shift focus to other domains such as staff and patient education. What you don't see on our screen is our pressure injury rates, and that's tied to our third metric of measurement. And as Lisa mentioned, we had focused intentionally on encouraging and democratizing reporting of pressure injuries at our organization. And so with an increase of focus on the importance of reporting and encouraging staff to report often and more, we've seen an impact on our pressure injury rates. And we look at that as a good thing, that in increasing reporting reflects greater awareness, transparency, and accountability. So I'm going to close up with a thank you and humbly recognize the numerous individuals who advance pressure injury prevention at UHT, because it's through the committed focus of many across different roles, we've been able to sustain momentum. And to highlight that, we're going to hand over just a quick video from our team.
At Unity Health Toronto, we are passionate about pressure injury prevention. A pressure injury, also known as a bed sore or pressure ulcer, is damage to the skin and underlying tissue caused by constant pressure, typically over bony areas like the tailbone or heels. In celebration of Worldwide Pressure Injury Prevention Day, we're delighted to present our interdisciplinary team and highlight how each individual contributes to prevention.
My name is Chanel. As a clinical nurse specialist on the wound care team, I help prevent pressure injuries by providing education to staff on all aspects of pressure injury prevention, assessment, and management.
My name is Russell. As a personal support worker, I help to prevent pressure injuries by assisting patients with repositioning and providing incontinence care to keep their skin clean and dry.
My name is Akish, and I'm a registered nurse. As a registered nurse, I help to prevent pressure injuries by performing head-to-toe assessment and determining my patient's risk level by completing the Baden scale every shift.
My name is Jillian. I'm a registered nurse. After identifying a patient at risk for developing a pressure injury, I then create a pressure injury prevention care plan that includes different interventions such as repositioning and including other team members.
My name is Jessica. As an occupational therapist, I help to prevent pressure injuries by ensuring my patients are on the appropriate therapeutic surface for optimal pressure redistribution and provide recommendations to minimize friction and shearing.
My name is Pruta. I'm a physiotherapist. One of the biggest ways we prevent pressure injuries is by keeping patients moving. I work with patients to improve their mobility, strength, and endurance so they can shift, walk, and move around and participate more in everyday life. I teach families exercises and movement habits they can use throughout the rehab.
My name is Tina Segovin. As a registered dietitian, I help to prevent pressure injuries by ensuring my patients receive adequate nutrition, especially protein, calories, fluid, as well as key vitamins, in order to maintain skin integrity and to support tissue repair.
My name is Magda Doran. As a clinical manager, I help to prevent pressure injuries by enforcing evidence-based pressure injury prevention policies, advocate for sufficient equipment, and implement and track quality improvement initiatives on my unit.
My name is Dr. Nayer. I help prevent pressure injuries by optimizing patients' overall health status and helping manage underlying medical conditions.
My name is Victor. As the operations leader for clinical equipment, I help to prevent pressure injuries by maintaining and distributing therapeutic surfaces and offloading devices to patients at high risk.
My name is Lauren. As a patient safety specialist, I help to prevent pressure injuries by monitoring safety trends and supporting the hospital in early identification and reporting of risks.
Together, we are Unity Health Toronto. Strong team, healthy skin.
All right, that was me. If that was a bit choppy on your end, we put the link in the chat. And I see some Unity colleagues on the screen, so happy to see colleagues here today as well. I think we have maybe 2 minutes for questions if folks have questions.
Yep, Unity Health. I'm going to ask actually people that are on the audience here if they do have any questions for Unity Health that they want to raise. Yep, there's a couple here. One second.
Hi, thank you guys for your talk. I have maybe one question with a follow-up, depending on what the answer is to the first one. What's your electronic record that you're working with?
Like our vendor?
Mm-hmm.
So our vendor is Epic.
Okay. Any suggestions for those of us not using Epic, using different electronic records in terms of trying to implement a marker of pressure injury risk within an electronic system?
Yeah. I'll take that one, team. Is that okay? So I think you can, like, agnostic of vendor, what we used, I would look to see in what tools you have available, or if you're using a paper record, what you can use as kind of a consistent visual flag. For us, it was like a big banner across the screen that everyone sees. So it's not an icon or like a flag per se. It's a big wording across the screen that identifies the patients at risk of pressure injuries, and then we put that in multiple places. So yeah, I think you can use that approach. That's kind of vendor agnostic, and we don't use an icon, one, because there wasn't a good icon to use, but also because we want to be clear to say, like, it truly says patient at risk for pressure injuries right across the screen for everyone that opens the chart.
Was there any question online that you'd like to flag before passing to Candy?
So I see, okay, so we talked about a visual identifier. So it's actually in our slides. So when we share those, I think we're sharing the slides or sharing the recording, you'll see it. And then what else? Is it mandatory? More about charting. Is it mandatory for staff to chart therapeutic surfaces? It's not mandatory. And I actually think that speaks to Khalil's point about communication and kind of getting everyone involved, because we're seeing those high rates of documentation despite not forcing people to do it. But what we have kind of anchored to is making that documentation flow seamlessly when folks are trying to document about skin and skincare. Janet, anything you want to add to that?
Yes, I want to add to the initial question that we were fortunate to work with the EPIC team when they were kind of standardizing what we wanted as part of the documentation. So our request was based on the policy that we wanted the skin assessment, breathing scale, and based on that, the score, if it was less than 18, then it will show that the patient is at high risk with the banner that Kaylin is describing. And at the same time, it will trigger the development of initiation of a prevention plan. So then we have the prevention plan, and the nurses will take based on the sub scores and select the prevention plan activities. Then they will implement and document. And the part of therapeutic surfaces, so if they have changed or switched the mattress, they will document the type of mattress that they are using.
Thanks, Janet, for that. We have one last question from the audience in the interest of time. Passing over to Candy.
Hi, thank you for that. I
I really loved how you had the different healthcare workers and clinicians talking about their role in pressure injury prevention. And I think that's probably, key for accountability and acknowledging how do we as healthcare clinicians prevent pressure injuries. And I think that needs to be more forefront and I think we need to push that further so that people are more accountable for their actions and how we prevent pressure injuries.
Thank you again. A round of applause for Unity Health on behalf of CPIAP. Thank you so much for sharing your journey and the strategic approach that you've done to ensure that the practices that you've implemented will become sustainable. And we have learned quite a lot of things from you, and hopefully we can adopt them in our own settings. Now, at this time, shifting gears, we're going to pass it over to Dr. Chester Ho and Dr. Sharon Gabison to talk about the National Pressure Injury recommendations to support policy change and make a big impact. Just want to introduce Dr. Chester Ho, who is a professor of physical medicine and rehabilitation and the inaugural spinal cord injury research endowed chair at the University of Alberta in Edmonton, Canada. He is also the facility medical director for the Glen Rose Rehabilitation Hospital in Edmonton, Canada, was trained in Cambridge University and Harvard Medical School, where he was a chief resident. He is a renowned clinical researcher with an interest in rehabilitation and delivering care for spinal cord injury. His special interest includes management of pressure injuries after a spinal cord injury and how to facilitate integration into clinical practice. He is also co-leading the Pressure Injury Prevention Committee in Alberta and a board member of the Canadian Pressure Injury Advisory Panel. He has published over 150 peer-reviewed papers in top rehabilitation journals and has received research funding from agencies including Canada Institute of Healthcare Research, U.S. Department of Veterans Affairs, Brain of Canada and Braun, and Craig H. Nielsen Foundation, and was awarded in 2021 the Champion of Change, and in 2023 the recipient of Chinese Canadian Legends Award, celebrating his achievements and contributions in the medical field. Now, Dr. Chester Ho will be shared with Dr. Sharon Gabison, who, as we are aware now, is president-elect of CPIAP. She is a assistant professor in the Department of Physical Therapy at the University of Toronto and an affiliate scientist in pressure injury and home care research at the Kite Research Institute, Toronto Rehab University Health Network. Now, part of her teaching at the University of Toronto, she focuses a lot in teaching future physical therapists on their role for wound prevention and management. Her research at Kite Research Institute is focused on the development and evaluation of tools and technologies to support individuals at risk of developing pressure injuries. Her goal is to equip individuals at risk of developing pressure injuries and the caregivers who support them with educational tools and technologies in order to reduce unnecessary pain and suffering. Over to Dr. Chester and Sharon.
Okay, just in case there's any confusion, I'm Sharon, Dr. Chester Ho, sitting down. So thank you so much for providing us the opportunity to come and speak today about the development of expert consensus recommendations for pressure injury prevention and management in Canada. And this is an initiative that's been led by Dr. Chester Ho, and I've been very privileged to be part of the ride. So thank you. And we also recognize that we're really what the thing is stopping you between our presentation and lunch. So we're going to be efficient in our presentation today. So hopefully by the end of today, you'll be able to appreciate the urgent need for Canadian pressure injury prevention and management white paper, and also appreciate and understand the steps that are required to develop a consensus on the development of a Canadian pressure injury prevention and management white paper, and also be familiar with the recommendations that will be included in the white paper. So before we begin, we just want to review some sort of standard or some basic definitions and understanding of what we mean by a white paper versus best practice guidelines and standards. So as you can appreciate, a best practice guidelines are really to provide recommendations or advice or best practices for pressure injury prevention and management, whereas standards are really there to establish mandatory requirements or specifications for pressure injury prevention and management. Versus a white paper being there more to inform, explain, or advocate for a particular approach or policy or solution to a problem. And the target audiences vary. There are overlap, but primarily the best practice guidelines have been designed for professionals, managers, and healthcare organizations and administrators, where standards are also for professionals and managers and healthcare organizations, where white papers really are things that we go and take to policymakers or organizational leaders or even investors or stakeholders and researchers and analysts to help advocate for change. I'll go through the examples later. I'll go through the adherence later, but there are some examples that we've put up here for guidelines and standards and white papers. And as you can see, there is no current existing white paper in Canada. And whereas there's differences in terms of the guidelines and standards and white paper, you can see that in terms of the best practice guidelines, they're really advisory and flexible and not necessarily strictly enforced, whereas standards are really more formal and compliance and maybe legally or contractually required, whereas white papers are really more of like a policy document and they're not necessarily enforceable. So across Canada, really, there is a lack of an adequate uniform standards and practices for pressure injury prevention and management. And this has been recognized by CPIAP. And what there is out there is quite variable in terms of the quality of care that individuals are receiving. And there's also health inequity, and we've already recognized that. Furthermore, we've already heard about the high costs of care related to pressure injuries. And there really is a pressing need to standardize and optimize pressure injury prevention and management in order to improve care for individuals who need it, ensure health equity, and also to reduce the costs. And really, as Dr. Joyce Black likes to say, the unnecessary pain and suffering. And so effective change is required, and it really must incorporate policies, practice guidelines, and also a readiness to change and appropriate resources. And so a Canadian pressure injury prevention and management white paper will really serve as a foundational document that will help influence policy development at the system level, and also to ensure equitable care that is delivered across all sectors. So what really is a white paper? Well, it's a research-based report which offers a focused description of a complex topic and presents the point of view of the author or the body represented by the author. And it really provides detailed evidence that there is a specific solution that's effective and as an effective approach to addressing a problem. So what did we do? And I'm going to start, and Dr. Ho's going to finish. But so the first thing that we looked at is doing an environmental scan. So there are 7 steps that you can see here in terms of how we are developing this white paper. And the first thing is to try to achieve consensus before we go to the final set of recommendations and develop that white paper. So I'm going to first talk about the first 3 steps, and Dr. Ho is going to talk about the last 4 steps. So there was an environmental scan that was done by Handfield et al. In 2024, and all 13 provinces and territories were contacted to provide pressure injury policies, procedures, guidelines, and standards. And what was found was that there was a lack of ministerial policy or procedure for pressure injuries in 4 out of the 13 provinces and territories. And for the 5 out of the 13 provinces and territories that did report policies, they provided them, but they were mostly appeared to be practice guidelines. And one province, such as Nova Scotia, they had a clear policy that all facility-acquired and community-acquired pressure injuries progressing to an advanced stage must be reported to the health ministry. And just as like a show of hands, is there anybody here from Nova Scotia? No, maybe online, I'm not sure, but good for you. Okay. We should model that all the way to across the country. So really what we found that there's a fragmented approach to pressure injury prevention and management in Canada. So the next thing is we went to the literature. What is going on in other countries, in comparable countries that have similar socioeconomic status? So we did a rapid review by Grams et al. In 2024. And the purpose of this rapid review was to explore pressure injury policies with countries that had comparable socioeconomic status, such as Australia, the UK, and the Netherlands. And what we found was that all countries emphasized evidence-based guidelines risk assessment tools, staff education, and the use of pressure relieving equipment as their core strategies. And for example, the UK focuses on national campaigns, competency-based nursing, education, and public awareness. And Australia achieved a significant reductions in pressure and ulcer rates through a comprehensive program, including e-learning and improved documentation. Okay, so the next thing we did is we have to represent the individuals with lived experience who are living with pressure injuries and the caregivers who provide their support to individuals with pressure injuries. So we undertook a study and it's currently ongoing. And if you're still interested in participating, I'm just putting a plug in there, come and talk to me. So we were trying to understand what is the experiences of individuals affected by pressure injuries in Canada. And this was a CIHR funded project, including multiple stakeholders, including individuals with lived experience, healthcare professionals, researchers, and it was supported by NSWAC, at CPIAP, and also Praxis. So the purpose of this study was to identify, understand, and achieve consensus related to the experiences of Canadians affected by pressure injuries, and also to prioritize strategies that may enhance outcomes of persons affected by pressure injuries. So we interviewed individuals with a current or past pressure injury, any caregivers who provided care, and unpaid caregivers who provided care for a person with a current or past pressure injury, healthcare professionals working in Canada, providing care for a person with a current or past pressure injury. We did interviews, one-on-one interviews, as well as focus groups, and we analyzed the data using inductive and deductive analysis. And what that basically means is we looked at what everybody said, and we tried to categorize that and put it into categories. So what were the 10 key recommendations that came out of this work? Was that it was essential to provide pressure injury education to patients and their essential care partners throughout their care journey. So it wasn't at the time that they just had a pressure injury. It was right from the beginning when they were deemed at risk of developing a pressure injury. Also, recommendations to encourage clients and their essential care partners to engage in regular pressure injury preventative practices, and to facilitate, where possible, any proper supports for clients and their essential care partners, to also ensure proper training of staff as it relates to pressure injury prevention and management, including letting them know about resources and referrals. Also to ensure that there was an organizational culture that's client-centered and prioritizes pressure injury prevention and management. It was also recommended that we ensure a holistic approach by the wound care team, availability of appropriate clinical expertise, access to equipment and services, and also promoting advocates and wound care champions as it related to pressure injuries, and also ensure that there were implementation standards. And now I'm going to pass it over to Dr. Ho, who will now talk about the process for consensus development.
Thank you, Sharon. Okay, so Sharon took you through the first 3 stages, and I have the pleasure to take you through the last 4 stages before your lunch. And so I'm just going to go through now the consensus statements development part and how that will lead to the e-Delphi process that we produce, and then I'll share with you the final set of recommendations that we have now. This is the first time that we're sharing this in public, so enjoy. But I warn you that basically, right, these are just still the raw recommendations. I'm sure that medical writers like John will say, you better change it to a more appropriate standardized language. So let me warn you that it's not refined yet. Okay, so basically, with all of that great data that Sharon shared, we had a steering committee to guide us with the development of the initial consensus statements that were used for the E-Delphi process. So who were on the steering committee? Well, this was actually a project undertaken by my master's degree student, Safa, who's actually listed there. And so she's part of the steering committee. And then we have members from CPIAP, such as Kathy, Kevin, Nancy, Shannon, and Sharon. And I also want to acknowledge Linda Moss, who's actually a family member of somebody with lived experience, and we really appreciated her input there. And so we included then trainees, healthcare professionals, health system administrators, individuals with lived experience, and also researchers, all in this small steering committee. So when we looked at the developments of consensus statements, we decided to use the quintuple aim. So that is really most relevant to the healthcare system. So how many of you are familiar with the quintuple aim or quadruple aim? Okay, so some of you are familiar with the quadruple aim, but not the quintuple aim. So maybe I'll just explain very quickly what it is. Basically, the quadruple aim is a framework developed by the by IHI, or Institute for Health Improvement, and basically it's a framework that the healthcare system uses to improve the quality. And so the quadruple aim had 4 main components in this framework. That included things such as population health, patient experience, provider experience, and also cost reduction. That means that when you want to develop a strong healthcare system with quality, you have to look at those different domains. And now with the quintuple aim, they took it one step further and included health equity in there as well. So that's why we use this framework. And basically, with all of that great information that we collected, as Sharon described, we came up with 30 draft consensus statements. And they actually were classified, under these 5 different domains. But you see that some of them actually overlap quite a bit, so they could live quite happily under, more than one domain. So let's see. Basically, with those 30 statements, we got our steering committee to look at those. And the steering committee then looked at the statements and try to refine them further. We also did a really wonderful exercise, if I may say that myself, in the NSWOC meeting in Montreal in May this year, right? Yeah, so there were 154 people who participated in that conference. And we actually got the NSWOCs who were there to give us opinion. Wasn't that wonderful? And so basically, we asked them these questions, right, using an interactive methodology with the Mentimeter. So this is one example under provider experience. And so for provider experience, I don't expect you to read the 4 statements, but it's just to show you that there are 4 statements. And we ask the audience to actually rank them and also to give comments as well. And so you see that this is how they rank them, right? So with the NSWOC input, as well as the expertise of the steering committee, we actually brought them down to a much more manageable number. Okay, because if we have 30 statements undergoing E-Delphi, it'll be too complicated. So basically, we then brought it down to 14 statements to 16 statements for the modified E-Delphi process. And so I'm just going to explain to you what I mean by modified E-Delphi. Is any one of you familiar with the Delphi process? Some of you are. So let me just very quickly go through what it is. It's basically a consensus process that's driven by evidence, and also that's driven by discussion among experts. In the traditional E-Delphi process, basically, you bring the group of experts together, all in the same room and discuss together, going through multiple rounds. They are iterative rounds, and you vote for the statements, you make changes until you actually reach consensus. But guess what? Especially after the pandemic, right? Can we always get people together in the same room? No. And also, it's too costly as well, right? So we basically use the electronic modified Delphi process here. And so we got the panel to basically review the statements and then vote, give comments, refine them, and going through multiple rounds. So basically, who were in that modified Delphi process? We recruited 32 participants through professional networks across the country. So they're mostly healthcare workers with some health administrators and some people with lived experience and also one researcher. And they actually represented people across the country. And so I think that we did an okay job to have most people, most places represented. And so basically, there are 14 statements. And we use a 5-point Likert scale. So 5 means strongly agree, and 1 means strongly disagree, and then everything in between. And that was for round 1. And then for the subsequent rounds, if needed, we use a 3-point scale. Basically, how do we reach consensus? Whenever we have more than 70% of strongly agree or agree, we define that as reaching consensus. And there are also comment boxes as well. So this is how it ran. So for the first round, from the 14 statements, we reached consensus on 10 of them. And then we went through the second round with 4 statements. And then from that round, 2 statements reached consensus. So 2 more statements went to round 3 for further consensus. And after that, we were done. So at this point, basically, we have now the 14 final set of recommendations. And so today, like I said, I'm just going to share with you for the first time what they look like. And but we still have to refine the language a bit more. Okay, so the first one is under population health. And so the statement states, we recommend a national pressure injury data strategy that will standardize pressure injury terminology and clinical documentation across all care settings, that will support mandatory reporting of pressure injuries at the organizational and provincial or territorial levels to inform accurate quality improvement measures that can help decrease the incidence, prevalence, and hence cost of pressure injuries. They will support a national pressure injury registry to collect vital information, identify gaps and trends, and regularly inform the need for practice and healthcare system changes. So I just want to go back to what Sandra said earlier this morning, right? So if there's actually a system that we can collect data and utilize the data at both the system level and at the unit level, right? At the hospital level and at the unit level, that'll be wonderful. Because I think that the risk is that we collect lots of stuff, but then we can't use it later on, right? So we want to make sure that there'll be a strategy for that. And then the next category under patient experience, we recommend a patient-centered approach in the development of care plans by ensuring the plan is co-designed with patients and caregivers and addresses individual and system-level barriers. How often do we design care plans that are really designed just by the providers with no patient input? We have to change that. And so, by the way, this also aligns with accreditation requirements now. So we better do it. And the second one says, we recommend conducting holistic assessments to examine pressure injury risk factors, such that prevention strategies can be applied for all individuals and that active interventions are implemented for individuals who are at elevated risk or have existing or previous pressure injuries. The third one says we recommend providing accessible and tailored pressure injury education for patients and caregivers to support self-management and informed decision-making aligned with individual and cultural needs. Okay. So now the third category is provider experience. I know many of you here are providers. Of course, you matter. And so let's look at the provider experience here. We recommend the adoption of an interdisciplinary approach for the prevention and management of pressure injuries. We recommend the provision of national competency-based annual training in pressure injury prevention and management for healthcare professionals and trainees. We recommend recognition of interprofessional healthcare teams that excel in the prevention and management of pressure injuries by provincial or territorial and federal health ministries. We recommend culturally safe, accessible, and ongoing education on pressure injury prevention and management to empower clinicians, patients, and caregivers. What do you think? Okay, now let's look at cost reduction. Of course, we have to look at cost, right? Because this is a very costly condition. So we recommend the prioritization of pressure injury prevention to reduce burden and costs associated with pressure injury healing. We recommend an interprofessional team with specialized knowledge and skills in skin, wound, and continence care to provide clinical leadership of cost-effective prevention and management of pressure injuries. We recommend the adoption of appropriate and innovative use of technology, including artificial intelligence, to strengthen early detection and risk stratification, streamline clinical workflows, and enhance the capture of pressure injury data. Okay, now, health equity. Under this domain, we recommend appropriate and equitable resourcing and availability of healthcare providers with a specialized body of knowledge and skills in pressure injury prevention and care across rural, remote, and metropolitan areas. How many of you come from the remote or rural areas here? Some do, but I think that we all recognize that the resourcing is not quite equitable, is it? Yeah, so we have to address it. We recommend the development of a coordinated and integrated national strategy with an advocacy framework involving all provinces and territories to position pressure injury prevention and management as a healthcare priority across Canada. And we recommend that provincial and territorial healthcare systems prioritize and allocate additional resources for prevention and management of pressure injuries with a focus on vulnerable populations. So those were the 5 categories and 14 recommendations. Sorry that I just had to fly through them, but this is just the first time that we're sharing them. And so what do we do next? So basically, well, first of all, Safa has to get through her thesis defense, which will be coming up soon. And because, like I said, this is her master's work. And the 14 final recommendations will be used to create a white paper. And we aim to submit that for peer review publication. And we want to socialize these 14 final recommendations with key interest holders through CPIAP and other organizations. And also, we want to consult with policy experts as to how to use these to influence health policies. So before we finish, we just want to acknowledge many, many people who have made this work possible. Apart from all of those that we acknowledged earlier, who were part of the panels, part of the committees, we also want to acknowledge these many people who supported this work. And thank you.
Thank you so much, Dr. Ho and Dr. Gavison. I think we just have time for one question, and there's a great question here online, so I think I'm going to pose this one. Do you think that standardized national mandatory happy public reporting would improve health outcomes?
Maybe I'll take it first. I think that Nova Scotia is the poster child for that. Because basically, if I understand correctly, I learned from my colleagues in Nova Scotia that after they have made their reporting of advanced pressure injuries mandatory, they have seen a significant decrease in the prevalence of pressure injuries. So I think that's quite an important outcome to learn from. Sharon, do you have anything to say?
Is there any question? We'll have one question here in the room. Is there anybody that'd like to ask questions to both Dr. Chester Ho and Dr. Gabison?
Hello, everyone. I just would like to ask a question in relation to the nurse to patient ratio. Do you think it is a big factor in preventing PI?
So I'm not speaking as a nurse, so I'm going to be completely transparent. And obviously there probably is some, if there's not enough support in any way to prevent pressure injuries that could lead to it. I think it's a multifaceted approach. You could have a situation where you suddenly have a trauma or something, and then you may not have enough people to support. So I can't speak, I'm not a nurse, so I'm not speaking from personal experience.
Yeah, but sorry.
The reason why I raised it, I
Give your mic.
data and sometimes research about PI prevention, and they never mention about understaffing and nurse to patient ratio.
Yeah.
Like I am sharing this on the unit that I work. Our nurse to patient ratio is 12.
I think
Yeah.
that I would like to have our nursing colleagues to address this, but I also want to go back to what Dr. Black said earlier, because she was mentioning, right, the ICU as an example. The ICU has one-to-one nursing, right? And yet, their rate could be high. So what I'm trying to say is, I think that ratio is one thing, but we have to look at the population. We have to look at multiple other risk factors. So it's not just a one direct ratio sort of situation. But I would love to have our nursing
Dr.
colleague-
Chester Ho, I just called a friend. We have one nurse that could have the answer here.
So I think that that's an excellent question and one that's certainly at the forefront. I'm in full agreement that pressure injury prevention and management is multifactorial. So I do get a little bit upset when nurses immediately say, oh, well, it was nursing ratios. That being said, we do know that this is a fight that's going on across Canada, across the continuum of care, where we are fighting for better nursing ratios. It's first and forefront in all the communication from the Canadian Federation of Nurses Unions. This is one thing that they are advocating for, is better nurse-patient ratios. But that being said, I caution you at saying, okay, we're going to suddenly get, go back to the good old days, and I'm aging myself, where we are 1 to 6 on a surgical unit. Guess what? We still had pressure injuries. So I think that we have to be very cautious of putting it all on ratios. I think it's an important part because, certainly for all the people in here in long-term care know that the ratios in long-term care of nurses to patients is almost unobtainable in terms of sometimes providing all the care you want to provide, but just be cautious because there's other things in education. And I firmly believe knowledge, attitude, and practices make a huge difference in pressure injury prevention.
Okay. We are going to get started again. Hope you all enjoyed your lunch. The next session will be presented by Christina Hagner, A Blueprint for Pressure Injury Data Collection to Action. And I'm just going to be doing an introduction to Christina Hagner, who is a clinical nurse specialist in wound ostomy continence for Vancouver Coastal Health, and works with all of the NSWACs across the Health Authority in acute, community, and long-term care settings from Richmond to Bella Coola. She started her nursing career as an LPN in cardiac surgery and rapidly fell in love with wound care after caring for patients with dehisced sternums. Her passion for prevention of surgical site infections led her into her master's, where she focused on challenges in preventing these complications. In her current role, Christina strives to improve best practices around prevention and management of wound ostomy and continence issues and is spearheading a health authority-wide wound care strategy aiming to prevent commonly preventable wounds, including pressure injuries, surgical site complications, and diabetic foot ulcers. So welcome, Christina.
Okay, so we're back from lunch, feeling good, right? Sometimes the lunch talk is great because people are keen, they're excited, and sometimes it's terrible because our snacks were too sweet and now we're ready for a snooze. And we're going to talk about data today, so hopefully it's not too much of a snooze fest and more interactive. So I just wanted to thank the organizers for inviting me to come and present. I feel really honored to be asked to speak to some of the work that we've done across our health authority. And this will piggyback on the presentations that we've had this morning in terms of what other sites are doing kind of across the country. So to start, we had our territory honoring this morning. I wanted to acknowledge with gratitude the land that I get the good fortune to live, work, and play on. This is a shot from one of our mountains where we can go skiing in Vancouver. It is a 20-minute drive from my house. And I think that it's really fortunate that we're able to live, work, and play in these places where the ancestors of these lands have cared for them since time immemorial. So just acknowledging with gratitude our Coast Salish peoples, the lands of the Musqueam, Squamish, and Tsleil-Waututh. This is where the presentation was built on and where the data is coming from as well. So just wanted to acknowledge their territory. No conflicts for me. So I was gonna try and be tech inspired and do a Menti question, and then I got nervous about how that was gonna go. So we're gonna do a simple raise of hands to set the picture around why we're talking about data. So I wonder, I'll ask the question, I'll provide the answers, and you can just raise your hands in terms of which one fits best with you. So just curious to know if you're able to access your numbers of pressure injuries in your care setting. So number one, wouldn't know where to start. Where are we at? Yeah, got a few. Can request it, but might not get exactly what you're after. Yes, a few more of those. I see folks raising hands online. Thank you, online participants. It's at my fingertips. Do people live in a dream state where we have it at our fingertips? This is amazing. Count yourselves lucky. And can people actually access data in care settings? That was my final question. Okay. So I want to talk a little bit about why data is essential to your project's success. I want to talk a little bit about where data is stored and how you can access that, depending on your patient populations and your care settings that you're seeing. Gain insights on how data is retrieved from this magical backend system that our electronic data systems use, and also how we do this in paper chart-based systems. And then talk about and use an example of how we actually put data into practice to make change. So why do we want to talk data? So I have three key things. If nothing else from this presentation, I'd love for you to remember just these three very important things. Number one, data is critical to the success of your project. What this means, when you say to somebody, I would like to change this particular thing, they will always ask, tell me why. Right? What's the reason? Is it a cost-based thing? Is it a time-saving thing? What's the reason for why you want to make this change? And then you're going to make the change, and how are you going to measure it? Right? It all comes down to data. The second thing that I have learned in my career is that data will open or shut doors depending on how you present it. And this is really important in terms of knowing your audience and knowing what you're presenting to your particular group where you're hoping to gain that buy-in and that support. So a senior leader may want things like cost. They want impact on capacity. They want to know if you're impacting surgical wait lists. They want to know kind of big system things. Your healthcare aides might want to know how this intervention is actually going to implement their daily work schedule. They might want to know, was my voice even included in this in the beginning, right? And if you present costs to care aides, they may or may not care, right? Same if you present really detailed clinical information to senior leaders who may not even be clinical people, it can cause some problems, and you don't want to lose your audience before you begin the conversation. Third, data is never missing. It's never missing. It can always be sourced. So if your data is missing, that's a challenge and an opportunity for you to be able to look at your sites, look at your care settings, figure out what's missing, why it's missing, and address the problem of missing data, right? So you can source your own. Okay, so what I wanted to do was provide a small example using Joseph. So Joseph is a First Nations man from one of our coastal Salish regions. He is a grandfather, he is a father, he's a local artist, he's well known for his carvings. And one day, Joseph is in his shop and he develops crushing chest pain. Joseph goes to his emergency department in his rural care setting. They aptly diagnose him with an aortic dissection, and he gets a one-way ticket to Vancouver, which is a 3-hour ride away. Joseph is transported, of course, on a hard stretcher. We heard about this morning in terms of transport and surfaces. He's on a hard stretcher, very thin foam, goes immediately from that transport stretcher into the hybrid operating room so that he can have his surgical procedure. 16 hours later, Joseph comes out into the CBICU. His first night is a little bit rough. We've also heard it's hard to turn people in our ICU care settings because they decompensate, right? Fast forward 3 days later, the nurse is doing their head-to-toe skin assessment, and what do they find? Right? What didn't they find? Yeah, and we ask ourselves, is this preventable? Is this truly preventable? We talked a little bit earlier this morning around this sort of zero incidence, right? And how sometimes we can understand where our folks are coming from. So this is Joseph in my fictitious data set, right? And what I'd like you to remember is that your data set is really stark, it's really sterile, it's not very friendly, right? It's not as friendly as Joseph would be. And our data points that we look at and that we care for are actually people, right? There are humans in our care and they are stories, and they should be treated as such, right? So when we're looking at our zeros and our ones and our negative 99s because we're missing our data, we want to remember the human behind the data and the reason why we're here. Okay, so talking a little bit about where data lives. So this is very much dependent on the care setting or the multiple care settings perhaps that you work at. So in my introduction, I work across acute community long-term care settings. I also sit on provincial committees, and we have access to sort of discrete site level data as well as national level data. And really understanding the problem that you're asking and sort of figuring out what's the care setting and how do they document, where is their data stored, and how do they access their data is the first step when you're trying to think about, if I'm going to make a change, how am I going to show it to the site? We know there's different data systems out there. We know that some sites are paper-based in terms of their charting. Some sites are electronic. Some sites are the great fortune of a hybrid system where you get both of these things. And data can be challenging in each of those particular areas. So if anyone has ever attempted a paper chart audit, this is a lengthy piece of work, right? It involves a lot of work and a lot of paper and a lot of phone calls down to records to try and get the actual records that you're interested in seeing. Electronic records are touted as these massive data sources, right? They're supposed to be this amazing thing for the future, but really what they are is accounting systems. And the ability to access what you see in the front end compared to what you get in the back end can sometimes be really challenging. And then it all comes down to culture. So I'm sure everybody has worked on units or in care settings where you are amazed at how excellent they document, right? Every single Braden assessment is done. Yes? No. So the culture of the unit is really going to dictate what data is available, and your data is only ever as good as what's documented, right? And we know that if it's not documented, it's not done. I wanted to draw particular attention to OCAP. Has anyone heard of OCAP? Yeah, a few folks. So we as healthcare, we spend a lot of time talking about data. We spend a lot of time talking about ways that we're accessing data and how we're using it. And OCAP is a First Nations principle that really asserts that First Nations communities own their own data. They are responsible for the data, and they're responsible for the way that the data is shared. And if you're interested to learn more about OCAP, I have the link to the website available. We use this within Vancouver Coastal Health. We have some partnerships with some of our First Nations communities where we have shared care, and our legal team really embedded OCAP principles in the actual data sharing agreement to be very clear on who owned what data and what data was able to be shared, and that was in collaboration with the First Nation. I think that's really important and groundbreaking work that we've done in that space. Okay, so we're gonna walk through a little bit about how to talk data. I am not someone who talks data despite having a talk about data today. But I wanted to walk through a bit of an example. So I had requested the rate of pressure injuries in one of our hospitals after about a year of them being live in an electronic record. And the team presented back to me that they were so thrilled about all of this processes where they had mapped the data to and from, and it was like 20 minutes of how great they were at mapping the data. And this is an 800-bed facility that we're talking about. And they're like, you guys are doing awesome. You have 2 pressure injuries. And I was like, oh, no. We have a pickle here. This is not exactly what we're trying to talk about. So sometimes when we're requesting the data, we have to be pretty clear in terms of what we're aiming for. And sometimes what we get is wildly offside. So I wanted to walk through an example of a recent data request that I gave to one of our informatics leads. I said, hey, Lori, is there an easy way to tell how many pressure injuries were acquired in community versus hospital? I'd like to know ratios and ideally separated by stage, stratified by care setting, if possible. And maybe community. Could we pull from the time the field was mandatory until now? Oh, and ideally in fiscal year format so I can see the ratios change over time. Thank you so much. Right? So this is the actual programming that our informatics folks use to find my wildly, confusing data request. So there's a lot of logic that's built into my simple clinical query and then how they're going to grab that data out of the back end of the electronic record, right? And that is not my job. That is the job of our nursing informatics. And the problem between these two things is that you need a translator who is able to speak the clinical language and someone who's able to translate that into the back-end data sets, right? You need to be able to frame questions like my wildly offside question into something that's really concise and organized and structured. And Dr. Lori Block is my informatics lead that I work with in Vancouver Coastal, who is incredible. And a lot of this work would be nowhere without her team because she's able to concisely request the things that she knows I actually need answers to. Having that sort of built-in relationship with your clinical informatics folks is going to be the key for you to have a successful kind of data sharing process and a good relationship ongoing. Okay, so some tips and tricks for those of us who are not savvy with data. Number one, what I've learned is be extremely clear. Please don't give the example like I gave to Lori. Try and be a bit more clear than that. Make sure that if you have an electronic record, your data people love screenshots. They want to know where that discrete data field actually lives when you're documenting. And part of that is really understanding what are your separate data points when you're requesting something. So we as clinical people, we see people, right? We don't see discrete data points. And trying to translate that in your mind in terms of what is your question that you're asking and what are those discrete data points going to be can be tricky, but it's really helpful to try and at least start thinking that way. And then when you have a conversation with your informatics person, they can help navigate through that a little bit easier to sort of bridge that gap between the clinical and the informatics sort of side of the house. So now we're going to walk through how we put data to work. As part of a big piece of work that I have is implementing a standardized framework for pressure injury prevention. We did a demonstration phase to sort of learn what works and what doesn't. And so part of that is what we're going to share as we go forward. So a little bit of our health authority related data. So this is data from our community settings. So it includes our community home health nursing clinics. It includes ambulatory care and primary care. And what we saw was that from 2018 to 2024, we had an 11% increase 10% increase in the number of wound clients cared for by home health nursing. And we also saw that over half of our home health nursing visits were related to wounds. We also saw in that same time frame that the rate of wound assessment per wound decreased by 2. So our nurses were not assessing as often as they had been before. So it's no surprise that the heal rates of our wounds worsened by 11% over that same time point. Now you can see the bars in gray highlight our COVID period. And I think everyone can probably agree we're still recovering from the impacts of COVID on our systems. And a lot of these changes are likely related to that issue we all faced. So this is the wound care strategy. We are not going to talk about strategic frameworks, even though it's my favorite thing to talk about. But I will just say that there was a lot of thought behind framing this as a building with the patient at the roof. The whole building supports the work and the care that we do for our patients. What I want to zero in on is the process section. So we have people at the top, we have process, our pillars, which is the work of our strategy, and then the principles that guide the work that we do. So the process section, it's a 5-step process. We heard about this also from Unity Health as well, following a similar sort of work. This is a quality improvement process. If anyone's ever done QI work, you'll see it's the same sort of idea. First step is engaging with the site and determining the champion. The champion is critical to the success of your project. They are the people that are going to help shoulder that burden of change until the sites are actually able to take it on and sustain it themselves. We want to do environmental surveys. We want to learn what's happening at this site. We want to use that to inform opportunities. And we, as sort of the clinical experts in pressure injury prevention, know what those opportunities are. Sites might not. And sites may have competing priorities where they want to decide what's going to work best for them. We want to use those evidence-based interventions to get them into place so that we can start measuring change, right? Measuring and see how we do in terms of change. And this is a cycle that goes on and on and on and on and on, right? All of this work, though, is sustained by an organic shift in foundational nursing practice. And I know that we have other members from the team that are at the site, so I would argue that this could also be foundational frontline practice. But this is how we do the work that we do, and how we shift it is making sure that we have sort of consistent education in place from all members of our team. So we know from the literature, and I won't go over this very in depth, but we know from the literature we have a bit of a rate gap in terms of pressure injuries that are reported. Even pressure injuries in our data often tend to be underreported. And what we found doing prevalence studies with over 1,100 folks in the year that we did this timeframe in across acute community and long-term care settings, we found half of our pressure injuries were undocumented at the time of our assessments. Less so in the community setting. And if anybody has ever done a prevalence study in community setting, please come and talk to me afterwards, because I'd love to know how to make ours better. It was a bit of a challenge, but suffice to say, we know that there's certainly underreporting going on in the rates of pressure injuries that we hear about across our data sets. So what did we do to address the gaps? So we've identified that we have some data that's missing. The data that we were missing in terms of documentation was around things like offloading equipment. Do they have wheelchairs? What kind? Are we using cushions, pillows? What sorts of equipment do we have at the bedside? We did look at skin tone assessment using the Monk scale, and we found it was very challenging to do that. And our inter-rater reliability of it was a little bit low. We wanted to know mattress selection, and we wanted to know things, are the Braden assessments actually being completed according to our guidelines or not? And so what we did is we created a standardized data collection form. We use this across all of our prevalence studies, and part of the reason why we wanted a standardized form, we heard about this also from Unity Health, is when you have standardized definitions, it makes it a lot easier to be able to compare cohorts, right? So we had sites that were more rural. We had sites that were in our metropolitan areas. We had long-term care. We had ICU. We had a really wide mix of sites where we tried to implement on. And what we wanted to do was find standardized definitions across those care settings so that we could then kind of compare them to each other and see how things were going. It also allowed us to have a really structured approach to thinking about when we want to scope and scale this work to different sites. We had some lessons learned. So one of the key things that we learned about this form in particular is that within the form, we wanted to know what mattresses are folks on because we wanted to create a surface selection algorithm. When you take this to community setting, they laughed at us and they said, I don't care what the mattress is. I want to know, does my person sleep in a chair or a bed, right? Or are they on the couch? And so we had some nuanced differences that happened as we started going out to our sites, and we subtly adjusted the form to be able to address some of those. So the standardized prevalence studies that we did, we had a baseline before we did any interventions. And then we did quarterly, and we did this with intention because we wanted to be sort of the bee in the bonnet. We wanted to be in contact with the sites and try and encourage them to make these sustained changes over time. We know with repetition, we heard about this also today, things tend to stick the more often you say it. So we really wanted to do those prevalence studies every 3 months so that way we could remain connected to the site. We had teams of 3 or 4 if the folks were heavy. And within the teams of 3, we assigned at the kind of pre-study huddle, we assigned roles to determine who was doing what in the prevalence studies. So we had a data recorder. We had somebody staging injuries if we found them, who 9 times out of 10 was an NSWAC doing that. And then we had somebody from the site. And this was really critical that we needed to have site participation because the whole point of this work was to engage the sites in pressure injury prevention. And by the time the wound care strategy team left, we wanted that site up, running, and independent. And to do that, we had to walk the walk with them and we had to train them in the process. We provided immediate data shareback to the site. So at the end of the prevalence study, we had forms that identified the new pressure injuries that we found. We also looked for moisture-associated skin damage. And so we identified those areas so that it could be immediately given back to the nurses for assessment and documentation. So that way I could have my data, which was very important. And then we also had standardized data reporting back to the sites, including leadership, educators, any physicians who were interested in the work that we were doing, as well as the folks who actually participated in the study. And we did a bit of a standardized template where we celebrated the successes of the site. So if they were increasing Braden documentations up to our target, great. If they had sustained implementing pressure injury prevention dressings, great. And then we addressed what are the areas of opportunity. So what's kind of the next step of the next thing that we could do. And we did this for them after every single prevalence study to really support and build the work from the ground up. Okay, so how does data sustain change? So what we found in our studies is that you really need to know who you're assessing and who's at risk before you want to think about things like implementing a pressure injury dressing or implementing an advanced surface, right? To do that, you need to do things like a Braden assessment. You need to have intervention care plans to be able to support kind of these interventions that we were aiming to get. So the first thing we did across all of our sites is tried to increase our documentation rates so that way we knew who was our risk profile folks and who we wanted to intervene on. Once sites were at that sort of level of being able to document effectively, we then looked at some of the assessment pieces. So are they doing the head-to-toe skin check? Are they finding pressure injuries? Are they staging pressure injuries appropriately? So this was education that we layered in on top of that. We had bundles around intervention and preventions, which I probably don't need to go into because I think everybody probably knows what these bundles are. But suffice to say, the most important thing that we learned is that when you are trying to implement something, if you don't have that baseline assessment of who's at risk, you cannot start layering in anything on top of that. You have to start with who's at risk, pick one intervention that you want to start with, get the site motivated around that, see some change, and then you can start layering in interventions on top of that. And this becomes, of course, a cycle of continuous improvement. So how do we do, right? This is always the end result of all these conversations is how did you actually do? So I wanted to start with a quote. We had a patient partner who was part of our steering committee and helped guide the development of the framework. And Cameron tells us, you must adapt early. You must give care early. My feet have cost millions of dollars, and a lot of that was because it was ignored at the start. Cameron is one of our folks, unfortunately, who had pressure injuries that were missed. So what we found over our year of implementation, we had this really nice sort of Kubler-Ross change curve, right? So we saw a little uptake in sort of our rates of pressure injuries over time, which is expected, also heard about earlier this morning. Folks are starting to document and assess better. They're starting to recognize more. Those rates are coming up. Then we're going to start to see a nice decline as we're starting to put interventions in place. And then we're going to plateau to a new steady baseline that hopefully is lower than what your baseline was at the start, which is what we ended up seeing. So overall, a 10% reduction in pressure injuries and a 7% reduction in healthcare acquired pressure injuries. Now, interestingly enough, we know in the literature that quilted soaker pads can cause pressure injuries and moisture damage. We also saw that within our sites. This was our first intervention and our first linen layer to go. And as a result, we saw a nice decrease both in moisture and pressure as a result of that. We also did a really cool partnership with one of our local universities because they needed a project and we needed help with math. And so they did some modeling for us around planetary impact. So we projected if we reduced 10% of our pressure injuries overall, we'd save almost 4,000 kilograms of CO2 emissions related to folks traveling to and from the clinic. And I thought that was a really interesting data metric. We have a planetary health pillar as part of Vancouver Coastal Health, so it was nice to be able to report back on that pillar and that piece of work. So I want to talk about some lessons learned. So this is one of our sites that's excluded from our results. And the reason why is because you can see this really nice dip at 6 months, right? Super low rates of pressure injuries at 6 months. And then they skyrocket right back up to baseline. When we walked into the unit for this 6-month study, we found out the site champion had left. And what we saw as a result is that all of that hard work of that 6 months was lost. So really, really important that your site champions, I mean, hopefully they stay on site, but we know that things move and people move and that's fine. But really making sure that the work is sustained is part of sort of the translation of the site champion if they are leaving to sort of build up the next person coming in to support this piece of work. This is a separate site. So another thing that we saw, you'll see at the 6-month time point. So this is our completed Bradens. So green is great. That means they did a Braden on admission. Red means they've missed. And what we saw at the 6-month time point, which was very interesting, this was one of our acute care sites in one of our coastal communities that has a lot of agency nurses over Christmas. And what we saw was that the rates of Braden completion rates really dipped during the Christmas timeframe. And it was because they were staffed more than 60%, I think, by agency nurses. So making sure that we're supporting the training for everybody coming on site and that the expectation of practice is the same is very important. They also lost a key site champion at 9 months, and you can see the results of that on the slide as well. So site champions, very, very important to sustaining your work. Okay, so finally, we had a bit of a, I feel like, a call to action from Dr. Young this morning around quality metrics, right? What I wanted to be able to give to you or to help you with is think about how do we sort of walk through this sort of call to action. It seems really big, it seems really cumbersome. And how do we approach it in a stepwise logical fashion that doesn't make you feel overwhelmed and want to not come to your job the next day? And so step one is find your data, right? You've got a problem. What data do you need to answer your problem? And then you're going to go collect what's missing because you probably don't have all the data, right? And so figure out what it is that you're missing and how can you create standardized ways to get that data embedded into the work that's already happening. Determining your opportunities is really important. And that's not me as the healthcare worker who knows what opportunities are going to work. That is the site identifying what's going to work within my culture, my unit, my population, right? What works in ICU probably won't work in long-term care. But you need to find that balance and figure out what are the pieces that are going to fit, because when you fit it, it will actually land and stick. And then it will be something that becomes integrated in that organic shift in foundational practice. And then you're going to have ongoing evaluations. And this is, of course, a circle. And you probably noticed I put circles throughout my whole entire talk because I love a good circle. If anybody ever drives with me, I never go the same way twice. I always like to complete a circle when I drive. Because I feel like they make logical sense, you know? It's something that's never ending. This is always an ongoing system, right? Like you're never going to address every single pressure injury across your care setting. You can try, but there's always going to be things that are going to come up. There's competing priorities. There's maybe a new documentation system that comes down the pipe. There's always going to be things that you need to sort of look at and evaluate and continually kind of walk the cycle through. And so with that, I will say thank you for your time.
Are there any questions for Christine? Just hopping over some clips.
That was fantastic. So I have a few questions for you. We did chat earlier. We're both on Cerner, so we'll connect after this summit for obvious reasons. Do you do pressure injury auditing in your ED?
Not yet.
Okay. Do you have anything in place in your ED within your EHR to, whether it's force function or not, to support staff to capture a CAPI?
No.
Okay.
Not yet.
And last question, do you have anything in place to, and I ask this question because when I do a high level chart review and I'm looking at that patient case, I often say we go to the front door of where the patient enters our facility, which is the ED oftentimes. But I've actually in the last 12 months taken a step back and looked at, there's a step before that. And that's our paramedics, that's our EMS. And what have they documented? What have they seen before the patient even arrives at the facility? Is there any work being done with your organization with aligning with paramedics and how they can support teasing out that happy CAPI and that skin integrity before they arrive at our site?
Before they arrive?
Yeah.
Yeah. So within BC, there's been a big push to do some education with paramedics around wounds specifically and around skin integrity. So the short answer is it's coming. I haven't seen it in real life, but I do know that there are works underway to try and support and promote this idea of skin integrity, like across the spectrum of the system. And within acute care, no, we don't know whether or not things were acquired in community or acute. There is a field in Cerner to answer that, but like if it's documented, they get the prize for actually documenting something. However, we did make it mandatory in our community electronic record in terms of wound assessment. So if you identify your etiology as pressure, you have to, in order to complete the chart, state where it arose from. And granted, that's only as good as your, ability to decide whether or not you're going to go through lots of charts to figure out where it's assessed from. But in that instance, we do see about 60% of pressure injuries in community arose in community with community services. It's only about 30% that came from acute in our data set.
Christine, just a follow-up question to that one. Is your practice in ED also to conduct a risk assessment as patients are waiting possibly to be admitted in the inpatient units?
What a great question. If you looked at our guidelines, yes. If you spoke to real life people, it's hit or miss. We should be doing Braden assessments if they've been officially admitted, even if they're in ED. This is part of our scope and scale conversations that we're doing at the moment, is trying to understand why it's not being done. And a key point that actually came up in our prevalence studies in the community settings, because we think, community home health folks, they should have a Braden assessment and lots of them don't. And the reason why that the nurses told us is because I asked the question, which was probably a bit naive of me. I said, how come you can't do a 30-second assessment, right? It takes 30 seconds. How come you can't do that? And they said, you are one of 70 30-second assessments that we have to do in the first hour of our visit. It's like, yeah, okay, that's fair.
So looking forward to that work, because as far as we know that waiting times in the ED is quite surmountable. And it varies wherever you are. But the thing is, if we could do something to prevent the pressure injury that's been brewing in the emergency department, by the time they get into an inpatient unit, possibly the damage could be irreversible.
Yep.
So looking forward to the work that you're going to be doing, and hopefully that can be adopted elsewhere as well. Thank you. Are there any other questions for Christine in the in person?
I'm going to take two from online.
Okay.
Two quick ones. Instead of quilted pads, what did you recommend for patients?
I mean, so nothing unless they actually need something is the first recommendation. And then if not, disposable dry pads.
And then second question, who are your site champions and did they have any advanced knowledge of wound care?
Yeah, that's a great question. So it really depended on the site. In the ICU, we had a CNS who was the site champion. In one of our medicine units, it was a nurse educator. Long-term care, it was the resident care coordinator. In our community settings, we tried to get the NSWACs to be the champions. And in one site that was successful, and the other site, the educator and the manager actually were more effective in championing the staff. So I think it depends. And did they have education based? They had the education we gave them. Some of them were keen, and so they already were invested in the work, which is probably why they were champions in the first place. But we did give them additional education to support kind of the process.
Any other questions for the audience? Seeing none, on behalf of CPIAP, Christine, thanks for giving us some ideas in terms of how we can leverage data to provide sustainable opportunities for promoting pressure injury practices. Thank you. Okay, so at this time, I'm calling my colleague, co-chair, partner, Dr. Sharon Gabison up front, and a little help from Troy as well. We're going to try to make this as interactive, short and sweet as possible. And to be honest with you, I know that we've had some technical challenges this morning, and that's nothing to say that we're setting this up for this activity, okay? Nothing related to that whatsoever. But we're going to talk a little bit about technology in terms of pressure injury assessment and management. So we will have a Mentimeter up and running right at this moment. And what we would like you to do is either scan the QR code or go into menti.com and type in the codes that will be presented on the screen, and we'll be hopping onto the stage.
Okay, you can see the code, so we'll just give you a minute to scan that with your phone. Okay, so the first question that we have is, what does technology mean to you?
I know it's a vague question, but what comes up to mind, first thing you hear about the word technology? Okay, so a couple of things are coming up here, but one thing that came up here for me that I spotted already, it says that it was a nuisance.
A nuisance. I look at the half glass, half full innovation.
Like Sharon, I feel sorry for actually being the catalyst for that comment, possibly because of our challenges this morning.
Oh.
But I'm seeing here as well, innovation, access and accessibility, advancement,
progress,
connection, innovation, automation, data capture. Okay.
Perfect.
So a lot of actually positive comments here and looking at potential, application of it in the future.
What's that?
Yeah.
Perfect.
Okay, so why don't we find out what the definition of technology is?
Okay, let's do that. So technology, according to Google AI, technology in pressure injuries refers to the application of various tools, devices, and digital systems for the prevention, monitoring, assessment, and treatment of pressure injuries. Yeah, I think that's a pretty nice definition.
I usually don't use AI in Google search, but I just typed in technology and pressure injuries and this one came out.
Yeah.
So I had to cite them, fortunately.
Unfortunately or fortunately. Okay.
Use of AI. Okay.
So for what primary purpose, so you can only answer this once, do you use technology for pressure injury prevention and management in your practice?
So think about this question is, if you have only one option out of all of these, where do you normally put a lot of your energy in the utilization of technology in your practice?
For now, right?
For now.
For now. Maybe we'll ask the same question next year and see how that changes.
Actually, what do we... Okay, so I'm seeing a lot of people are using technology for documentation. So those that are in person here, can somebody would like to expand upon that? Those of you here, anybody using technology in documentation? Wound rounds. I'm going to go around with a microphone. So one of our colleagues here is saying that they're using it for wound rounds. Anybody? I just heard. Okay. Can you expand more about that, please?
Don't use wound rounds. I did the risk assessment, but I threw it out because I'm imagining that's what they're thinking of is wound rounds. I don't know if there's other long-term care homes that use wound rounds, but it captures photo as well as measurements and PERS score.
Yep. So it sounds good. It seems like also in other facets as well, it allows you to document information on the go. So at the point of care, when you're doing your assessment, the technology, like sometimes it's a mobile phone, EPR related, and then you can capture the photo, do your measurements, and then updates there in the flow sheets, and automatically it uploads into the system that can then be trended over time. Is that how you can capture it? Like, that's how it normally is for the documentation piece. So I saw some people are talking about wound photography. I did just mention that, but is there any type of wound photography tools that you guys are using that's in this room?
We currently have the Swift app with PCC, so point click care, till the end of the month. Anyway, so that's why I chose that for now. So it does an amazing job of taking a photo with, of course, accurate lighting, and it does the measurements as well. And then it throws you into the assessments piece. So it's, I love it and very sad to see it go.
Should you and I have a conversation as to what the backstory of that would be? We don't want it going live here, right?
Okay.
Okay, so how about data quality and reporting? Christine Hagner just talked about data quality. Oh, I'm going back to her again. This is part 2 of her talk. So what do you love about the technology piece in enabling you for data collection?
So I will say I was remiss. I didn't address the work of my project manager that is working with me on my team. Because I don't do data and quality reporting, but he does all of that work. And you said I had to pick one that was the most important. And for me, this is what I can use to enact change. And so I need to have good quality data reporting and people who can do that for me because I'm not great at graphs and technology, as you've seen. But that's the important part for me.
So thank you. And one of the things that are findings from the research that has been done for the environmental scan was the lack of data collection, and of course the how data is collected, how it's stored, how it's synthesized and utilized in different facets. I think that's one of the things that we want to tackle in when we talk about policy change in the white paper, right? Okay, over to you, Sharon.
Next slide.
Yep, next slide.
Okay, so technologies for pressure injury assessment and management. There's been plenty published in the literature for the different technologies that are used, including support surfaces, monitoring and sensing. For example, looking at subepidermal moisture scanners, repositioning and monitoring. So one of the posters outside is looking at the development of technologies for repositioning and monitoring, and there are other repositioning and monitoring technologies that you probably have seen out maybe you've heard about them, for example, the LEAF system. There's also technologies including clinical decision supports using AI and machine learning algorithms. And also there are some educational technologies out there as well to help provide education for individuals living with or at risk of developing pressure injuries and their caregivers. So which of the following technologies do you use most for early detection of pressure injuries?
So early this morning, Dr. Joyce Black covered most of these, and even Dr. Gareth Sibbald. So you have either ultrasound, thermography, subepidermal moisture, all of which are looking at early potential signs for pressure injury development that are difficult to see with just your naked eye or 4 eyes or 6 eyes whatsoever. So we want to leverage that opportunity to detect them as soon as possible. And I'm seeing a lot of reds on the far end of the spectrum there, Sharon.
62 people don't use any technology. 65. And just so you know, I think there's over 200 people online, right? Something like that.
Any comments about this, Sharon?
I don't think I'm surprised, maybe, or to some degree. Maybe the people who are, I don't know, the not participating, the other 200.
Actually, I'm just gonna have to ask Dr. Joyce Black, what's the US landscape in adopting technology, if that's okay?
Well, in the US, we are not paid for hospital-acquired pressure injury. So the best that we can do is use technology to determine that it's present on admission, but not visible to the naked eye. So that's the deep tissue injury story. That's where these products come in for us, and they're huge for that reason.
The stick.
A large stick. And a follow-up question to that is for us Canadian colleagues and friends, if there is a message that you'd like, for our policymakers to hear that we can utilize to leverage in order for us to get appropriate funding, for example, for these situations to prevent pressure injury development, what could that be for us?
Well, I think the first thing you need is the data that tells you what type of patient has what type of wound in what setting. So working with the ER, somebody was talking about the ER a few minutes ago. They are one of the most difficult groups to work with because they're saving lives, not undressing people. And so to work with those entry points into your hospital system, figure out who's ulcerating, who's that high-risk group, and then drive your policy off of that, because that's the way you're going to get the biggest return on investment.
Great advice.
Thank you so much. And I know there's somebody giggling right back here, Dr. Sibbald. And I just want to get Dr. Sibbald's perspective because he was talking about thermography not a while ago, a potential cost-effective strategy to preventing and mitigating pressure injuries. Dr. Sibbald, do you want to just add a couple of points for that?
That's a difficult thing because sometimes pressure injuries and some theories may relate to relative ischemia at the time of the injury itself. So the temperature can fluctuate, that I think you really need to look at a number of conditions on the skin. And sometimes it's a change in color or texture or edema. Sometimes it relates to the patient having pain or feeling a different type of sensation. And I think, looking at skin health in general and looking at the skin, and we do know that if you don't moisturize the skin, you're more likely to get injury if you've got a lot of heat, if you've got a lot of bed trash. And I think there are lots of things that you can do that can prevent injuries. And, start back with really doing a good examination of your patient.
Thank you, sir. Over to you, Sharon.
Okay, we're going to move on to the next question. So are you currently using artificial intelligence for pressure injury prevention and management?
The no's are rising. A couple of yeses here. So for the couple of yeses, is there anyone in the room that has answered yes? Oh, I'm going back to Christine.
Oh.
Okay, Christine, tell us more about that.
Okay, twofold. Our project manager uses coding, and he bases it through ChatGPT in terms of not having to actually learn how to code, but just kind of get examples of code so that way he can very quickly create the sort of graphs that we share back to our sites. And the other thing that we use it for is creating educational bathroom readers for sites. So that sort of 30-second or less poster of, what are we trying to achieve? Our clinical educator is a big fan of using AI to develop those posters.
Great. Now, does that also involve looking into potential literature sources? And how do you find some of the sources that are being pulled by the AI specific strategy? I'm seeing movement there, and can you explain more?
They're horrifying. Don't use them. The one author might be accurate from maybe 1992, or the date might be accurate, but everything else is inaccurate. So the ability at the moment of the AI that I've used to try and do lit searches, when you try and actually source that article, you will not find it, unfortunately.
Yeah, they're hallucinating. We call it hallucinating.
Sharon, you want to just add on to that one because I know you're also tech savvy. You want to just add a couple of comments there?
Yeah, just a lot of I mean, there are some AI literature, stronger AI literature sources, such as Undermine AI. That one pulls actually pretty good articles, but a lot of the times, if you're not using a good AI tools, many of the AI algorithm or whatever they give you out will actually hallucinate and make things up. So that's the term called hallucination. So
I've got some horror stories if anyone is interested in citations that are made up by AI. I don't know, New England Journal of Medicine, the article, the DOI, all completely made up, doesn't exist with checks. And I know that the Canadian Journal of Wound Ostomy Incontinence have also now had articles submitted where references just, if you fact check the reference, it doesn't exist. So
yeah, I unfortunately had an experience like that, and then it was submitted to me for review, and I was looking through the literature, and I was like, oh, I've never read that article. That's really interesting. And I contacted the author, and they're like, that's non-existent. It's AI generated, because I couldn't find it, so I was actually asking the author. But anyways, that was shocking to me to some degree, but it really opened up my eyes to what's really happening.
And I think the AI is only as good as the coders themselves have developed it too, right? So there's a lot of flaws, and of course the data that they will produce and resources will not be valid.
Mm-hmm.
Yeah. Okay, passing it over back to you, Sharon, since I'm all the way back here.
So how likely are you to adopt AI in your okay, now that we said all the bad things about it, how let's think about the positive.
Yeah, I think let's just focus on the positive side.
And you had good prompts. How likely are you to adopt AI in your practice?
Just look at that photo there of that cute little robot enticing you to adopt
I
him.
feel like his neck is
or her.
rotated like 90 degrees to the left, and as a physio, I don't think that's anatomically correct, but okay.
But it's AI, everything's
Yeah,
possible.
yeah.
Okay, some promising movements there. And by the way, it's being averaged,
Yes.
right? Okay. At a scale of 1 to 10, I think.
Yeah, we couldn't do 0, but didn't allow us 0. Sorry, we're dealing with it. It was
That's
not
AI
designed
stuff.
with the user in mind, so. Got 81 people who have contributed.
So you're looking at a potentially close to 60% of people looking to adopt AI. So after the horror stories that we have told them, they're still going to adopt it. No, I think under the right circumstances, I think, as technology becomes more savvy and things are becoming smarter, and under the right hands of people developing the coding of system of it, I think there is potential that we can utilize it to support a decision-making process. Okay.
Okay. So what do you think are the potential benefits of the use of technology for pressure injury prevention and management? So what are the potential benefits?
So we have early detection, consistency, efficiency, monitoring.
Yeah.
No human error. Ease of work. No human error there. We'll talk about that later. Ease of work, better outcomes, accuracy, simplified process. Yeah, I'm going to walk around here. Anybody would like to add a comment on the things that I've added here that I'd like to share about the potential benefits of having technology in pressure injury prevention and management, aside from what we have talked about so far? Anybody like to comment? I'm going to go back here. Dr. LeBlanc.
If you call me Dr. LeBlanc one more time. I think one thing that we haven't really, maybe you did it when I had to step out to take a call, but one of the big things that I'm seeing it used with is translation. So I work in long-term care. I have a lot of residents who, with their dementia, they have reverted back to their language of their birth language, and they may not understand English or French anymore. And when we're looking at prevention, management, and interactions, when you can use AI translation, all of a sudden you can communicate.
Yeah.
So communication can be really key, or with family members who English or French may be their second or third languages. It opens a whole avenue of communication where you can get better collaboration.
Excellent answer. Oh, Candy has a.
Awesome. Thank you. Okay, Candy.
Just to add to that, also like translation to the staff as well, that when you, if for Mimosa in particular, even with the Provisio, you can show them that there is risk or an early pressure injury developing. So it just visualizes what they can't see ahead of time. So it's helpful that way, I think.
And speaking of Mimosa, we do have Mimosa in-house. And if they can share just a thought about that, about potentially benefits of technology, generally, technology.
Thanks, everyone. Yeah, I think it's around that early detection. There's the data that's associated with it. So having a standardized tool to track, treat, document, I think really, we get the intel at the point of care to inform treatment decision making. We have the data to support the monitoring and the tracking. Also, evaluating if our methods and treatments are working. So we have this data that can be used not only at the front line, but at an organizational level too. So yeah, I think that's where the potential is.
And I also think, just if I can add, and just building on what Dr. Kimberly LeBlanc said, if to have patients also, for example, if they're tracking their own wounds and they're able to see their wounds are healing or not healing, that's also a way that we can try to engage with them as well.
And I think one of the possible challenge I could present for our industry partners is that if the technology and innovation that is presented to us can help support early detection of pressure injuries, I think building some partnership with healthcare organizations to kind of create a business case on how this can actually minimize the costs of treating pressure injuries as opposed to preventing them. So I think that partnership that can help organizations to adopt specific technologies would then increase the likelihood of us using them in the future to then mitigate pressure injuries. Okay, so on to our last, I think, question, or not yet.
Oh, so we've just identified not using fake references, some benefits of technology, including providing real-time data, supporting clinical decision-making, promoting workflow efficiency, improving patient adherence, support reductions of HAPIs, promote quality of life of patients and clients, and reduce costs. Okay. Oh, geez, do we go back?
Everybody close your eyes.
Close your eyes. Yeah, sorry.
There.
So what do you think are the challenges related to the use of technologies in pressure injury prevention and management? What do you foresee as the challenges?
Of course, number one,
Oh,
cost.
turn on investment. Lack of human judgment. Oh, yeah.
That if you use ChatGPT for your assignment, I will catch you.
Can we reinforce that in more volume?
For all the students in the room, if you use AI to complete your assignments, I will catch you. We run all the assignments through detection software, and you do not want to end up in my office. You just don't want to.
Are there any students in the room, by the way?
Of Dr. LeBlanc.
Okay, I'm seeing kind of like people are hiding, shying away. Okay, so that's an indicator. Oh, okay, there we go. So, just a friendly reminder, right?
Okay. Oh,
Sharon, take it away.
I'll take it away. Sorry. Oh, taking it away in the wrong way. Sorry. Okay, so some of the potential challenges of adopting technology could be the costs, financial constraints, system infrastructure, and the impact on clinical workflows and staffing and competing needs. Oh, so sorry, here are the references, real cited references.
So thanks everybody for your mini activity that we just had there. And I think it's a good eye opener to us in terms of how people's perspectives are with technology, whether to adopt or not to adopt. But of course, there are a lot of benefits that technology can provide, not only for efficiency of workflows, but also allows us to leverage that opportunity, that open window to prevent pressure injuries and minimize the gravity of its extensive delays in healing and the quality of life of full thickness pressure injuries if they do develop. So thanks everybody for your participation this afternoon.
Thank you so much, Josh and Sharon. We don't have any questions in the chat, and I think seeing as we had such great conversation in the room, perhaps we will go on to our next speaker. I'll let Josh introduce.
I will actually introduce the next speaker here. And unfortunately, I have to repeat myself this time around because we're going to talk about shifting the culture on pressure injury prevention and management in long-term care. And it's going to be talked by Dr. Kimberly LeBlanc. So Kimberly LeBlanc, the current academic chair of the Association for Nurses Specialized in Wound Ostomy and Continence Canada, Wound Ostomy and Continence Institute, an advanced practice and certified wound ostomy and continence nurse with KDS Professional Consulting. Kimberly is the current president of the CNA. She holds a Doctor of Philosophy in Nursing from Queen's University. In 2020, she was inducted as a Fellow of the Canadian Academy of Nursing. And in 2025, she was inducted as a Fellow of Nurses Specialized in Wound Ostomy and Continence and a Fellow in the American Academy of Nursing. In 2025, she received a King Charles III Coronation Medal for her contribution to nursing in Canada. Kimberly is a past president of the International Skin Tear Advisory Panel and past co-chair of the Canadian Pressure Injury Advisory Panel. She is currently a board member of the World Union of Wound Healing Societies and the International Wound Infection Institute. Kimberly has lectured extensively on wound, ostomy care, and is considered a global expert in wounds and ostomy issues in aging population, and has numerous publications and book chapters on wound, ostomy, and contents-related topics. Please a warm welcome to Dr. LeBlanc.
We have this ongoing thing where I keep telling him my name is Kim. Can you make sure Vita has a mic?
Yes.
Thank you. So I'm going to start this by, first of all, acknowledging that I have the privilege of living, working, and playing here in the unceded territory of the Algonquin Anishinaabe peoples, also known as Ottawa. Here are my disclosures. And today, what I really want to do is take a step back and maybe have a bit of fun with this, but also look at how we can collaborate as teams. So first and foremost, can I get all my swans to stand up, please? Because there's a lot of you here. Okay. Come on. Yes. So she moved. She was there. I'm like, she was just right there. So thank you all so much. And this is we're now on cohort 13, or about to start, which is huge. It's come a long way. Some of you were in cohort 1, whether you liked it or not. Some people I did bully into joining the program. I'll fully admit that. But when we look at our SWAN program, we're often asked about the difference between the NSWACs and the SWANs. So now I'm going to ask all the NSWACs in the room to stand up. All the NSWACs. There's a fair number of you. So we also have a fair number of NSWACs in the room. And we have a couple of NSWAC students as well, which is exciting. So, when we look at this, they're two complementary programs. They have been designed to collaborate. They've designed so that we work together as a collaboration. So yes, there's differences between the programs. One's at a graduate level, one's at a post-RPN or LPN, depending on where you live in the country level. But the whole concept is that we will work in a collaborative team. And you'll notice under CNA certification, I have the SWAN list as pending because I'm working very hard at that, and I'm hoping to have something exciting to announce before I end my CNA term, is what I'm hoping for. So when we're looking at the prerequisites, I think most people know this. I'm not going to go over this for the sake of time. But we're very proud that both of our programs are accredited by the CNA. The NSWAC program is also accredited by the World Council of Interstomal Therapists. And for the SWANs in the room, know that our SWAN program is currently with their education board for approval to get accreditation as well. So we're looking at being loud and proud and really taking this internationally. So where do you live by generation? By geography, where are you living? The majority are here in Ontario, but we're making inroads elsewhere. And we're hoping that as the word spreads, that people are really going to see the importance of this collaborative team. But then we look at where you're working, and this should be no surprise that the majority are in long-term care. And we see a huge role in community as well. Our practical nurse colleagues, or my practical nurse colleagues, our colleagues, do the bulk of the hands-on wound care. So it makes sense that we should have specialization in that area. I'm proud of the work that we've been doing. So when we look at the power of collaboration, we have Anne Marie, one of our first swans, and we have Vita over here, one of our leads. So for those of you who don't know Vita, standing in the back, I put her on the spot today because I love surprising Vita. So Vita is our lead for the swan program. She's Mama Bear. She takes care of all the swans. And, you know, I love this picture because it has been such a collaborative effort. And NSWACs and swans, we work together. We learn from you, you learn from us. The idea is that we're going to be there to mentor you, to help you through ongoing consultation and case review. But the flip side is the swans lead the bedside assessments, preventative initiatives, and staff education. Through regular communication, this ensures that we have a consistent, evidence-based care. And this collaboration really builds confident teams that are competent, we have continuity, and we have this ongoing dialogue. So I'm going to ask some of my team here to stand up because I can see my City of Ottawa team. So if you guys all want to stand up. So once a month, I round with these lovely ladies, and they have other colleagues as well. But we have NSWAC students and we have swans. They're my retirement plan, in case anybody's wondering. But what we're trying, you guys can sit down now. I just like embarrassing people. But the plan is that we will have this collaborative team. And what I've noticed is my consults have gone down. My consults have gone way down. This is a good thing. You know, some people have said to me, Kimmy, you're in private practice. Why do you want your consults to go down? I said, because I want appropriate consults. And anybody who knows me knows that a lot of my research is around skin tears. I got involved in skin tear research because I used to be asked by the nurses in long-term care, can you go and see Mrs. So-and-so? It's just a skin tear, but it's not healing. So well, if it's just a skin tear, why are you bringing in an advanced practice nurse to do this assessment? And, you know, what we found over time was that it was because they weren't being managed appropriately and they were becoming chronic and complex. I don't remember the last time that my team has consulted me now for a skin tear because A, they manage them immediately. When they do become complex, they put the right things in place really quickly and they never get to the point where they need me. And to me, that's a win-win situation because our residents their wounds are healing faster. They're also putting huge preventative pieces in place. So when we look at the NSWAC teams, you know, really the NSWAC should come in as the expert who's coming in for those really complex that go beyond the scope of a practical nurse, whereas our practical nurses should be managing the day-to-day. More importantly, really working on the education piece with the other staff. And together we form a model of wound care excellence, in my humble opinion. And I'm going to have Vita jump in here because I know she's chafing at the bit to add some things.
Just maybe I have an advantage because I know what my swans have learned, and they are my swans, every single one of them. But it means when I'm getting a call from a swan, I know the assessment they're giving me has been done, is accurate. They have thought of potential causative factors that they need to consider. They have put prevention and action into place, and they're getting me because something's not progressing appropriately, or maybe they would like just reassurance. Yeah, have you thought of everything? Have you thought of what potentially could be leading to having the issue? And it's the difference between my homes where I have a swan, I may get three referrals. My homes where I don't have a swan, I'm getting called in for one, and the minute I'm in the building, it's, oh, I've got 19 other people for you to see. Going up to a unit and saying, okay, you want me to see Mr. Jones? And, oh yeah, I heard he's got a wound. I don't know where it is. Let's strip him down. So knowing that my swans are based on evidence, that they are doing the assessments, getting prevention in place faster, preventing things from getting as complicated, as well, they're tri-specialty. So if somebody's got a wound on their coccyx, they've learned about continence and the impact of continence.
Tell
and
your
getting
continence
that
story. Tell your continence story.
So I walked into one of my homes and I was asked to see a wound. And I had one of my swans and I had the floor nurse because I don't see anybody without somebody from the unit there. It's a teachable moment. I like those teachable moments. And I said, oh, we've got a pressure injury. Are they incontinent? And the floor nurse said, yes. And my swan said, yes, I think it's probably stress incontinence and functional incontinence. I think I'd like to put this in place. And I think that's going to help, and we're going to get better healing with our pressure injury. And the floor nurse is looking there like a deer in headlights. You mean I can't just put them in a brief? No, that's not going to be best practice. That's not going to be best for the patient. That's not going to be best for the care. I need my person who's got that extra education on wound ostomy incontinence getting prevention into place. And my swan got buy-in from her staff, then realizing, wait a second, you've got extra knowledge. I need that. So it was a win-win-win.
I think, you know, the importance of all this is the speaking the same language. So that when we're speaking the same language, so if, you know, often NSWACs, we will have to do some things remotely. So if we're doing remote consults, it's really great when we can all be speaking the same language. And I can trust the assessments that are done on the other end are going to be the same as if I'd done it myself. So to me, that's a huge importance of that collaboration, having those eyes and ears on the site so we can very quickly, you know, implement and these interventions. And you can see Lara, who's our NSWAC student on the screen, and Kathy. This is just the other day when we were rounding together in long-term care, and I threw them and said, I need a picture for a presentation, and threw them in a room and took a picture. But it's a cycle of learning and empowerment that benefits both the staff and the residents. And more importantly, you know, I've been at this now for, well, oh my goodness. It's been going on 26 years that I've been working as a consultant in long-term care. And I've yet to move the needle in terms of getting our PSWs to really implement change, no matter how much education I put in there. However, as soon as we implemented the SWAN role, now all of a sudden we have somebody who's not just there 4 hours a month and is a bandit on a hemorrhage. We actually have someone who's there every day. And we're starting to see a culture shift and change, which is really important. So education is at the heart of this success, but it's more than just that. We know that our SWANs complete specialized coursework, and I know many of you still have trauma from it. It was a hard course, I understand that. I get complaints all the time, but they completed this very intensive work. But we also know that when you have that knowledge and you're feeling supported and confident, that you're going to engage more deeply. And then we get these preventive strategies put in place. So it changes the culture from a reactive wound and ostomy incontinence management to proactive skin wellness. And that's our real goal. We want to look at overall skin wellness, and we want to be proactive rather than reactive. So in long-term care, there's challenges. This is my mom and my late aunt. We know that 8% of long-term care residents experience pressure injury at some point in time. Over 25% of pressure injuries in long-term care develop 1 week after discharge from an acute care hospitalization. Okay, those are some of the harsh realities. When you live and work in long-term care, and often I'll get a calls that say, Mrs. So-and-so fractured her hip, she's gone out, we're expecting her back in a week. Can you come and help us put a plan in place for the pressure injury she's going to come back with? And you know, the flip side of it is acute care also gets some nasty wounds from long-term care and from community. And what I would like to say is let's stop the blame and let's start collaborating together. Let's provide better communication. So I mentioned earlier this morning when Dr. Black was speaking that I do legal work as well. And a lot of it could have been, I look at a lot of the cases and I think, oh, if only there'd been better communication, if only when the long-term care home sent Mrs. Jones into the hospital, they had also written on that transfer patient, she had a pressure injury 4 months ago that we've been able to close. It was located here. These are the things that we've been doing. Can you please make sure that she's offloaded from that area? Then those poor overworked nurses in the emerge can maybe try and put something in place while she's in the emerge for 48 hours to keep her off. Now, we would like to think that they would identify someone at risk and do it anyway, but isn't it nice if you can give them the heads up? And the flip side of it is, it'd be really nice if acute care could send back to long-term care, oh, by the way, they have a pressure injury. this is where it is, and this is when it started. Because often it's surprise, surprise when we get them back. So, but let's rather than blame, let's try and collaborate. Let's send better notes back and forth to one another. We know that chronic wounds increase pain and infection. And we have a team right now that is working on looking at us. We're doing a scoping review, looking at the intersection between wounds and dementia. So does having dementia increase your risk of wounds? And what does having a wound do to your dementia? So we're looking at this intersection, and what we're seeing, what's coming out loud and clear, is that yes, having certain parts of dementia does put you at increased risk for developing a wound. But if you have a wound and you have dementia, you're going to have more aggressive behavior. You may have pain, but you're going to express it in a different way. And how you allow us to manipulate and work with that wound. And all of you working in long-term care are going, yep, this is what I see. So these are some challenges that in the community and acute care, you probably don't see as intensely. Yes, you see patients with dementia, but you don't see the concentration that we see in long-term care. And staff shortages everywhere are a problem. So one of the solutions to overcoming some of these problems is this NSWAC-SWANS collaboration. It's a winning combination. We're seeing the results. What's known is that there's been lots of studies done, particularly by Joyce's colleagues in the United States, showing that when WOC nurses are involved, there's improved quality of life for patients, teaching, mentoring, cost reduction, improved efficiency, improved wound outcomes, improved incontinence outcomes, advanced treatments, research, and leadership. And what we don't know yet is the impact that SWANS and the NSWAC-SWAN teams have. And so this is where I want my area of research to start to focus on now, is really looking to see what kind of impact are these teams making within the Canadian healthcare system. And, anecdotally, we know that we are making a difference. So, when we see what we're seeing is that across multiple long-term care sites, these models have produced measurable improvements. Facilities have reported fewer number of wounds, faster healing, reduced hospital transfers, but perhaps most noticeably, they're describing feeling more empowered and more valued. This is a workforce development strategy that improves both quality and job satisfaction. But we don't have anything that's publishable yet, and this is what we need to work on. So, we're seeing decreased wound prevalence and severity. We're seeing decreased hospital transfers and associated costs, increased healing rates and resident comfort, increased nurse satisfaction and retention, and consistency in quality and documentation and planning. So I'm going to have Pierre stand up. Where's Pierre? There he is. So this is Pierre, one of our first SWANs, and this is Pierre's data. So Pierre, I'm going to get you to take the mic from Vita there and just maybe walk them through this a little bit, because this is your data, this is your study, and he deserves so much kudos for this. So I'm going to hand this to you for a minute. He's giving me the stink eye too. Go for it.
I work at long-term care St. Louis at Weir Health, and I was graduate for this one course in 2022. And after that, I was appointed to a full-time position as SWAN. So as a lead of skin and wound program. So I have to start somewhere. So when the first thing we done it's education. So we develop education for PSW, 1 hour education module, and after that for the registered staff 4 hours. So we give the education, and after that we put the prevention plan in place. So we use the PERS. That's the risk assessment we use in most long-term care. So at the admission, every resident who is admitted as a PERS. So in the past, we had the PERS, but when we fill the PERS, we do the assessment, there's nothing has been done. So after we have a resident who is at risk, we put some prevention plan. So what the thing we look at repositioning, and we look at the support surface, And we created posters. We developed a turning clock. So it's a visual for the staff when they see every resident who is on the program. So every time they see the poster, they know they have to reposition the resident. We created the offloading poster for every resident should be who is on the program should be the heel should be offloaded with the pillow. And after that, we created the interdisciplinary team. We call it the Wound Squad. Include OT, PT. We have our nurse practitioner here today with us. And we have some managers too and supervisor. So at the beginning, we meet every 2 weeks. So as our wound rate has decreased, now we meet every month. We develop wound care, a skin and wound toolkit. Include information for the staff. And most important, I have the privilege to have two great mentors, you and Vida. So every question I have, I call you, and when I have a wound I can deal, I do and consult. So that's our journey at Resident Saint-Louis.
Thank you. So I wasn't sure if Pierre was coming today, so he had very little notice to get this prepared. So thank you so much for explaining your journey with us. And, you know, I think you can see the bar graph on the screen is telltale the amazing job that they have done. And, you know, rarely do I get consults now from his facility. When I do, it's because they're either super complex or it's a family that they need to kind of make sure are happy. But for the most part, you know, developed a sustainable program that is making huge inroads and improvements. And I think that, you know, you were really the poster child for what a SWAN can do to change culture within a facility. So I think once again, a big round of applause for Pierre and his team. So, you know, when Vida and I say we're proud of our graduates, we certainly are. So, you know, some of the benefits of this though are there's a natural segue. If you have fewer wounds, you're going to have fewer supply and treatment costs. If you have fewer wounds, you're going to have fewer ER transfers and hospitalizations. If you have staff that are satisfied and happy, you're going to have better retention and recruitment. Therefore, you're going to end up with a sustainable workforce model. And these things, and you know, if I put on my Canadian Nurses Association hat, these are things that are very important. When we look at the nurse retention toolkit, these are some of the things that Dr. Lee Chapman outlined that we needed to do to keep our nurses. So we need to continue building a culture of skin health. So from wound care to skin wellness. We need to be prevention-focused care models, so doing the kind of education with your teams. We need consistent assessment tools and documentation practices so that we're all speaking the same language. Ongoing mentor education and mentorship to sustain long-term success. You can't do the one and done. It never works. There's staff turnover. You need to make sure, and you know, we saw earlier from our BC model that when you lost that champion, there was a bottom out. So you need to keep going. And having our SWANs educating their peers, focusing on health promotion, this really shifts that mindset from being reactive to being proactive. So prevention becomes the key. So I polled some of our graduates. I asked for some quotes. So things like, before the SWAN program, I often second guessed my wound assessments. Now I feel confident in what I'm seeing and what steps to take. As a SWAN, I see myself as the bridge between the frontline team and the NSWAC experts. Together, we ensure consistent assessments, timely interventions, and better outcomes for our residents. The SWAN training gave me the language, the knowledge, and the structure I need to speak up and advocate for residents. I feel empowered by my role. I didn't know how much I would grow. The SWAN program just didn't build my skills. It built my confidence as a leader in skin and wound care. And these are just some of the quotes that we had. And, you know, the other day I had the opportunity, we had a very complex case at a long-term care facility, and one of our swans who's listening online, Angela, called me and she said, okay, I just want to make sure everything is doing right. And she had all the right labs she needed to request from the physician. She had all what could be the possible differential diagnosis. She had everything laid out so well that I thought, my job here is done. But she probably saved this resident's life. Right? She was so accurate in everything that she was doing, and she immediately was able to communicate with the physician who understood the importance and the risk that we were looking at. So these are the kind of things that we see from our swans that is just so heartwarming. So moving forward, we want to expand the NSWAC Swan Lead model across all long-term care networks, not just in Ontario. We want to go national, baby. We want everybody to be doing this. We want to continuing measuring outcomes, and I challenge all of you who are working in long-term care with NSWAC Swan teams, or even just, not just swans, but swan teams, to start collecting data. We can help you with it. I now have a chief research officer who can help us, Dr. Kevin Wu. So we can help you design a study. We can help you publish your data. We need to continue to invest in education and mentorship. And this can be ongoing. We have Sharon, who's our board representative for the swans, and we have our swan community of practice lead, Anne-Marie. If you're a swan or want to be a swan, come and see them. Get involved afterwards to keep growing the swan as a role. Because together, I think we can make huge strides and huge differences. And many of you in Ontario may have seen the big announcement that was Kathy and I were privileged enough to drive to Toronto for on Tuesday. So they've just announced some massive funding for swan education in long-term care. If you want to be a swan, or if you want someone, you know someone who wants to be a swan, who working in long-term care. Sadly, this is from the Minister of Long-Term Care of Ontario. So it is only for practical nurses working in long-term care in Ontario. It's not for community, it's not for retirement homes, it's not for acute care, it is for long-term care, but we have a funding model now available. So that is it, but thank you all so much, and thank you to all of our swans and NSWAC teams. And I've given them back some time.
Okay, we have time for one or two questions, and on behalf of CPIAP. How can we encourage long-term care administrators to encourage their nurses to take the SWAN program? We see so much potential with our RPNs and our long-term cares, but they were never offered by management to take these courses, even though we promote it.
So I'm going to have Vita start with that, and then I'll finish up.
We need to do a better job of explaining to the admins what is a skin wellness associate nurse and how they can be beneficial. For many admins, honestly, it's okay, what is this going to do for me? I can send this person to get education, but how is this going to help? And explaining that you are bringing knowledge and skill and expertise into the building, that you're going to have on-site expertise, that you're going to have the ability to have somebody supporting and teaching their peers, because there are very few long-term care in Ontario. Outside of Ontario, there might be more that have an NSWAC on site. So having to wait until your expert can get in is delaying care. It's impacting your clients. It's going to make things worse. Having somebody on site who's got a foundational and ability to deal with stable things and put prevention in place is going to be the best thing for your clients, your budget, your staff.
And I think, you know, looking at it as well, as an NSWAC, sometimes I feel like I'm a Band-Aid on a hemorrhage. I'm 4 hours a month in a long-term care home, or I'm called in for a one-off. There's no sustainability. So when I have, you know, so for instance, when I'm called into Residence St. Louis, Pierre and I are speaking the same language. He's calling me in because he wants validation of what his plan is or something super complex. We work together in collaboration. We put in a plan, and then he's able to follow through with it, and he'll call me back if there's a problem. not all facilities have that. So it's, do you have that kind of continuity? And you normally, how I'm able to convince them is by talking about not only the cost savings, but the improved resident satisfaction and family satisfaction, and that wounds are painful. They, you know, as we talked about, it makes dementia, heightens dementia symptoms, which has a whole other, like it's like a roller coaster domino effect, right? So we really try to promote the concept of promoting health. Sometimes it can be a hard sell, but we're getting there through baby steps. So Island Health in on the island in BC, both of their long-term care homes have swans, and they're seeing the difference as well. And they'll be presenting their study out in the conference, and they just won a poster award for a conference they had out there for all of the work that they had done. So I think the more we get published, the easier it's going to be.
Thank you so much. So at this time, we're going to take an exact 15-minute break. We're going to be back at 3:55.
Okay, so welcome back to this last session. And it's my pleasure to moderate this session here. Are pressure injuries avoidable? And we have our all-star panel here. And we don't have to introduce Dr. Black, Mr. Brown, and also Dr. Garrison anymore, because they were introduced earlier. But I'd love to introduce Caleb Boileau, who is, was the president of the Canadian Pressure Injury Advisory Panel from 2023 to 25. She's a registered dietitian with a Master of Health Sciences who's completed the IWCC course before. And Caleb currently practices as the interprofessional practice lead at Toronto Grace Health Center, where she leads the interprofessional wound care team, serving patients with chronic critical illness in complex continuing care, rehab, and palliative care settings. In her current role, Caleb supports the interprofessional pressure injury prevention and care across the organization by delivering staff education on pressure injury prevention, wound assessment, and management. There's a lot more about Caleb and her achievements, but in the interest of time, she said, just focus on that paragraph. So anyway, but before we start though, I think that we would love for you to do another Mentimeter. Okay, Caleb, go ahead. What?
Are pressure injuries avoidable?
All
If
right.
they answer this, then we're done.
Yeah. So we just kind of want to hear from you guys to start, from strongly disagree to strongly agree. Are pressure injuries avoidable? You're going to hear about what we think.
The link again, because
Oh, yeah, yes.
the quickest song.
Here we go.
I know you guys cannot see the results, but I saw the results right away. My goodness.
People were fast.
Okay.
I pre-voted.
Oh, boy. Wow.
So most people agree.
Yeah.
Right now we're
preventable.
Yeah, preventable. Yeah.
So for 4.4 out of 5.
Yeah. Okay. Strong numbers here.
Well, the lawyers would agree with you.
Joyce, do you want to start us off?
Yeah.
What is our?
Maybe I'll just let the team know how it works here. So we have until 4:25. And so what we're going to do is we're going to ask each panel member just to give a brief statement on that. And then after that, we'll ask that question, are they avoidable? We'll ask them to kind of talk about that. And then we'll also ask the question, are they unavoidable? Then we'll take some questions. And I have some questions as well. Okay, go ahead.
So you want me to start with answering those questions? Can I start by defining?
Just the statement, yeah.
Yeah, sure.
Just your statement first, yeah.
Oh, yes, the answer is pressure injuries are generally avoidable, but I don't want you to set your organizational goal to 0 because you'll never make it. The definition, though, is one in which the patient, to be avoidable, the patient enters your facility with intact skin. So that's why it's so crucial to do a skin assessment. Then you have to have an accurate risk assessment. They can hear me. You have to have an accurate, they can hear me in the other provinces. You have to have an accurate risk assessment, which means the Braden has to not only be done accurately and drive a care plan that's appropriate and targeted. Then you have to do what you said you would do. And then you have to document what you said you'd do. There's the whole issue right there. So when you look at a legal claim, that's exactly the process you go through. And yes, there are unavoidable pressure injuries, but the majority are avoidable. And as I said today, the majority start in the ICU because the priority is not skin.
Okay. Thank you, Dr. Black. Now, who'd like to go next to give us a general statement?
Bob, do you want to go?
Sure, it'll be short. I'll just go by my experience. I'd say normally they're avoidable until this year, where it was a hot summers, a hot, humid summer here in Ottawa, and that has
Kidding.
no.
So hang on a minute.
Yeah.
It's freaking freezing in this room.
I said it was hot summer.
Yesterday?
Yeah, it's yesterday. Anyway, so other than that, because unless you're gonna stay in air conditioning all the time, not go out, it's kind of a little tough. So yes, and no.
Okay, thank you. Hayden, would you like to go next?
I like it's a hard question. I think if I were to have to say like yes or no, and there was no in between, I'd probably say no, they aren't avoidable. And that, like, for me, it's like, there's hundreds of risk factors that go into putting a patient at risk of pressure injuries. And our patient population today is so complex, and there's things that we can't fix, right? You said earlier today, Bob, when you were young, you never saw any problems, but as you aged and climate change, apparently, I didn't even think about that when I was preparing. But yeah, like there's just so many things that are out of our control. And by the time that I, as a clinician, see my clients or my patients, there's only so much that I can do. And I feel like I want to say, like, I might have been able to prevent this pressure injury had I met you 20 years ago and we fixed XYZ to prevent, your diabetes and to prevent your kidney disease and to stop the progression of these diseases and, to perhaps support your healthy body weight and prevent you from becoming morbidly obese. But there's just like so many things that go into this, and on like a unit level and on a like moment level in the time that we're caring for these patients, I don't know that it always is preventable.
Wow, Caleb, I think you're actually trying to anticipate my question.
Well, that's too bad.
Thank you. Now, Sharon, you're next, please.
Yes, that is a very hard question to answer. And I do believe that not all pressure injuries are avoidable. I think there are situations where risk factors have been addressed, but there are certain situations where there is nothing that we can do as clinicians to help, for example, have a patient reposition or a client reposition if they don't want to be repositioned, or maybe they have cognitive impairments and they don't understand. Or maybe the caregiver has gone home with the individual and they haven't received enough education and they're not able to access any information about pressure injuries, or they didn't even know what they were even before they recognized a pressure injury. So yes, maybe with adequate education and all factors being optimized, I think that maybe in those cases they could be avoidable, but I don't think all pressure injuries are unavoidable.
Thank you. So I'm going to now get more specific. You guys kind of talked about, how some pressure injuries are avoidable and some may be unavoidable. But let's get more specific. Can you give us some situations where they truly are unavoidable? Yeah, just be quick. And then we'll go to the next round to talk about those which are avoidable. So
yeah, to me, the unavoidable pressure injuries occur in patients who absolutely cannot be moved and it would cause them harm to move. So the unrepaired cervical fracture, the fractured pelvis, the open chest, the patient with very severe intracranial pressure, and if you move them, their brain's going to herniate. Those to me are absolutes, and even the U.S. federal government has heard that. How about that? We're working on the concept of septic shock as a risk factor. We've got a little data on that, but it doesn't have the state power that the other cases I gave you do.
Okay. Thank you. Bob?
You?
Yeah, well, I'm not sure how to. I don't have enough background in it.
That's okay.
Yeah.
All right. Thank you, Caleb.
I think I would just highlight, like the end of life when I think of like the non-avoidable. I think, again, those situations where they might not make it out of this, but also like the actively dying, you'd see the people who are, they're going into end stage organ failure. And now, of course, we might also have skin failure here. So I'm not starting that. I'm just saying, I'm like, I don't know.
I have to go out there and talk.
I'm like, I don't know what exactly that is, but I hear it's a thing.
Leave it at that.
But I think this is like, when a patient's like in all this pain, like our goal is not to be piling on these preventative strategies. It's for comfort and to like support them potentially from, a psychosocial perspective more than a physical at that point, like from a pressure injury perspective. So at that point, I don't think it's preventable. Yeah.
Thank you. Sharon?
I think my colleagues have spoken very well, and I don't have any further comments to add, but I do agree that there are situations where you can't avoid pressure injuries because maybe the priority is to save somebody's life and they can't move in the ICU. Or
I do think that what is unavoidable today may be avoidable tomorrow. And I didn't see the roster of questions, but when I think about what our support surfaces were like years ago compared to what they are like today and what they might be like tomorrow, perhaps even those unmovable patients will have intact skin.
That's right.
So I don't want to throw the towel in, but that's where we are at today.
Yeah.
Isn't it a little kind of like, somebody with the gangrene? Do you cut off the limb to save the body, or?
Well,
Yeah,
sometimes
I don't want to
we
be
can't
morbid.
throw the body
No,
away,
you don't.
the
Yeah,
limb alive,
yeah.
Bob.
But that's kind of my point.
Okay.
So why don't we now turn this around and say which are the conditions whereby they are avoidable? When are they avoidable? Shall we start with you first?
when individuals can be repositioned, offloaded, but they're not taking the pressure off. I think when there's for example, they're not getting enough nutrition, but they could. I think all of the correctable risk factors, I think that would be unavoidable.
Okay. Thank you, Caleb.
Yeah, it's, I think as you guys go through your Braden tools or your pressure injury risk assessment tools, we've spoken so much about that today. And when you're identifying that a client is at risk in an area and you can implement a strategy there, I think that's when they're preventable. From a nutrition perspective, this is like an area that I'm very passionate about, but I think, if we have a client who screens positive on, a nutrition screening tool, okay, risk, that's going to be increase your risk of pressure injuries. Now, what are you doing about it? Are you implementing a nutrition care plan? Are you referring to the dietitian? Because if you're doing nothing and they get a pressure injury, well, that was preventable.
Okay.
Yeah.
Thank you.
Oh, but Caleb, let me tell you that we have the dietitian recommend supplemental feeding in cans or bottles that I have a picture of it somewhere. The family made a mountain.
Did it go home with them?
Out of them. No, she was in isolation, so they couldn't leave. No, made a mountain out of these things. And so when we tried to talk to the family about her pressure injuries developing from malnutrition, the daughter pointed out the mountain of Ensure. It was like we just lost the fight.
Well, but no, but that it's, you know, yeah, it's there. They had access to, she had access potentially to
But
it.
you didn't feed it to her.
Exactly.
The nutritionist didn't feed it to her.
What? She can't open it. She didn't like it. She didn't know what it was. Like, we don't know what the barrier was.
The point of
We actually
contention
do.
here.
Maybe you do.
We actually do know what the barrier was.
So maybe hold your thoughts because I know that you guys are bursting with questions and comments. Okay, so hold them because we'll get to you. Mr. Black.
Avoidable pressure injury, I think I can give you the clearest example, is the case of a hip fracture patient who cannot move the fractured hip. So they're not yet in surgery, and that leg is spasming and spasming, and they can't be turned to the side because they scream in pain, and the wound develops. The heel can be offloaded. They can be placed on a better bed in anticipation of arrival, because the ER calls and says, we're sending you a fractured hip, but they don't have cardiac clearance for surgery. So we're just supposed to watch them ulcerate. That problem, when I started as a staff nurse, and I won't tell you when, we knew better how to deal with it then than now. That's, to me, that's sad, because it ends up often leading to a gangrenous leg that we have to amputate. And it's sad. It's sad. That one is one of the most avoidable that I see.
Great example. Thank you. Bob.
Say, this is from experience, but going in, say, if, you know, like for example, going in an ambulance, like I got to get off that gurney kind of thing that they leave you, you know, parked for, or normally if I don't put up a fight, you know, you leave you on a gurney for a couple of hours, and you know, on a quad you're not moving, so we're moving around. Get you know, on the bed, like ideally an air mattress bed, minimum, you know, because it's going to happen. There was a guy in the news in Canada last year. He went into, I think I may have mentioned it. He went into on a gurney. They put him on an ICU, not ICU, but on just an ER. You know, and he's a quad, so he's not moving around, and left him flat there. He developed a pressure sore, turned into somehow cancer. Didn't quite follow that, but it was a result of the thing, and he chose MAID out of it. So it turned into 4-stage cancer.
So what I'm hearing is that with the inappropriate use of equipment,
emergency, no.
Yeah. So basically, it could have been avoided by using the right support surface that is actually available in our system, right? So,
Have you guys got good ER carts?
No.
We don't. Ours are terrible. I mean, I was going to have my ambulance bring me up here if you had better ER carts up here. We haven't got them in the States. I can tell you that. They're terrible. They're awful.
I know.
Yeah.
Okay, now we've heard from all four panelists on the thoughts about which ones are avoidable, which ones are unavoidable. Now, do you guys agree with their comments? Would anyone like to start?
You're not going to throw anything else, right?
No.
I can find something.
I think it just depends, and that seems to be the big answer to a lot, where some things can be avoidable, some things can't. Goals of care. What does the patient, the resident, the client want? What do they need? So it's fine for us to come in and go, we know how to fix this. And they're like, go away. Well, what do? We can't hogtie them. We can't force them. At least we can't tell them we're doing that. But
so
it depends.
I think that you kind of looked at my sheet before. So let me ask this question to all of you. So how do we determine when it's actually avoidable or unavoidable? Let's say you have a pressure injury in front of you in your unit. Okay, now you're trying to determine whether it's avoidable or unavoidable. How do we go about that? You kind of touch on that, right?
I think one of the first things you have to think about, Chester, I'm down here. I'm not standing up. But it's like when we're doing treatments, if we aim for sterile, we're going to end up with clean, right? No, when we watch anybody do dressings, nobody's doing great sterile dressing changes, right? But we at least aim for sterile, because if we aim for clean, we're going to get dirty. So to me, if we aim,
Are there any surgeons
Yeah.
here that they wouldn't take that statement?
I know. But if we aim for preventable, then we're at least, because I find too often people say, well, it's not preventable. And then they stop trying.
Yeah.
Well, we can minimize, like, what can we modify and what can we not? And okay, maybe it's maybe it's unavoidable, but does it have to turn into a massive one, or can we at least minimize it?
Yeah.
So, you have to look at the whole picture, and you have to look to see, what can I change? No one's going to drink Boost and like it. I'm sorry. It's gross. I've tried it. But what else can we do? Can we get protein powder or other things?
Okay, thank you. There's a question back there.
I'm gonna go here to walk all the way back there. There's my steps for the day, by the way.
I think we need to look also at how are we sharing information? It's fine and dandy to tell a patient, I need you out of that chair for most of the day. I need you in your bed 3 times, or in the chair only 3 times a day for an hour at a time. If we're not explaining the why, if we're not explaining how it's going to impact, again with smoking, if we're not explaining why we're asking to reduce smoking, they can't make an informed decision. If they're not making an informed decision, we're ending up with the wounds.
Thank you. I love this concept, right? This essential concept of co-decision making with our clients and patients. Okay. Now, I know we only have like
Dr. Ho, by the way, I just want to say that we started off with about 4.6-ish or 4.4. Now we're down by 20%.
Oh, wow. Okay. Okay.
Can I just give a moment to have somebody make a comment here?
Okay, sure.
I think that looking at the whole picture, compliance, education, their diet, their weight, I think that it's important to look at the entire picture and not just that person, but that who their support is as well is huge.
Thank you for that great point. So I do have a couple other questions for you all to ponder about. So now let's say your client has a pressure injury and you all agree that's avoidable. How do you disclose that to the patient and the family?
Honestly.
Okay, who would like to start?
Straight up.
Well, okay, I'll take it here. Okay, so going back to my heel ulcer story, we have everybody in elastic stockings, regardless of whether they fit or not. We have them all in elastic stockings and they never come off the whole hospital stay. My students tell me the reason they don't take the elastic stockings off is they can't get them back on. So they just don't take them off and they can assess the heel through the stocking. You need to hire these people. There's nobody as good as they are. So I know. So here's my excuse. We don't tell them they developed a heel ulcer because we don't know it. They go to long-term care and for the first time in 3 weeks, they have their elastic stocking taken off and skin cells are flying through the room like confetti. And they find the necrotic heel and they go, wow. And the patient says, well, I haven't had my socks off in 3 weeks. That's how we get by with it. That's terrible, but it happens all the time.
Yeah.
So I have to apologize to long-term care because we do it all the time.
Yeah. So when that happens, how do we disclose it to our clients and their families? Because it happens, right? And how do you do that? How have you been advised to do so? Yeah, just 1 second, because I know you have a great point there. So let's just hold that thought until you got the mic.
In long-term care, I think the biggest thing is having those interdisciplinary care conferences with the family present and having those conversations right off like 6 weeks after admission and breaking it down.
Yeah, so being honest about it and bring the team and the families together. Okay.
Dr. Chester, actually, I want to ask a question just to rewind before that even happens. How can we engage the family member if we know and we've done a risk assessment and the patient's already at high risk of developing a pressure injury? How can we engage the family member in the process before it even happens?
Great question. So what are your thoughts? Anyone? Feedback? Anyone? Do you want to make?
I'm going to tell a story. Can I tell a story?
Quick one.
So, okay, sorry. So I think that family members need to know right from the beginning, as soon as a patient is deemed at risk of developing a pressure injury, their families need to be told immediately. And there was a very unfortunate case here in Ontario that happened several years ago. Linda Moss's dad, it's not a secret. It actually made the news where the family members were by their dad's side, like for 24 hours a day, almost like all the time. And they didn't even know their father had a pressure injury until he was transferred over to another hospital and they took the dressing off. And they said, had we known, we would have done something. And I think that those family members need to be told and the individuals need to be told as soon as they're deemed at risk. Like, then take that information and they can and they can make an informed choice of how they're going to proceed. So I'm very passionate about that, as you can tell.
Thank you. I also see some comments online, and I think they're very much in agreement with what's been said here. So thank you. Okay.
Sharon, I wanted to just build on that. So it's okay. It's also circling back to the accountability. So I recently had a case as well and had a female patient. She had a pressure injury, a HAPI, and was being transferred to rehab outside of our organization. Son was furious. And just having that conversation of accountability. We are sorry. This happened under our care, but this is the plan. The physician was there. I was there as a subject matter expert. And I watched him come down like this from a very angry son. We de-escalated by owning that and taking on some accountability. So transparency.
Yeah.
Don't you think that starts though by letting the patient know they're at risk?
For sure.
Instead of just all of a sudden, oh, I signed up and I knew there was a risk of bleeding and infection and whatnot, but you never told me, like the face guy, you never told me I'd get a pressure injury. So if they're told they're at risk, then it's education. If after the fact you start with this long diatribe, then it's an excuse and it just doesn't play as well.
I would agree. And this patient didn't want to get out of bed. So the plan going forward was now the son had to take some ownership, that you can't just come in and have a visit with a Tim Hortons. You've got to say, hey, mom, were you up today? Like, you need to get moving, right? So having that conversation and having family engagement is important. Ownership there as well.
Can I ask them a question?
No, you have the last question.
Are your hospital administrators okay with you telling the patient they got this pressure injury during this hospital stay?
I don't think they know. I don't know.
How about a raise of hands? A raise of hands if that's okay for you to disclose that to the patient that they've got it there. Raise of hands.
Wow.
I'll say as a hospital administrator myself, I say that is the way to do it.
Wow.
Yeah.
There are a lot of hospital administrators in the US that do not want the patient to know so that maybe they won't figure it out. And it's like, are you kidding? They're going to figure it out when their pants stuck to their butt because of the bleeding. What are you trying to do? I'm glad you have a group of administrators then that are responsive. That's wonderful.
Okay, I know that this can go on for another 2 hours, but we have to draw this to a close.
And we get a pressure ulcer.
No, but before we finish, let's look at the score now. Can you score again if you change your mind as to whether you think that this is pressure injuries are avoidable or unavoidable? We have, Josh, we had 4 point something before, right?
And we're still sitting down about 3.6. So you're looking at potentially around 60 something to 70%.
Okay.
Avoidable.
So some of you shifted your mind a little bit through this conversation.
Oh, shifting down.
Oh my gosh, further. Okay. Anyway, thank you so much to all the panelists.
Just a comment before you finish.
Go ahead.
Yeah, no, that's what, again, I just want to mention there's two kind of environments, institutional and the community.
Yeah.
And this has been pretty pro-institutional. We haven't really mentions.
That's very true.
Yeah.
Very true.
That's my point.
Yeah. Hey, thank you.
There are.
There are, but it's getting them to the right people at the right time.
Yeah. Yeah.
Okay, let's give a round of applause to our panelists.
All right. Thank you so much, panel members, Mr. Bob Brown, Dr. Joyce Black, Kalen Below, and of course, Dr. Sharon Gavison, and moderated by Dr. Chester Ho. Thank you.
Thanks.
Thank you. Okay, everybody. And so thanks for joining us all the way up to this moment in the afternoon. It's been such a very, very, very long day, but I think it's very fulfilling for everybody to see. And I'm still happy, actually, when I look at the chat, the number of people that are still there, it seems like it didn't decrease at all. Like there's just so much passion and commitment for people to really listen to all the programs and topics that we have had this afternoon. So on behalf of CPIAP, we would like to thank each and every one of you for coming in here, both in person and online, for joining us in our second summit. We are so thankful that you are here today to learn with us and those that are their speakers as well. We just want to also thank our speakers for the entire program for coming in here. Some of them are coming from different parts of Canada. Some of them are coming from the US. So a heartfelt thanks for each and every of you for imparting us with the knowledge and insights that we can take home with us back into our settings. Now, before we end, Sharon's going to let us know who is the most impactful e-poster that we had today.
Even read it? I can't even read it. I'm over 50 years old.
Age is just a number, by the way.
Oh boy, can you see it out there? Can you read it out?
Do you want me to say? Pressure injury prevention at home, detecting patient positioning with ankle sensors.
Wow, that's the.
Congratulations. I didn't vote.
Yeah, I think that's the Roja. Yeah, so
That's
congratulations to the ankle person.
She's right over there. Naroja, do you want to just stand up? And
Congratulations, Roja. Round of applause.
From Toronto.
All the way from Toronto.
Congratulations.
I'm gonna walk there. Take this to you. And Sharon, do you want to let our audience know about what's going to happen next year as we bring this summit to the next level?
Okay, so next year, dun, 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 drum roll. Boop, boop, boop. So next year we are going to be having our pressure injury symposium. Next year on more details to follow, but wait until we.
But it's going to be on November 20th and 21st. So I think that's a Friday and a Saturday. It's going to be a 2-day academic education event focused on four of the strategic priorities. And we're going to be having a lot of topics presented, a lot of abstracts, both partnership with industry as well. So we are hoping that you guys can make it out for that time. We will let you know more as we get close to the event, but the planning committee is going to be built. And we have actually a planning committee that's being spearheaded by our directors. This will be in
2026.
So it's going to be Kirsty Stewart as well as Chantel Led Barnes that's going to be leading this process for us. And we're going to help out as a board in terms of planning this. So hopefully we guys can see you in 2026, November 20th and 21st.
And we also want to take this opportunity to thank our exhibitors and our partners. They're listed here on the screen, and also Woundpedia and NSWAC. So thank you. And don't forget, if you have not become a CPIAP member yet, please don't leave until you scan and join.
And also, please, we want to make sure that all events like this that we have put up together is going to be better and even better every single time. So we value every opportunity that you give us. Let us know how it worked out, how we can make it better for the future. Please keep us posted. And even any questions that we may have not answered for you, please let us know as well so we can get the right individuals to give you those answers. And I also want to take a moment to thank a couple of people here that has been part of the planning committee. I want to thank the CPIAP board panel members who have been involved in the planning of this event, and a heartful thanks to both Kathy, Harley, as well as Troy and Jonathan, who has been working tirelessly behind the scenes for making this event possible for us. I don't think these people really sleep, but they're moving around so they don't develop pressure injuries. So I want to thank each and every one of you guys for supporting CPIAP for making such events possible. Thank you.
I'd also like to thank the AV people too.
And
Thank
the
you.
AV people, thank you for that. And of course, Carleton University, thank you for allowing us to use your space for this important summit. And also the recording of today's session will be available on demand by the end of next week at www.cpip.com/summit. And also thanks to John Gregory, who's going to be providing us the meeting proceedings of this panel, CPIP second summit as well. Thank you.
Thank you.
Have a great evening, guys, and stay safe.
Travels.
Safe travels to everybody. Good night.